Check. Okay, all right. Here we go. Good morning, everybody. It's great to be here. Welcome to the second day of the World Health Summit. We have the first session. We're going to get started with transformational strategies enhancing access to surgical care. I want to really thank those of you who are here, certainly our panelists who have made the effort to come in and share, traveling as far as Rwanda, Vietnam, and some other places as well here from within India. And also want to thank those of you who have joined the audience. I know some of you are recent postgraduates coming back from the UK, and some of you are students of this wonderful NIMS University who serves as a host. So I want to begin by asking you to raise your hand if you've ever had surgery. And how about someone in your family? So look around. If that's the case, then you are among the lucky ones who've actually had access to surgical care, either you or a loved one. That's not true for the vast majority of the people in the world, but today we're not going to talk about the enormity of the task itself only. We're going to ask our panelists to help us talk about the actions that they're already undertaking to make sure that people around the world have access to safe surgical, obstetrics, trauma, and anesthesia care. So today we have a short video to begin this session, and I would love for you to think of, is this a trailer of a documentary that's going to come later this year? And anyway, before that, I want to introduce you to Alfred. Alfred is a gentleman from Madagascar. And when those of us who work for Operation Smile see someone like Alfred, we rejoice in seeing the transformation that surgical care can offer to someone like him, but it also makes us wonder what his life could have been like had we had the chance to take care of him when he was 3 months old, which is about the time where this 45-minute procedure could have given him another chance at integration to society, education, jobs, et cetera, et cetera. So the work of surgical systems goes beyond the technical aspects of putting together something that offers an umbrella of protection and care and opportunity to people. It goes into the core of humanity and our commitment as professionals and as health workers to deliver on the promise of health for everybody. For those of us at Operation Smile, it's been a privilege for more than 40 years to serve patients and people such as Alfred, but we've understood that the same systems that support patients like him also can deliver on the many, many needs of surgical care around the world, obstetrics, trauma, cancers, keep going. Over a third of the burden of surgical disease could be addressed if we focus on surgical systems. So today we'll ask our panelists to highlight some of the work they're already undertaking to overcome some of the challenges and to bring about that promise. We'll begin by sharing a short clip. It's a trailer of a documentary that will be aired later on this year, but it gives you a sense of the needs of people and the workers that are making it possible for people to get care. Hopefully it'll make you think about what role we can continue to play to support these efforts around the world. And whereas this short documentary trailer is based in Kigali and other parts of Rwanda, please think about what this is like in your own countries, in your own systems, in your own communities, and let's see if we can leave our mark. So let's please go.
Oh, this is bad.
nuko aka kaguru tugakatira munsi y'ivi.
Plastic surgery here is a function. It saves lives.
A lot of patients were there, but hospitals were not having doctors.
So I just said, why not me?
When I went to the hospital in the first days, I was really scared.
What's the issue? Is the patient okay?
Honestly, I did not want to be a plastic surgeon in the beginning. These are long days. You always expect that they are going to be long.
Today you can do 10 patients, tomorrow you see 20. That's where the debate is here today. What will happen if we don't do?
Just kind of safety here.
You can do almost everything. You can cut here, move this, move that. It's magic.
It gives you a sense of purpose. Craniofacial surgery deals with deformities of the head. But so far, we don't have any craniofacial surgeon in the region. Toronto is in the top in training of craniofacial surgery. But for now, I'm going alone. I had a feeling like I was leaving them behind.
We pretend to be rocks, but sometimes you crack. Unfortunately, we lost the kid.
Am I really going to make it?
How many women are you seeing in surgery?
An empty house welcomes you. You cannot share how good or bad the day was. Is this worth it?
Gatura dusabe twakuvurire sibyo noneho ko tujya kwiga
Mfite uniforme.
Mfite na uniforme good ni sawa cyane
Sawa rero ngaho.
I feel the sense of hope for the future because we are resilient people.
Today is a tie day. It's all about mindset. That's what makes you a surgeon.
Because if you're not passionate about it, you'll not do it, trust me.
It gives you some food for thought, right? For us as well as at Operation Smile, we're really privileged over the years to have had the chance to work with amazing partners. And today, our panelists represent a cross-section of those incredible partners. The World Federation Societies of Anesthesia, a tireless advocate for surgery, for anesthesia, safe surgery and anesthesia around the world. Our G4 Alliance, the Surgical Obstetrics Trauma and Anesthesia Alliance, advocating for surgical care. The University of Global Health Equity, one of the leaders in education and at the forefront of thought leadership as it relates to surgical care, and many other global health areas. Incision, the International Student Surgical Network, young leaders really believing in the future. And last but not least, incredible leadership by the Vietnamese Ministry of Health, with whom we've had the privilege of working for more than a decade, Advanced Surgical Systems. It's really a pleasure. So I'm going to introduce our esteemed speakers with the most genuine of gratitude for your time with us today. So I'll begin with my friend, Mr. Abhishek Sengupta, whose almost 20-year experience across Asia has given him an opportunity to serve in advancing surgical systems. Having graduated with distinction from the London School of Economics, he came back to the region and has continued work that impacts countries such as India, Nepal, Pakistan, Cambodia, the Philippines, and many others. He's the current Associate Vice President for Asia and Executive Director of Operation Smile in India. Mr. Abhishek Sengupta is going to be our moderator for today. So you'll be done with me. He'll take the please, Abhishek, join us. I'd like to welcome Dr. Saloni Mitra, who's a medical doctor and health advocate. She's the current co-chair of Incision Ukraine, previously serving as Vice President of National Working Groups of Incision Global. Saloni has this breadth of personal experiences in addition to her commitment to global surgery, having trained in a country that's also suffering from conflict. and having had to move to other countries and to another country to finish her medical degree. She's been a fellow of the Global Surgical and Anesthesia Alliance and is joining us today. Dr. Mitra, please welcome. Dr. Bonan Zhang is a prominent figure in the Vietnam's Ministry of Health Department, serving as Deputy Director of the Department of Medical Service Administration. He has postgraduate work in business administration and hospital management, having spent some time in Germany, having returned. And I've had the privilege of knowing Dr. Song for over a decade now, and seeing his brilliant work as an advocate and leader at the Vietnamese Ministry of Health in many different areas, but certainly in surgical systems. Dr. Zhang, please welcome. So yesterday, we had the opportunity to welcome Dr. Namita Sharma, and she's probably one of the few who has the opportunity to take on 2 different panels in this World Health Summit. Dr. Namita Sharma, as we saw, those of us who had the opportunity to be with the World Federation of Society of Anesthesia, is a very passionate advocate for safety of patients. So endless, over 2 decades of experience, and a member of the Indian Society of Anesthesia, currently the head of a 300-bed subspecialty hospital anesthesia service. Dr. Sharma, as a graduate of the Advanced Management Program for Healthcare and the Indian School of Business, she does a lot of data analysis to improve operating efficiency. And yes, with data, we can make some significant changes. Dr. Sharma, please welcome us. I'd like to welcome my friend, Dr. Navajit Roy. He's the Professor and Associate Chair of the Center for Leadership in the University of Global Health Equity in Kigali, Rwanda. Dr. Roy is well known, not only here in India, but around the world for his work in surgical systems. Yesterday, it was funny to walk around the hallways with him, having him pull in 20 directions. It's almost like you're walking with a local celebrity. But in all honesty, he has seen it and done it. So he doesn't just talk about the importance of surgical systems, he walks the walk. He has spent time not only as an advisor for public health here in India, but also had important positions of leadership all the way to the World Health Organization. And he's a Lancet Commissioner for Global Surgery, and an tireless advocate and leader of global surgical systems. Dr. Navajit Roy, welcome. And Dr. Shirupa Das, a healthcare industry leader with more than 2 decades of experience. Her expertise ranges across medical affairs, thought leadership, clinical research, regulatory affairs. You keep going. It's a very broad portfolio. She has served and had leadership roles at Johnson & Johnson India as a country medical director, APAC lead for global scientific affairs, and the head of corporate social responsibility. She was a country medical director in India and South Asia of Abbott. So we can keep going, but you can see that we have individuals that bring a lot to the surgical system and experience in research, education, professional societies, and also valuable contributions from the private sector. Dr. Das, please join us as well. And at this point, I'll ask my dear friend, Dr. Abhishek Msengupta, to get us started. And thank you once again to all of you in the audience. Let's have just a discussion. I was saying, let's imagine that we're in the living room of our house talking about something we really care about. We're thrilled and grateful that you're here with us. Good morning.
Thank you, Ruben. A very good morning to everyone. It's actually a privilege to be sitting here with all these amazing people and also scholars. So again, like Ruben said, I think what we are going to do is we are going to, I don't think we have any presentations, so I think we are just going to chat and discuss and try and brainstorm, because I think this is a very, very important issue that the world is facing, and it's actually a crisis. And I think it's only together, and on this panel we have people from the government, we have policymakers, we have people who have actually worked with health systems, we have people from the industry, we have young leaders, and we also have clinicians, you know. So I think we try to balance, have a very balanced panel, because these are all the stakeholders that is needed for us to be able to deliver safe surgical care and influence surgical systems. So I think we'll get started with Dr. Roy. So Dr. Roy, you have been someone who has been on the field as well as you've worked at a policy level. So you know, over your career, you've pretty much seen it all. So why don't you get us started with, you know, talking about surgical systems across the world, with especially we saw this film about Rwanda. Maybe we can start with Rwanda and then we can talk about other countries in Africa as well as in India and Asia.
Thank you, Abhishek. I think the movie, I think this short clip was amazing because it just transported us from Bharat Mandapam to my daily life in Rwanda, actually. And that's exactly how I spend my days. And you look at this, you saw the child with that huge tumor, and you are like, the first thing that you tell the patient is like, what were you doing till now? And you know, when we are trained in the medical colleges, the first response is like, what were you doing? And what I've learned in my 33 years of community, as a community surgeon, is that the size of the tumor is directly proportional to poverty. If you see a bigger tumor, you can see that the patient is more poor. So for the health financing guys, I'll tell you, we have to make that statement because as medical doctors, we are shocked. I mean, your eye, I'm going to gouge out your eye. What happens with most of these things is by the time they come to you, you are doing futile surgeries like, you know, it's too bad. I'm going to take your leg off. That's my work. I'm just taking legs off, hands off, eyes out. And it's pretty meaningless surgery. Though most people look at rural doctors, you spent your entire life in a rural place, you're a hero. You don't feel like a hero at all. You feel very, very small because at the end of the day, you're going to go back to sleep with, I couldn't do anything for this patient. I just took the leg off. I took that eye out. I took this. And you are like, I spent a very tiring day, but what was the point? You know, sometimes you feel like that. And yet we know that we have to get past that system to be able to evolve. And I think when we look at what is happening around the world, you look at only the cross-sectional view. You say, what is going on? I mean, there's so much of high infection rate. There is this, there is that. Doctors don't want to work in rural areas. But it's not that the US got there today or the NHS got there today. It's been a process of evolution of health systems. And one of the things that I think I am really concerned about is calling it surgical systems. The moment you say it's a surgical system, you know, you think it's this nice ecosystem where you put a patient into the surgical system and out comes a cured patient. Usually that's not the way it works. Surgery has to understand that surgery is a part of the health system. You are just one more person, one more peg in that thing. But you know how surgeons are. We believe that we are the center of the world, we are the sun, and all the planets revolve around us. And that's how we start. We have this exalted opinion about ourselves. But actually, you are as important as the virologist, you are as important as the nurse, as important as the technician. I think, and that has been a barrier to over-glorifying the surgical part of it and not looking after everything else that needs to be done, especially in community health, where the public health person, the surveillance officer is definitely polio and everything else got taken care of by these people. So these are where I would place it. The second important thing was like, I think that really moved me, you know, that, oh, we are rocks, but, you know, the person said we are rocks, but still we crack. And that's the hidden part. That's the hidden part which nobody talks about. That at the end of the day, when you're sleeping with blood on your hands, you crack. And burnout is the hardest thing because when you're a surgeon I've been a surgeon for about 5 million people. You're never going to finish. Your list is never going to end. Because you finish and the next day they come more and more and more and more. And what happens eventually is that you burn out. I think we all of us have a role to play because I think all you need to do is support the frontline worker in whatever capacity you are. Even if you feel that we can't do anything for that child, what can we do for that child? Just to say, what happens? You've had a bad day, you come home and you speak to your dad or you speak to your wife and you say, or your husband, and say, I've had a bad day. And then you say, I've had a bad day. Oh, I tried my very best, but I lost that patient and I'm feeling very bad about it. And your day gets better. At least you sleep well. So the point with the frontline surgeons or frontline not surgeons, but the frontline surgical team is that there is nobody asking them about their day. They do not come to fancy conferences like this. They do not come to global surgery. You will not see anybody from that team in any of these conferences. So we've somehow managed to exclude the very people who serve the larger population from this conversation. So that's the thing. So support for the frontliners. Second is not calling surgery as a system by itself. And the last thing I would say is that it's all about, of course, quality and affordability. We have a lot of conversation around that. But in daily practice, that child who was telling that I have a uniform and I would go to school and I'm not able to wear my uniform because I've got all these burns and blisters on my legs. And his whole point was that when am I going to wear the uniform? Isn't it? It was, again, a very touching moment. Like, you can't even realize that I want to wear a uniform and I want to go to school. That's the biggest thing you want to do. I am not going to be able to help that child. Those contractures cannot be released, I can tell you. He is going to limp. But the very fact that I'm there and you've had that conversation, people want to feel that you're there with them. That's it. They don't expect you to be God, and they don't expect that you will take care of everything. And so that's the thing, that just being there, it's not about affordability. But if there is nobody there, then you feel totally abandoned, which is what happened in Gaza, that the hospitals were not functioning very well. But once there is no hospital, people just lose hope. And you're taking away people's hope. You're not taking away medical care from them. There was almost no medical care. But the very fact that hospitals have this unique role in the Geneva Convention, saying that you have to have hospitals standing, because it's like a church, it's like a temple, it's like I've got something which we call our own. So actually medicine is far beyond just the transaction of the treatments. So with those 3 points, I thought I would set the stage that we all have a role: surgical systems, patients first, and affordability. Thank you, Abhishek.
Thank you so much, Dr. Roy. I mean, very, very, very to the point, and I think some very important factors to consider. I think something that you said, I've written down, circled it, and I might actually use it on some slides and in the future and quote you. Size of the tumor is directly proportional to poverty. And that is, I mean, that's a great way of looking at it. And yeah, I think, thank you, Dr. Roy. We will come back to you with some questions later on. Moving on, we'll go to you, Dr. Sharma. So you are an anesthetist, anesthesiologist, and you're here representing WFSA. So can you give us some, lay out a picture, give us an overview of how safe anesthesia is being talked about, and how are we ensuring safe anesthesia is available? Because like you said, it's a surgical team. It's not just about the surgeon, and we can't do a surgery without an anesthesiologist. And I'll just add one thing is, in Operation Smile, and we were talking about that yesterday, but for the audience, in Operation Smile, we give a lot of value to the anesthesiologist. Sorry to all my surgeon friends here, but everywhere, all our regional medical officers and everyone are anesthesiologists, because we feel that they are the key upholders of safety and quality, mainly safety for all the kids we operate on. So can you give us an overview of India as well as Asia in terms of, how we are talking about it, and how can we make anesthesia safer for the population?
Thank you so much, Abhishek. Thank you, Ruben, for the very kind introduction. And Abhishek and also Dr. Roy, One beautiful thing that I think has made my day already is that we all at least accept and give this, that this is not a surgeon, it's a surgical team. And then coming on to Abhishek, that the anesthesiologist lies at the center, at the very foundation of safe anesthesia care. So we cannot be talking about universal surgical access till we talk about safe anesthesia delivery. So thank you so much, because I don't think that in practical ground reality, when we go off to the ground, that much importance or spotlight is being given to those people who ensure patient safety the most. So the more the anesthesiologist comes up to panels, the more the anesthesiologist reaches the stages of advocacy, I think our patients are going to get safer. So talking about how the situation is currently in India, I have been 20 years into anesthesia, and I can say I graduated from a government medical college in Gujarat, which was one of the largest hospitals in Asia. So we were the referral center for Western and Central India. So we had cases which would feature in the newspaper the next day, every other day, with arrows coming into the eye, going up into the occipital. So all sorts of cases coming up in emergencies late at night. From there, transforming and coming here, where I'm heading a private organization in, of course, the metro of this country, things have changed. If I had to talk about quality and safety of anesthesia, we have grown by leaps and bounds. Today, anesthesia is way more safer, not just by the terms of better equipment and infrastructure, but also because of better training, also because of the usage of more technology. For example, now we use ultrasound guidance for all our blocks. We were doing blind blocks at the time I was graduating. And today, I don't touch a patient if I don't have the ultrasound here in my Apex center, right? And that makes my precision so much better. So I know that I can use the minimal amount of drug and give the block in 5 minutes, and the patient will be ready for surgery, wherein back then in those days, we would take an hour to put the block and then an hour for the effect to ensue, and then fail, and then probably switch to general anesthesia. So one, equipment is getting better. Two, monitoring standards are now defined. So we know what we are monitoring. And third, simple things like the WHO surgical safety checklist, it just looks like a paper. But if you ask me, it's one of the most game-changing things that a patient file now contains, because before you're going to put, in fact, the patient under anesthesia, you're confirming all the very relevant points about the patient. So that one piece of paper, I think, is a game changer, right? Apart from that, many anesthesiologists are now being produced in our country. At least in my country, I can say that now we have 6,000 plus anesthesiologists passing out each year. So things are getting better. From what we were in 1990s, we are getting better in 2025. But of course, the gap is so big. It's definitely not getting filled anytime soon, right? But we're walking in the right direction. So that's another thing. So the numbers are increasing, but they are way too little. And again, the video was so moving. I still, can remember we had an observer who had come from an African country, and he was the only anesthetist to that hospital. He had come to learn and observe the regional anesthesia techniques that we do. And when we were listening to his stories, we were actually horrified. And how many anesthetists from here would actually want to go back there? And if Dr. Roy, the kind of work you're doing, I think it is it's divine intervention for that population. You may sleep with the fact that I couldn't do anything, but I feel it's divine intervention for that subset of population that you're serving. So safety definitely is going up. But again, the safety divide is also, the disparity is definitely very high. In urban areas, very safe. But as we go to remote areas, the poorest third are receiving the poorest care, and hence they're unsafe. And I also believe giving access to surgery is not enough. No. Giving access to safe surgery is the only point. If we have to give, please give them safe surgery or leave them alone.
Thank you, Dr. Sharma. I think that last sentence that you said, I think that really resonates, because it's not about just, okay, anesthesia is available. If you're doing it, do it right, and do it and make sure you're providing safe anesthesia. No, thank you for saying that, and I think that is something that Operation Smile really believes in. I'm going to come to you, Dr. Zhuang, because Dr. Sharma talked about the WHO safe surgery checklist. And in Vietnam, I mean, through the Ministry of Health, I think you have been able to implement safe surgical systems all over the country. Can you talk a little bit about, why the Ministry of Health in Vietnam decided to do it? And then also, how is it going? And have you actually seen a difference after implementing the systems?
Yeah, thank you very much, Abhishek. And good morning, everyone. I'm very happy to be here today to join the meeting on the transformational strategies enhancing access to surgical care organized by operations and some other partners. And that I would like very much with the topic because as myself, I have been joining for the healthcare system in Vietnam since the last 30 years. And I have 25 years working in the Ministry of Health level. And in my department, we are, the name of my department is Medical Service Administration. And we're responsible for the hospital management of the whole system in terms of the performance of the hospital and in terms of all of the health service organized and provided by the hospital. We must make sure that all the health service be running on the right way and also must be safe. And today, with the topic of the enhancing the accessing to the surgical care, and we say that is a very comprehensive topic, not only talking about the safe surgery and talking about accessing to the surgical care service. In Vietnam nowadays, we have some different strategies in order to make sure that all of our population must access to the healthcare service, including the surgical. For example, we must make sure that everyone, where you stay, it doesn't matter, not different but of the location or geography. We must be sure that they should access to the basic healthcare service, including the surgical service. And the second is we try to improve and trying to applying and all of the high technologies of healthcare and including the surgical. For example, nowadays we can do the organ transplantation surgery for 8 different organs and successful. And we also apply on the robotic surgery in some of the hospital. That we make sure that we trying to apply application of the high technology in our healthcare system. And whatever you do, whether basic surgery or high technology surgery, but if that is not safety, it will be the big difference. When we're trying to improve the service, we must go in parallel with the quality of the service. And talking about the quality of the service, I also experienced in my time of work for over 25 years in the Ministry of Health level. And we found that some days we have to receive, whether reported by the mass media, with the serious medical error. In our hospital system and also especially in the surgery, in operation theater. That is very sad. And we're thinking about what can we do? Very strict on applying the WHO safe surgery checklist in our whole healthcare system. But then whether that works effectively or not. Even the person, when they guide the hospital to do the checklist, they also did not understood very well what is going behind. For example, when you're talking about the risk of the complication from the administrations of the anesthesia surgery, or you're talking about how to make sure the loss of the airway during the anesthesia during operations, and how to prevent it, how to find it easier and earlier, and then we must going to find our partner. And luckily we find the Operation Smile at that moment. Because Operation Smile, every year they operate more than 2,500 cases of operation with the clip pallets. And they're successful. And we don't find the big serious or medical error reported by the Operation Smile. And then we try to work with Operation Smile, and how do they apply? What do they do with the time out when they make sure the patient before operations? And then we, with the support of the Operation Smile in Vietnam and Operation Smile headquarters in America, they provide us one big project in order to do assessing how is Vietnamese healthcare at that moment to of the quality management on the safe surgery, especially focusing on the safe anesthesia. And then we have the expertise team of the Operation Smile also going to Vietnam to assess and to work with us to develop the strategy as a quality standard for the safe surgery. And luckily, we, after almost 2 years, since 2015, 16, and then until 2018, we finally have the set up the safe surgery criteria on safe surgery. And since that, we introduced that once, and by Ministry of Health decisions to make sure every hospital, they must apply and they must do following that set of the standard. And also we have the supervision at the hospital level itself, and also at the management, whether provincial or at the Ministry of Health level, to do supervisions. Maybe every year we do 2 or 3 times in the hospital, and in the hospital they must to make sure that they have a manager to do supervisions day by day in the hospital. Then now we must say that become almost routine, like a routine activities in our hospital nowadays. Yeah. Once again, thanks Operation Smile with the support for Vietnam on these issues. Yeah.
Thank you so much, sir. And I think what Vietnam has been able to achieve, I mean, very few countries, I think, have been able to. And from Viet, I know that you personally are a huge champion of quality. So again, I mean, it is people like you who are making a difference. And thank you for your support to Operation Smile as well, sir. Next, I'll actually come to Dr. Mitra. See, I think one of the things that we really believe in Operation Smile is the power of the youth. We have a lot of young people who work with us, and a lot of young people who have stayed with the organization. Ruben is a great example. I am also a decent example. I'm also okay example. Ruben is a great example. But so, you know, tell us why at this point in your career, why have you selected this space to work of advancing safe surgery and working with surgical systems? And how do you think people like you know, the young people can actually be advocates towards ensuring safe and high quality surgical systems?
First of all, thank you so much for inviting me to this incredible panel. I'm among world leaders, and I feel privileged to be around you, to listen to what you guys say, to listen to your work. And I think that is really inspiring for young people, because we look up to you. We want to become like you. So for me, I had a pretty different experience, something other people might not have, because I'm born in an LMIC and I went for an educational training to another country, but like in a few years, that was the country which was the most talked about about conflict. And that made me start to wonder that what exactly is healthcare? Because we as med students, we just, cram up books, we just go to the hospitals and see patients, and that's it. But healthcare has so much more to it. When I was in Ukraine, I went to war camps, I've seen refugee camps, and while I was sitting there, I felt so privileged to have a house, to have access to healthcare, to have a family who can support me. And that is what I always felt, that I am a girl who wants to become a doctor. There is another girl in some part of the world who also wants to become a doctor, but is not able to. But why is the difference? Like, why am I different from that person? And this is how I entered to global health. That is why, for me, I'm passionate about global health and safe surgery. But if I speak about young people in general, we are the generation who have seen the global pandemic, who are facing conflict, like who are seeing conflict not only in the news, but also in environment. Through climate change, we're understanding the problem with our society currently. And, we don't want to just sit and complain. We want to go out and do something. We want to make our younger generation, the next generation, not face such things. But the only challenge we have as young people is we try to do a lot of advocacy, we try to do a lot of research, but there are, of course, resistance, because global surgery sometimes could be a very adult-defined space. As young people, we do not have much knowledge about advocacy, much knowledge about research. So I think, my work with Incision and me working with Incision and what we do as a youth organization is to improve access to advocacy training, to research training across the world. My role as the vice president in Incision allowed me to work with these people, work with 60 national working groups across 60 countries, and mentor them somehow to help them to identify the gaps of surgical discrepancies in their areas. And I think, which for me was really fulfilling. And when you see Incision, in only 10 years of time, Incision has done great work. We are a part of WHO Youth Council. We have a seat in the United Nations. We have a seat at the World Health Assembly. But if you ask me, is that why Incision is great? But because according to me, that is really good that we are able to present ourselves at high-level meetings. But it's the grassroots people. It's the people who are making a difference in their communities, in their hospitals, and that is what is making Incision great. So, your question, how do I think that young people should include? I mean, I think we could at least start. Doesn't matter where. It could be very small, but at least have the passion to start and do something for the society. And gradually, with time, of course, like Operation Smile has been supporting Incision and supporting youth organizations a lot. And somehow, youth are able to, fill these gaps, fill these spaces, and be there, be here, be in a forum like this. So I think this is how the youth can start, at least. But the major problem is to start. So that is what I would suggest to young people who want to work for surgical care and safe surgery.
No, thank you. And I think most importantly, I think what people like you bring is the passion and the enthusiasm, which is so much necessary. And I think, and I think someone like Dr. Roy will say that sometimes these things can become very boring, where you're doing research, looking at data, and it can be monotonous. So it's great to have people like you, and your entire team actually be advocates. And I really feel some of the biggest changes in the world, in world history, have been brought out by young people. So thank you for doing this, and thank you for your passion. Next, I'll come to Dr. Das. You are an industry leader. I think in round 2, there's a few other things that I want to ask you that came up from Dr. Sharma. But to start with, how do you think research and training can influence or can help us strengthen health systems and surgical systems? And what is the role that, let's say, the private sector or the industry can actually play in helping build more resilient and more more stronger systems?
Yeah, thanks, Abhishek, for the question, and thank you, Operation Smile, for enabling me to be part of this exemplary panel, and a bigger thank you for bringing this topic to the forefront of discussion, something that's so very critical to adoption of universal health coverage and yet is so neglected. So thanks for that. So coming to the role that research and education play. So I'll start with education. So I think it's a no-brainer. Everybody agrees that all professionals need training. We all need to be trained in order to be optimally delivering whatever it is, our specialized area is. It just applies a lot more to healthcare practitioners. It's a must-have, not just for surgeons, but for entire surgical teams, as Dr. Roy put it. So it extends to nurses, OR staff, technical staff, technicians, anesthesiologists, like ma'am said, to caregivers, who happen to be one of the pillars of the entire, healthcare system, caregivers, to the frontline healthcare workers. I think all of them. And the more critical piece here is not just train them to deliver optimal patient care and put patient safety always at the forefront, but also to be able to deliver in sometimes highly resource constrained settings. Because when we're talking about access, we're obviously speaking about underserved communities here who do not have the kind of access that maybe people living in urban settings have. So really helping them to operate and deliver in resource constrained settings, understanding the patients and the communities in those areas. So something that we may take for granted in a more sort of a urban setting, the ability of patients and their caregivers to comprehend certain things, something as basic as medication adherence, or reporting to the healthcare center, what we saw in that movie earlier, people, do they really report in time? And, the point also Dr. Roy made about the size of the tumor, I mean, that's something that we've also seen through as part of our medical training. The poorer sections of the society, they complain less and they come and, visit a facility, healthcare facility only when things have almost become incurable and almost reached a point of no return. So understanding those, those psychological aspects of patients and communities, ability to communicate effectively with these set of people, explaining the nuances, adherence, follow-ups, all of that, foster collaboration between the multiple stakeholders who build that system, not only within the center, but also with the frontline healthcare workers who are kind of interacting with these patients and communities on a daily basis. A few years back, FICCI, which is an industry association, a prominent industry association in India, undertook an exercise to put together recommendations on cancer care in India. And I was fortunate enough to be part of that exercise. And amongst a lot of recommendations that the paper put up, one of that was also the role that primary care can play in this whole ecosystem, the importance of screening. And in Johnson & Johnson, we actually partnered with the non-profit sector to train frontline healthcare workers to screen for breast cancer, for example, in high prevalence areas. Then in terms of training, the partnership that we've had with Operation Smile for training nurses. And, there's a lot of focus on surgeons, maybe the next focus on anesthesiologists, but do we, as a system, really focus on nurses and caregivers who play the major role? I mean, for the surgeon, it's a one-time intervention and he goes back. But the recovery is really dependent on the kind of caregiving, and which is where these set of people play a very critical role, and also screening and early diagnosis. Again, where the frontline health workers, the lab technicians. So when we're talking about education, I think it's educating, all segments who make up this, multiple stakeholders who make up this whole ecosystem, and of course. And it needs to be a collaborative exercise between the government, industry, and obviously the not-for-profit sector. I think it has to be a collaborative exercise where, and we leverage technology with, digital pathology these days, or telemedicine, or use of tech platforms to reach people in marginalized areas and train them effectively. I think that's something that's very, very critical. So this is about the education part. I'll touch upon a little bit on research as well, the significance of research. So one is, of course, we all know that it's important to adopt, the right care pathways. And care pathways, again, the ideal care pathway that is recommended may not always be applicable in some of these settings. So what is most suitable? So one is that adoption of those development and adoption of care pathways, which is evidence-based. And secondly, also build in a culture of research to measure the impact of the interventions that are being taken. And the introduction of new technology, for example, or new quality standards, and there's a lot that people want to do. The government wants to do, industry and the not-for-profit also want to do. But it's equally important to measure the impact. What is the actual impact on the ground that these measures are creating? And I think building that culture of continuous research, where you're looking at data and you're looking at what are the actual outcomes in terms of patient outcomes, clinical outcomes, safety outcomes, in terms of, say, cost savings, improving efficiencies. Because in these settings, it's not just important to have something that will produce the best clinical outcomes, but it also needs to be cost effective and efficient and easy to sort of implement. So these are some very critical parameters also that we need to keep in mind. And I think like in education, even in research, there is a huge opportunity for cross-sector collaboration. Look at large data sets, RWEs, patient registries. Democratization of clinical research, for example, is a huge topic. I mean, it's out of the scope of today's discussion, but that is essentially what it intends to do. That when we are doing research, are we really looking at and covering all sections of the population and making research more inclusive? So I think that plays a key role here as well. Thanks.
No, thank you, Dr. Das. And I think some very, very important points there. I think the first one being, you talked about nurses and the importance of training nurses, and that is something that me personally and even in Operation Smile, we really believe so strongly. And with Johnson & Johnson, we did a nurse leadership conference, and it's And what we did is it's not just about the clinical skills of nurses, it's also leadership skills, interpersonal skills of nurses, which we need to work on. So thank you for talking about that. And they are such an integral part of the health system, of the surgical system. Another very important point that you brought out is actually the collaborative model, or which sometimes we tend to call as PPPs, like public-private partnerships, and how all three sectors can come together. And yesterday I was in a panel and there was a lot of talk about convergence, and exactly, even in other sectors, not just surgery, but this was a panel on nutrition, and that's exactly what they were talking about. And I think together we are stronger. And last, you talked about research and democratization of research. I think that's so important, and also understanding when we are doing a program, understanding the outcomes, understanding the impact, and then changing the program accordingly if you need to. And that is where I'm going to come to you, Dr. Roy, actually, because this is something that we started talking about even yesterday. So let's look at it two ways, because I wanted to ask you two questions, but I don't know if I'll have time for two, so I'll combine those questions. So you also have some experience of working in Vietnam. What do you think is the reason for success in a country like Vietnam, and what are the lessons that other countries in Asia as well as other parts of the world can actually take from that experience? And the second is, how do you think, so again, something similar to what we are talking, we start a program thinking it's going to look a certain way, and sometimes it doesn't, but we still keep pushing and we still do the same thing expecting a different result. For years we'll keep doing the same thing and we think it will be a different result this time, which just can't happen. So again, it's actually two questions, but if you can comment on both of this, that'll be.
Thank you, Abhishek. Yeah, after having been an academic for most of my life, I moved on to the dark side and became part of the ministry, just like Dr. Zong. And my respect for ministries has gone up since. We think as doctors, we are concerned about patients, but actually the ministries are concerned about people as opposed to patients. And I think that what sets them apart. What Vietnam did, like a lot of the countries, and Vietnam is not a rich country, but what they have done is what WHO mandates is bringing care closer to the people. And the way the thinking of the ministry, and it's happening in India too, you start with the global burden of disease. You don't start with, I'm a hepatobiliary surgeon, so all of liver transplant is important. I am so-and-so. And so you don't start specialty specific. You say, what is out there? And there are so you took the global burden of disease and disease control priorities 3, came up with 44 essential surgeries. Out of that, 7 can be done at primary health centers, 29 can be done at district hospitals, and 7 can be done in tertiary hospitals. That's the division. So you clearly see that most of the hospital's work has to be done at the district hospital, which is the closest for the patients. Every time a patient has to transition from one level of care to the next level of care, poverty, catastrophic expenditure. They will sell their cows, they will sell their houses, they will sell, and they will move to the next level of care. So every time you actually bring a surgery from a higher level to a lower level, you are saving lots and lots of people from poverty. And we in surgery are the biggest creators of new poverty in the world. So if you were a landed laborer and you had 2 cows, after a surgery, you will be a landless laborer with no cows. That is the reality of the world today. And it's happening in the middle class. You don't even have to go and see. In the middle class, you will lose your life savings. You have to have 1 cardiac surgery, isn't it? So that's how it is. What Vietnam and a number of these countries, and again, credit to OpSmile, there are only 2 surgeries which moved from tertiary to district hospitals. One was cleft lip and second was cataract. You can go to a district hospital and get a cataract done. And it's a pretty high level, high-end surgery. And moment you shift it down, people say, oh, it's going to be unsafe. And that's what you all have done. You all have shown, Vietnam has shown that our sterilization practices in a district hospital is of the highest class. So that's one transformational strategy, since that's the topic of today, of enhancing surgical access. And surgical access and poverty are so deeply linked. It's not like any other things. You know, you have other NCDs, you have high blood pressure, you'll get tablets off the counter. But surgery is a one-time expense. So that's one thing. Second thing is that what most of these countries have done really well already came up in the conversation. It came up in Sirupa's thing, it came up in Dr. Zong's comments, is that we look in India, oh, there are no doctors in these places, there are only quacks. Why are the quacks there? If the doctors were there, quacks are not going to be there, right? If you have a big Reliance mall going to a village, all the fellows will disappear. All the rest of the smaller vendors will disappear, right? So let me take a page out of the maternal health movement. We keep calling, oh, surgical quacks, these are quacks, and they are practicing unsafe surgery. Maternal health movement 50 years ago took an illiterate woman who was the dai, who was a traditional birth attendant, and they gave them 3 technical interventions. First intervention, clean blade. Second intervention, clamp. Third intervention, tetanus toxoid. And the world went up in smoke. You're going to teach an illiterate woman to give an injection? And the gynecologists and the obstetricians of the world said, yes. Were you illiterate and did you become a doctor? Everybody can be trained. And I think that is what we are not doing in surgery. We are all about specialization and only the specialists are safe. But I work with bone setters and they will send you 2 cases as complications. They'll try and do a supracondylar elbow which will get messed up, and they will come to the tertiary hospital, the teaching hospital, and we'll say, these bone setters. But 98 cases he has done properly. You're not seeing there. You're sitting in a tertiary hospital with a hospital bias saying that, look, they are messing up cases. But you're not seeing. And if he started sending all 100 cases to you, you couldn't cope anyway. So you've got to make up your mind. You need the dais, you need the bone setters. They all need training. Instead of, and the dais were witch hunted until the MCH movement came and said, you are going to do more deliveries than me, OBGYN in San Francisco, who will ever do in my life. So I'm going to train you. That's not happening out with us. And that is what I think the models that most of these countries like Vietnam are showing, that we can do it at the district hospital, we're going to train all cadres, and we're going to make everybody more capable and safer than what they are. So these are the ways to move forward. We are aping the West too much. We're just aping the West and saying that we have to have 7-year residency programs, 10-year residency program. It's all right for replacement population, but Asia and Africa are, the populations are rising so quickly that you can't have that. So that's how it is. People told me that, what are you doing with a 3-year surgical residency? Harvard has got a 9-year surgical residency. I said, great. If I did a 9-year surgical residency, when I qualified, the average lifespan in India was like 57. I would graduate at 47, do 10 years of practice, and I would be dead. So it's not a very efficient system for us, isn't it? So, and anyway, what do you learn in a surgical residency? You just learn, when in doubt, cut it out, right? That's all you learn. Why should you take 7 years to learn that? I don't understand. Thanks, Abhishek.
Thank you, Dr. Roy. I mean, again, a very important aspect of why certain, in certain regions of the world, certain countries, certain regions within a country, we have a much weaker surgical system or a health system as well. And that's the resource scarcity that we have. And what you said is ways in which we can address that. And yes, in a lot of public health intervention, there is a lot happening, maternal and child health, there's a lot happening. I'm going to come to you, Dr. Sharma, and from an anesthesiologist point of view, because again, this does get very contextual, conflictual at times also. Because again, an anesthetist is responsible for the safety of the child, right? And so when you're looking at safety and what Dr. Roy said, I mean, I'm not even going to frame a question. I'm going to let you respond to that actually and see what you feel of that.
Yeah. So my response to what Dr. Roy was saying is actually pretty mixed. I am not saying that the model that worked for obstetrics with midwifery cannot be translated into surgical care. I'm not saying that. I'm saying, but for doing that, it begins either take the bottom-up approach or take the up-down approach, but you have to go systematic about it. First, starting from leadership. Leadership plans it, creates a roadmap to it. Then we create a framework that's not just clinically safe, the guidelines and the measurements and the metrics, and how do you really consider that someone now can be deemed fit to deliver anesthesia or surgery for that matter. So I'm not considering anesthesia in separation. I'm saying the same fundamentals will apply to surgeons as well. I'm saying it will apply to plastic surgeons as well. There is no shortcut for this. There is no key, oh, anesthesia training can be rendered in 2 years to this medical officer and then he can be fit for anesthesia, but he cannot be fit for surgery. No, it will be across sectors, right? Across branches, specialities, and it can be done, but through a very defined curriculum, a system that validates and then giving them a legal protection. That what they do, we support you and we will legally protect you in case there is a problem at you. So all of that, so certain parts of the world have done it. You know, registered nurse anesthetists. I was reading certain case studies from various countries. Things have been done. But again, this has to be a very systematic approach. Some pockets somewhere in this country are doing it. Oh, this looks okay because, 9 out of 10 patients survived, 1 died. It's okay, let's do this. I think each life matters. Each life counts. And so I was speaking to a young medico here in the crowd, and I was telling him that what you consider is a very simple surgery is lap cholecystectomy. You consider a very simple surgery. Just day before yesterday, I think I shifted one of my patients to the intensive care unit after lap cholecystectomy because healthcare is not exactly what you think. So every time someone says it's a simple appendicitis, I don't think anything is simple. You cannot declare things simple, and yet Operation Smile taught us how the very complex, cleft lip, cleft palate are one of the most complex airways for the anesthesiologist. And you brought it down to the district level, right? Something that we considered was keep the difficult airway cart ready whenever you have a difficult airway patient coming in. But you did it through a systematic approach. And before you bring in a child who has cleft lip, it is the moral obligation, I tell you, of the clinicians who touch that patient, that infrastructure is ready to cope up with a difficult airway and the mishaps that can come up. So yes, if we are ready from top till bottom to create a wonderful, and systematic approach to this, yes, then the Indian Society of Anesthesiology and probably the World Federation of Societies of Anesthesiologists at large would definitely want to partner. Why not? We're all for it, but in the right way.
No, that's a fantastic point, and I think, Dr. Roy, you spoke about traditional birth attendants, DAIMA training program, but it was done in a very structured manner. They were trained, then there were refresher courses, and then there were, and they had support. If they wanted to reach out, they could reach out to the sub-center, the A&Ms and all of that. So I think you're right. I mean, it is doable.
Let's incorporate them into the mainland. Let's incorporate them into the main system. Let's not make them a remote, they should be a part of the system.
Talking about them as
a distinct entity that we don't really, we close our eyes to their existence, but that's not happening. So, okay, let's give them the, entity that they are. Let's accept it.
Correct.
And
no, I think, that makes a lot of sense, and I think, that there should be more structure, there should be regulation, there should be licensing, there should be quality monitoring, but I think it is very much doable.
You will need the collaboration of world bodies like the WFSA, the ISA. These bodies will need to be a part of it so that continuous training, continuous upgradation, improvement, all of that can be brought about. All of that can be done, but collaboration is the heart of progress.
No, perfect. Thank you. Great discussion. And so moving on, I'm going to come to you, Dr. Chuang, about Vietnam. So, here we have people from the private sector. We have people like you from the government. We have global health specialists. So my question to you is, and Dr. Shirupa mentioned about the PPP model, private-public partnership. So as someone with the Ministry of Health, how would you want, let's say, civil society like Operation Smile or the private sector to support you in the ministry or the health system in Vietnam for you to be able to develop better protocols, because you've done the surgical safety checklist and all that, how can we do better, and how do these sectors come together to support you? Private and civil society. So like Operation Smile, what more can we do to help you strengthen your systems further, take it to the next level? Because now you have the quality indicators and the surgical safety checklist which you're implementing. What next, and how can we help?
Okay, thank you very much for the question. So first, I would like to add one point about the leadership, and then I will answer some more detail of what Operation Smile could and should support for Vietnam now and in the future. So first, I would like to add one more point about the leadership. I like very much when you mentioned about the leadership. And in order to make sure the safe surgery, the leadership must be mentioned at all levels, from WHO, from anesthesia, World Health Associations. And as Vietnam, as member of the WHO, and we all follow the resolution of the WHO in order to strengthen the surgery and anesthesia. And of course, we must base on the WHO sub-surgery checklist. Everything, we must follow it. And what we do is trying to bring the detail. And to understand and to easier to check and to support for the WHO guideline. And that is one thing. And the second is must make sure from the Ministry of Health level, we must develop, and we must have some kind of the compulsory in order to implement it in the real level. And also from the leadership as a hospital must make sure that they support for that topic and that activity, and they must make sure you have the person responsible to do supervision of it every day. That is one thing that I would like to add, very important of the leadership. And the second thing is nowadays in Vietnam, the private sector growing very fast. And Vietnam have a big policy in order to support for the public sector, especially in the health sector. We could counting nowadays the number of the private hospital is for 25% of the total number of the hospital in Vietnam. And the service, public or private, whether you are private or you're public, but the service you provide for the population must be the same. Must be make sure that is safety, and we have the equity on the policy to support for whether public or the private by the health insurance. You are public or you are private, you also have the patient with health insurance coming to you equally. We don't we don't have a difference yet whether you are public or you're private. That's one thing. And talking about the organization of Operation Smile, if you could support us, the first thing is focusing on safe surgery. We think that is good idea, because nowadays we still have changing of our healthcare system. Before we have 3 levels: central level, province level, and district level. And nowadays we don't have district level. We have all 2 levels. One is a very specialized hospital, and one is a basic hospital. And then that is one thing of the changes on the managing of the hospital. And that is one thing that Operation Smile could support us for guiding before 3 level into 2 level of the hospital performance. And also with the surgery safety, we also need to have stronger supervisions in the hospital, and maybe we need more supporting on the training program to train for the specialized in order to do the accreditation and supervision in all level of the hospital, public and the private. And besides, we also have the idea to develop more criteria of quality standard on different aspects of the hospital performance, like in the ICU. And I guess that's something we would like to have. Okay, thank you.
No, thank you. I mean, I'm gonna quickly come to you, Dr. Mitra, and I think we have 6 minutes, so maybe a quick response from you is, see, I think we are going to keep it a little futuristic. So as a young leader, what would your message be to people from the ministry, to world leaders, because you also represent us at in the UN and the WHO. So what is the one message that you would want to send out to the world leaders as well as policymakers in the countries?
Thank you so much for your question. So I just want to say that young people who are creating and who are doing so much change in their local communities don't even know that meeting like this exists. So my only question to all of you, all of the people from the ministries, from organization, is you always talk about making a better future. But my question is, with whom do you want to make this better future? You know, I urge you all to meaningfully engage young people. I mean, not just as tokens for pictures, but of course, if you click pictures, do tag us on social media, we appreciate that. But, you know, invite us as co-creators of policy, co-creators of the things which you are doing, because that is commendable. The amount of work you guys are doing is commendable, and we want to learn from you. We want to see and implement that in our future. But for that, the first thing is that you need to teach us how to do that. We will not be able to learn by ourselves. I mean, if I talk about Incision, we are very limited in how much we can do. Maybe research, maybe advocacy, but that's it. We want to expand, and we want to be there with you in the same room, talking about surgical care. So sorry for the time. But yes, we want you to utilize us. And the last thing which I want to add, that there should be nothing done for us without us. Thank you so much.
Well, thank you. Very quickly, Dr. Das, I think one of the things that I noted down when Dr. Sharma was talking about is that anesthesia care, quality of care, all of that is getting better. And some of the things she mentioned is actually, one was definitely education training, which all of us talked about. But one of the things she mentioned is new technology and new products that are coming. She talked about using USG for blocks, right? While all that is true, and I definitely agree, the point is how many people have access to this technology. And you know, technology, I feel, brings us together, but technology can also divide us. You know, if you have it, great. If you don't, if you can't access it, if you can't afford it, it's a problem. So again, looking at that, you know what I'm going to ask. But so from a private sector point of view, how can, I mean, you know the conversations going on in the industry. So is there a conversation going on that how do we make technology more accessible, more affordable, and more available in rural areas, you know, where the majority of the patients are, where delivering safe surgery is even more difficult. So again, like Dr. Sharma said, technology is there, it is available, making things safer. But from the industry point of view, you would agree to that. But how do we make it more accessible to the people?
Yeah, I think it's okay. I think you know, you've touched upon a very raw nerve, I would say. So yeah, so I think if you look at industry, any industry for that matter, whether it's to deal with drugs, whether it's the medtech sector, which deals with devices and other sort of diagnostic and technologies as well. I think what everybody would like is how to really make their products more accessible. It definitely is there on everyone's mind, but then there are, of course, other issues like pricing challenges and all of that, where there's a constant dialogue that goes in with the government, right, on how to resolve this. And industry, unfortunately, happens to be a for-profit sector. So, those are certain considerations, of course. But I think there definitely is an opportunity to look at innovative models through which these can be made more accessible. And there are a lot of, industry stakeholders today in different areas who are working on, patient support programs, along with the not-for-profit and along with other payers to make these more accessible. And when it comes to, technology, of course, there's so much happening in the tech space. If you especially see whether it's diagnostic or telemedicine, with the use of AI, and also the evolution, there is extremely rapid. So I'm sure, this is going to bring about change in future. And telemedicine, for example, is a wonderful tool, right? It makes access, so much easier. Even training people in those areas, or the use of AI for screening of certain cancers, or for a lot of conditions, making radiology services a lot more accessible, pathology a lot more accessible. So that's definitely there. And but yes, there's a lot more collaboration required between industry, between the government, and also between along with the not-for-profit everywhere. And I think Dr. Jong made that point that for governments, it's the people. That's a key lens to look at. For the rest of us, we look at patients, and when we talk about access, we look at patients. But for the government, it's the population that they serve, and I think those conversations are really helpful.
And another, just a quick comment on that let's not forget the power. Again, we have the youth leadership representation here, that I have personally seen a lot of startups come up. Locally grown kids from here, working on technology related to healthcare, making it actually way more affordable. And all they need is a little more support from the government in terms of aid, in terms of incubation areas where they can sit and actually devise certain things. One of those is at AIIMS, which I was talking about yesterday also in my conversation, that AIIMS and IIT have collaboratively made a cell in All India. And much work is actually going around there, but yes, that has to be harnessed and then developed. That can be the solution for providing cost-effective solutions, same technology, but locally made in India, and then used. So,
yeah. So I think what is important, and you've touched upon the right point, Dr. Sharma, and but before we sort of harness and leverage that, I think testing that technology out to make sure it's effective. That's the testing,
and then you have to
validate, and then.
No, thank you so much to every single one. It's been amazing. You have something?
I just wanted to add a point, like, follow up point to Dr. Sharma and Dr. Das, that, when you're doing that, please do invite us, because I think we're good at technology and with AI.
No, I think it's not them doing it. It is you guys who will do it, actually.
Yeah.
Affordable technology, which is accessible. I think that is something that's going to come from you. It is not going to come from others, so.
Exactly. Yeah.
Perfect. Thank you, everyone. I'll let Ruben close this.
So we're at time. Maybe if I can have one departing sentence from each participant. One sentence departing message.
I think surgical care has a lot to learn from other movements, global movements in the world.
The last I should say is safe surgery is very important, that every country should be and must be focusing on.
So there's a lot of focus on essential medicines. WHO has a list of essential medicines. Every country has a list of essential medicines. We have a national list of essential medicines in India, which is always a hot topic for the government and the industry. Similarly, we should have a list of priority surgeries, which are again made accessible to the last mile. That's something that we should all work towards.
I just want to add that, invite the youth. They might have the solutions to the problems, and they might have much better solution, which could actually be more efficient than what's happening around, like with surgical care specifically. Because if you see as Dr. Roy mentioned, if you see other movements, they have done wonderful work with social media. Mental health has done wonderful work with social media. Now everyone is talking about mental health. Like Incision wants to see surgery in a platform, in a way that everyone knows what global surgery is and how important it is right now at this time.
Thank you.
Collaboration is the only way forward.
Abhishek?
Oh, I didn't think of one word, but I think it's a collective responsibility for all of us to reach out to that last patient in that last village. I don't know how it will happen. I don't know who will do it. I don't think any one person sitting here or one sector can do it. We have to come together to do it. We have to do it.
I love those thoughts. I will add my own. As you can see from the wealth of expertise and the ability to collaborate, partnerships have the ability to deliver the opportunities for health systems to have the surgical anesthesia capacities that protect people's lives and livelihoods. I want to thank our panelists for this insightful session today. I want to thank all of you in the audience. I know time has been brief. If you have some questions, I would love it if you could grab some of the panelists and have a discussion on the side. Thank you for coming, joining us today, and for believing that we can make a difference in people's lives through safe surgery and anesthesia. Thank you very much.
Thank you. We don't have time, but we have a little something for all of you guys. Pleasure. Guys, we have a little.
We went out to your carry-on. That's a lot of stuff.
पूरी लेना ये सब भी आना चाहिए दिखाओ इधर से इधर से इधर से इधर से कुछ बोल दूँ क्या मैं सॉरी 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 बंद
In fact, we can start with you guys. Yeah. Yes. We have equal number of audience as panel. So we can all have a good conversation within us. You are in the right room, right? Because our names are here, so we have to make sure that we are in the right room. You come and all of you just come.
We'll give you one. Yes.
Is it working? Switch it on. Hello.
Yeah.
Is that working?
Yes, it's working. It is working.
No, the mine was. Just say hello.
So, I want to know.
No, take this.
I want to. Hello. It's working. I want to know how a government devises policy, how I, as a younger generation, can help by promote my ideas, my viewpoint to the more experienced people like you. So I want to be a part of this in the devising how to devise policies, so I can be part of, be meaningful part of the doctor community and do for the more for the population.
Good. What's your name?
Aditya.
Aditya. Good. You were not expecting that you will start the session. Just go on.
Hold it closer to the...
Just put it like this.
I didn't know too much. I am second year MBBS student, so...
Very good. Nor that we know much, trust us.
I want to
Let's start. Right.
Good morning, everyone. I'm Jasleen Kaur. I'm towards my completion of Masters of Public Health in Health Policy, Economics and Finance. And currently, I'm interning in a mental health, digital health organization who are using a VR technology to solve the mental health from the grassroots level itself. So it is like the amalgamation, combination of both the things that I'm learning and trying to do right now. So that's why I'm here in this panel.
Okay, wonderful. Any other voices?
Yeah.
Hello, everyone. I'm Tanushree Jain. I'm serving as the chairperson of public health at the International Pharmaceutical Students Federation, and I'm also the chair of the Health Literacy and Education Working Group at the WHO Youth Council. We at IPSF, the Federation of Pharmacy Students, has passed a resolution in our last World Congress in South Korea about digital health and how pharmacy students and pharmacists can play an essential role in access to healthcare through digital health. And that is why I was very interested in the panel, especially because I belong to the Southeast Asia region. So, thank you.
I will be with Catherine Bergen launching a digital initiative in Geneva on 19th.
Yeah, we'll be there with our delegation as well. It would be lovely to connect and with all of you actually and see how we can work together.
Hi everyone, my name is Dheeraj Kumar Gupta and I'm from World Resources Institute, a research-based organization. So basically, I just wanted to know, because the India healthcare sector is quite diverse, and when we'll see the tie from sub-centers to district hospitals and including the private and others public health facilities. Then how we are going to leverage this technology where the peoples are coming from the different background, diversity is there, and how we can make technology that is quite available for them, because even the at district level or the state level, the officers and others are not much empowered to take this technology forward for the healthcare system. So I'm just I just wanted to know from the patient perspective. Thank you.
Anyone of you have any thought?
Hi. I would just like to introduce myself. I am Nikita Sachandani. I work with Tata Trust. I'm a program associate there. And currently at the Trust, we have a lot of programs that are not exactly focused on healthcare technology, but technology is a cross-cutting theme across elderly care, geriatric care, palliative care, and mental health, and a lot of other programs that we have. But what I think is that technology can do a lot more, and I am trying to start more programs where we integrate technology with way more solutions for healthcare. So I'm here to hear a lot of perspectives from you guys to understand how we can take it forward. What are you doing in your individual capacities, and what has been your experience deploying this technology? Because just conceptualizing and deployment is very different, and a lot of things can go wrong, right? So I would like to learn from your experience. And Mr. Tandon, I also had a chance to speak with Mr. Gaurav yesterday, and his views on what Tata 1mg is doing in terms of leveraging technology was very, very helpful. So I would also like to hear your perspectives on it.
Great. Any other voice, or should we get started? Lovely. Okay. Since we are so I would call it an intimate conversation, because it's let's make it more interactive. If this room was, say, 70, 80, 100 people sitting here, then it would have made more sense for us to, just keep giving our kind of, our viewpoints, our opinion, and then ask somebody to ask questions in the end. But because it's like I said, a very close group, I started by saying we have as many number of audience as we have panelists, which is a very unique situation. I'm sure it'll be a very interesting conversation. So what I'm going to do is I'm going to change the format a little bit because of the way we're all sitting in this room. First of all, I would urge the panelists and each one of you to really think about the fundamental idea of what should be the policy that really unleashes the technology for health access in our part of the world. It could be anything, it could be a internet policy, it could be a data policy, it could be a technology policy, whatever. Just think about it in your head, and we will go and have that conversation as we go forward and with our conversation. Second thing is, I had initially thought that I will set the context and introduce the panel, but I'm not going to do that. What I will do is I will actually go around the panel first, and each one of us will introduce ourselves directly to you so that you get a little bit of a sense of who you are talking to and what kind of conversation we should have if you have any question. Third, one of the important things of technology is that it typically democratize access. Technology, they always say, is a level, right? If technology democratizes access, let's have this conversation more democratically. If one of our speakers speaking and you feel that there's some intervention you want to make or there's some question you have, please raise your hand. We will try and have the conversation right there, rather than, you keep listening to us and waiting till the end and saying, oh, now, you said about this and this is my question. Is that okay with all of us? Is that fine with us? Okay. So let me begin with myself. My name is Ishtiaq Amjad. I work for, many of you may not be aware, but we are actually the India's largest healthcare company. It's Abbott Healthcare in Abbott, India. We take a lot of pride in saying that we are in the entire continuum of care, healthcare, because we are in point-of-care diagnostics screening, we are in core labs, we are in molecular diagnostics, we are in CVD implants, it's a nutrition company, it's a pharmaceutical company. So everything that you can think of, there's some play of Abbott in that. So we're not really a typical specialized healthcare company, but we have a very, very varied portfolio. We've been here for over 110 years in India. So we actually came, India was one of the earliest offshore operations that Abbott started outside of the US. We also have the highest number of people outside of the US anywhere in the world in India. So we have about 13,000 people working for Abbott. I have been here for I'm completing 3 years in this role, so relatively new. I used to work for Coca-Cola before that. So please please pardon my ignorance about healthcare in case if I say something which is not to be said or if you don't understand. I'm very new to this field, but it's a great learning and it's been a great journey for me so far. So go to my right.
Hi, I'm Prashant Tandon. I'm the co-founder and CEO of Tata 1mg. 1mg is a digital healthcare platform. At the core of it, we started with content around healthcare and information around medicines. Today on the platform, we get around 250 million unique people every year, every month around 40 million or so, mostly coming to read content and access information. And then the second layer of the business is that anything that is needed in healthcare outside of the hospital, that's what we aspire to provide to the consumers. Now, what we are known for is, of course, medicines and diagnostics, but the whole host of ancillary services are also provided to the consumers. So what do we have? We have a front end for the users to engage with us. We have a supply chain to deliver the required healthcare services or products. That supply chain, in case of pharmacy and labs, is 100% our own end-to-end. In other services, it's a partnership with various players of the ecosystem. Doing all of this as a company today, our pharmacy supplies, we cover around 2,000 cities, some 20,000 pin codes. Diagnostics around 55 to 60 cities today. While digital is where we started, today we also have a physical and an institutional footprint. So 30% of our business is actually work we do with insurance companies, hospitals, corporates, pharmaceutical companies on their patient access initiatives, where we provide the healthcare services to the beneficiaries from these institutions. 70% of the business, of course, is direct to consumer. We've just started our brick and mortar footprint. So today we also have around 105 stores. We'll have a few thousand over the next few years. So net, anything outside the hospital, we are kind of set up to deliver healthcare services at home, at the retail point, at the corporate location, once the patient is out of the critical care setting, which is the hospital. That's where we play. Right.
Thank you so much, Ishtiaq. My name is Vineet Gupta. The organization name is slightly, needs to be changed. It's Siemens Healthineers now. Yes, I was part of Varian Medical Systems, no doubt, but Varian was then, kind of acquired by Siemens about 4 years back. So we are Siemens Healthineers now for sure. Siemens in India, of course, is a very old organization. And from a healthcare point of view also, I think we established the first X-ray unit way back in 1927. So I think in a couple of years from now, we'll be completing 100 years in the country. And we are exclusively there in the medical technology space, unlike Abbott, which is also there in nutrition, which is there in pharmaceutical. We are purely in the space of medical technology. And within medical technology, the larger focus is on the high-end technologies, which we manufacture, like MRIs, linear accelerators, PET CTs, CT scanners, and so on and so forth. So that's the segment we represent from medical technology point of view. And thank you for being here. Thank you. Thank you, Stan.
Yeah, good afternoon. I'm Rajendra Gupta, as you see my name. There is no photo ID required, so you can judge me that I'm the right one. But it's the toughest thing for me to do is what I have done or what I do. So I'm a totally lost guy. Started with private sector, was there for a long time, known most of these people, worked with them. Then I decided that we should look at changing the policies of this country. So I ended up writing the manifesto of BJP in 2014 when our Prime Minister came to power, transition from CM to PM, and I was involved in that team. So you can see that he does all right things. If the policies are wrong, I am to be blamed. I publicly take the credit. So, I don't blame anyone. Partly bureaucracy, which everyone do. But, so then not only that manifesto was good enough, I was tasked to write the health policy. My boss, JP Nadda, who is back again. I was his advisor from 16 to 18. We launched the biggest insurance scheme, the digital mission. Wrote the health policy. So even if health policy is wrong, you can blame me. And if that was not good enough, they said write education policy also. So I screwed up all the policies, health, education, and that was not enough, Viksit Bharat Mission. So I created Viksit Bharat Mission and it became a flagship program. So I like writing policies with good intent. What they do to the country is for best, I think, for you to judge. And I'm not an authority, so I ended up writing books. I'm an author. So I wanted to make sure that I get it right. So I'm an author. I'm not an authority. I've written 5 books. Each of the books have been on a sector domain where I learned that writing the books. So I write books, and I also chair 3 committees in UN on environment, economy, and digital health, and the Commonwealth AI Consortium. I'll stop here. I think there's enough misleading I have done for you.
Hi, good morning, everyone. My name is Harkesh Dabas. I lead the Clinton Health Access Initiative, Clinton Foundation in India. We are an organization that founded in response to the HIV/AIDS crisis at a point in time when it was estimated that 40 million people had HIV/AIDS and less than 1 million were on treatment. The cost of treatment was about $5,000 per person per year, and the world thought this is a problem never going to get solved. And it was principally an issue of really aligning the supply and demand, understanding incentives, and bringing scale into a problem. Today, there are more than 30 million people on treatment. The cost of treatment per year is less than $60. HIV today is not the death sentence it was, it's a chronic disease. And I recount the story principally to tell you that the problems that underlie that space actually underlie every part of the health system, and it's all about how do you work systems. And I also tell you this story because 10 years from now, you will not know healthcare as you know it today. It'll be far more democratized. It'll be available at your home. Colleagues like Prashant and others are creating systems that allow you to really sit in your home and really access healthcare. Healthcare, hopefully, will be about preventive and promotive and not the curative that it is right now. And I think that's very, very sort of, I'm very optimistic that will happen. Number 2, I think each one of you individually knows about digital health more than each one of us individually do, because digital health we understand in silos. We understand, someone understands it as an app, someone else understands it as a technology or a diagnostic platform. And I think, and the change is coming when, everything will be reckoned, all will sort of all come together to deliver service to the citizen who really needs to be at the center of it. So,
any question in any one of yours mind on the basis of the introduction that we've had? Okay. So let me turn to you, Professor Gupta, first. Since you owned up to messing up all the policies, let me start with the policy. I think, particularly post-COVID, so of course we started a lot of these policy making, especially in the healthcare, I would say, after Prime Minister Modi's first tenure. But COVID was in many ways disruptor and accelerator, and we really saw that the entire healthcare, seeking the health care by the citizen for the first time really came to the central space where, people started to get more conscious about it. That we realized that we are a vulnerable breed. We need to take care of ourselves, and what Harkesh was saying, moving to preventive from curative in certain way. And that also led to what is the universal healthcare mission in India, right? A country of our size and diversity. What exactly is the aim, what is the end game of universal health coverage? What do we really want to do? Is it going to move from a private setting to public setting? Is it going to move from out-of-pocket expenses to the reimbursement? Is it going to move more towards the access? Are we And I know that, we are also superimposing this with the digital mission so that, there's an access piece and all of that. So if you were to define the universal health coverage in India with respect to the digitization and everything else, the entire India stack and all of that is going on, how would you define that?
Thank you, Jack. I think it's a very loaded question. I'm still trying to, sync all the dimensions of that question, but let me give you a sense of where this policy things came from. While COVID did force us to implement, policies were written much earlier. I can give you the exact date. Health policy had completed on the 2nd of June 2016. It was released by the cabinet in 17. Education was written in January of 18, released in 2020. So all this happened before COVID. So if you ask me today, I keep telling the government we should relook at the policies because they were written before COVID. While they were planned in a way that any exigency we can take care of them. That's embedded in the policy. But having said that, I think if you look at the policy where it starts from, there are 3 lines that I wrote in the manifesto, which I also wrote in the policy: increasing access, improving quality, lowering the cost. That's the essence of policy's achievement, that we put it down there. India also has a challenge of the finances that we have. So I think in the policy paper, people only read the policy, not the background note, which is a situational analysis. But it's clearly written the goal was universal health coverage, but given the competing priorities, we said we will give comprehensive primary care. So effectively, if you ask me today, there is universal primary healthcare in this country, promised by the government, it's available. So that's already done. It will gradually get scaled up. So you look at PMJAY, which has come, which covers 550 million. Now we added seniors on that. So you add another 150 million. So gradually you see we are finding ways to enhance the cover. And on the digital mission, at least I can say that me and my boss, that time also he was health minister, is back now, that we were clearly in agreement that doctors like them who are sitting, they are sitting to make the healthcare system better, but effectively not go to villages to, live in an infrastructure where they can't support their families. So me and my boss clearly believe that we shouldn't force doctors to go to villages. We should actually use digital technologies. That's where the digital mission was born. And on the policies you asked me, and I think one thing that I keep worried about, I see there is entire industry across this panel, and the government is much ahead of the industry, I can tell you, and you should think about it. This is the first country in the world where the government is much ahead. So we have an ABDM which has rolled out 760 million Aadhaar IDs. We have eSanjeevani which has done 350 million teleconsultations. And look at the scale at which government is moving, and the health claims exchange coming. A lot of things are coming which will force people to adopt technology. So as a students, you asked me, what's your future? Your future lies in being digital. It is not going to be what you read today is going to help. And I think as Harkesh also said, others have also said. So policies for India have been, I think I have worked across the world. And one thing I learned that people in the industry get technology first, policies follow. In India, we have got policies first, standards first, industry is still following up and trying to catch up. They have still not been able to catch up. Let me ask you a question to do a reference check of what I'm saying is right or not. How many of you know about software as a drug? Can you raise hands? Software as a drug. Software as a drug, DTX, if I were to say DTX. How many of you know digital therapeutics? Can you raise hand? Can you give me an example or give me a definition of that? How many of you work in healthcare? You should raise hand. You're in healthcare. Don't shy. I mean, there's nothing to shy.
He's also a professor, and therefore...
As a policy maker, I always write policies interacting with you. They were never written in a boardroom. Now, let me give you a reality check of why I say government is ahead. The Drug Controller General of India approved 2 digital therapeutics last year, and my people don't know. Every day I talk to, I address thousands of, and deliberately now I address. I used to shy from interacting with people. Yesterday I was talking to pharmacists across the country, online, and we had taken pharmacists who are dispensing pharmacists at the retail level. They didn't know about their new developments. So we are not spending time on what's the future. We are just thinking about it coming to the conferences. There's a limitation. I think you have to be prepared. The government of India is, I think, on that one of the most progressive governments in digitalization. But the industry is not. I mean, I still have to push my friends. We are too driven by balance sheets. We are too driven. Nothing wrong. I mean, I think if you don't have profits, you won't have any plans. No one is going to approve. But if you're actually looking at how government operates, I think one should be ahead. I mean, I see that as a big drag on the private sector. They are still way behind. And the government is much ahead. And I think don't get disrupted if you're not using technology. You are already late, I must say.
Yeah, please, please.
And again, a question to you and perhaps other panelists as well, right? It's a given fact that perhaps,
just bring it closer to you.
and we should be proud of this as well, that perhaps we have the most enabling policies in any given area, right? Be it sexual and reproductive health, be it digital health, be it the way policies are written so far as healthcare delivery is concerned, be it the design of the architecture that we have going forward, and yet that doesn't translate into really delivery of services on the ground. And I say this, I think all of us have experienced at one point or the other a friend or a relative or someone who we know who may need medical care. And every time that happens, you are then talking to someone saying that, do you know this doctor? Can you get this appointment? Can you get... There's massive friction in the system currently, right? Where policies don't eventually get translated into actual delivery of services to the patient that are required. It's a series of IOUs that you exchange as you navigate the healthcare system, be it private or be it public. The transaction cost of engaging with the public healthcare system are perhaps higher because the system is overloaded. So coming back to, and perhaps to the panelists itself, APDM, extremely enabling. There's a United Health interface, there's an exchange that has been created. You can actually go ahead and hold all your medical data there, which belongs to you. Data confidentiality is assured, and yet it doesn't find the uptake that is really required in the private sector, or for that matter among citizens, because use cases where you structure a win-win-win, and I think that's where what really needs to be done is government spending a lot more on awareness, a lot more engagement with the private sector, creating those win-wins. I think, you know, and at some point in time I'll ask Dr. Gupta to come in on this as to how do you solve for this? You have the policy, you have the architecture, and yet it's the frictions within the system, especially between public and private, and between the citizen as well, and lack of awareness on part of the citizen that really doesn't really translate into leveraging the potential of what we have.
We will come to that. That's it. Let me come to you, Prashant. So we did talk about the overall architect of the policies. No doubt the way this is moving, putting multiple pieces into it. You know, you guys started 1mg with a vision. You clearly saw a gap, right? And you talked about it. Outside of the hospital setting, what is the access of healthcare information to begin with? And then, of course, you know, I mean, having the access to medicine at a click of a mouse, or, you know, I mean, to be honest, I was pleasantly surprised that you actually do the delivery in 200 cities. I wouldn't imagine that. And diagnostics in 55. Not that, I mean, India has far many more cities and we have a lot to get there, and we're going to talk about that. But if I were to ask you, what were the major policy impediments that you really encountered, and how did you really address that? Because, you know, I mean, one of the fundamental thing I think we have in India, despite everything that Professor Gupta and Rukesh talked about, is the trust issue. I genuinely believe that we don't come out with the best policies or implement it the best ways because of the lack of trust between different walks of life in the society. How did you address that?
I think at the outset I would upfront say it's still work in progress. It'll always be, and I think, see, the thing is, healthcare is a regulated sector, as it should be, and in any regulated sector there is always going to be this little bit of tension that the regulator sees the primary job as maintaining status quo, and the innovator sees the primary effort as changing status quo. So there will be some meeting of the minds at some point for both to move in sync. And there's almost always in every regulated sector, not just healthcare, but specifically healthcare, there's a lockstep, or there's sometimes a gap in who moves first and who follows. The good news is, and to the question that how did this entire journey happen, that the regulators and the governments were willing to engage on a very active basis. So many times in regulated sectors, ideas are just stillborn. You just can't even get started because of the regulatory overhead and problems. But at least here, what we were lucky to find was, what we did first of all was, from the get-go, we had to engage actively with the government, with the ministries, with the regulators. The public policy was an integral part of the startup journey, which is atypical in other sectors. Now, does that add friction? Does it make it harder? It certainly does. There's a lot of additional uncertainty, additional effort on top of that, being on the concurrent list, and both states and centers having a role, both having roles or views on interpretations. And another big challenge that, this is an evolution of the ecosystem or the country itself, is healthcare is today no longer just a medical science. It's technology plays a role, data plays a role, and there's obviously it's commerce, there's financing involved. So now what has happened is that the skill sets required to manage or regulate healthcare, and what was the challenge in our context? It's the Drugs and Cosmetics Act very clearly would define how a pharmacy, the process of sale of pharmaceutical products. It is actually silent on mechanism that how the prescription should come or this or that. Those things are actually covered under the IT Act, which is in another ministry. Then financing of companies and corporations and all of that, the Ministry of Commerce has a very significant role. Now, getting all of that aligned and making the onus comes on the entrepreneur to explain it to the various regulators that there are other acts that make this entire chain possible or viable or in sync with the laws of the land. And we want to work with you to create the more progressive, comprehensive rules and systems for the next phase, because this is going to be a key part of the architecture of healthcare delivery. So I think that part has been pretty much integral to our evolution and journey from the very beginning. So it was both a necessity, but it is also actually a huge important step, because we are creating an industry, and the regulators also need to have partners from the industry work with them. So that's how the journey has really been. And I think in healthcare, anyone who's looking to innovate or start anything, engagement with the authorities will be a key part of the journey, and the sooner we do, the better. The good news is that there is a very positive willingness to learn. There's a very positive willingness to understand, and once you do, there are obvious concerns and constraints, and that trust deficit that you mentioned, there is significant, because there have been bad actors on all sides. And that has created that trust deficit. But the way policy gets created that actually moves the agenda forward is there are also good actors on both sides. And once you understand what are you trying to put guardrails around, then collaboratively you kind of find the working model, so to speak. Having said that, is there, so it's a continuum. It's not like it work done and now that part is. So now what is the next phase is continued more work, because we've come a long way, we have a long way to go. Because the the regulation, again, Drugs and Cosmetics Act, 1940, it was written. 1945, the rules were written. The new act is now in draft phase and hopefully will be notified, but we really need a new progressive act, and then more importantly, the rules that come. We need to move in step with, and it needs technology, data, IoT systems, new AI-based systems. All of those have to be an integral part of the new policy. And all that capacity building is needed in all our ministries, all our government bodies, which traditionally it takes time to make those switch. Will it happen? It will. Is it something that as an industry we want it to happen faster? Yes. But I think in the large scheme of things are actually moving at a pretty interesting and decent clip. So net, where are we? I think the sector needs regulation is very clear because it is a sensitive sector. You're dealing with human life. It needs innovation is also very clear. So we've got the job cut out for all of us, both industry and the government.
Thank you, Prashant. This is very, very comprehensive, and really, one can see the journey of 1MG in the way you've described this entire thing. Let me come to you, Vineet. Let me bring you in. Viksit Bharat, the concept of Viksit Bharat, is, to my mind, is just not a policy journey. It's just not a technology journey. It's just not a governance journey. I think it's a behavior journey, right? A developed nation behaves in a slightly different way than a developing or an underdeveloped nation, right? When we do that, Prashant talked about the Drugs and Cosmetic Act. The current Drugs and Cosmetic Act doesn't even differentiate between drugs, diagnostics, and medical devices, right? So it is as primitive as that, and there's so much of changes that is required here and now. For someone like you who represents a digital technology healthcare company, let me ask you two questions. One, do you think that the policy changes are at pace with innovation, number one? And number two, you can bring in the best technology in this country, but if you don't have the best manpower or the capacity to really operate that, and which is, again, that's where the trust deficit comes, that, can you take Indian healthcare professionals outside for the training, or, things like that. Like Prashant was saying, there have been bad actors, and as a result of which you need regulation. It's almost like, you're driving on a road, you see that people are not behaving, so you start putting too many red lights, saying, oh, they must stop every 500 meters. But when you do that, you slow down you basically slow down the speed of the traffic, right? So it's basically a balance between the two. So how do you really see that as a digital diagnostic company?
Thanks, Ishtiaq. So, 2-3 points which I want to highlight. First of all, I think one good thing which happened for the medical device sector or Meditech sector, which was coined by the earlier Secretary DOP, from an absolutely non-regulated industry, we are a 100% regulated industry today. So this is definitely a very positive thing which has happened. And all the medical devices either being manufactured in the country or being sold in the country by getting them from outside are regulated by CDSCO under Medical Device Rules 2017. So this is definitely a very positive move. However, to your point that, the concept of Viksit Bharat is more of a behavioral change. I think what we are looking at, in terms of Atmanirbhar Bharat or self-sufficient country, somehow we feel that we can do everything on our own. And that is being forced on us for some reason or the other. And it is happening in the medical technology field also. There is a lot of thrust by the government on Make in India. Just to give you a brief, background, Siemens Healthineers, much before this vision of Make in India, I mean, we have been doing this manufacturing of technologies or in medical devices for almost 60 years in the country. So from that point of view, I think those things have always been there. But I think today the biggest challenge we face as a medtech industry is that we are being viewed through a single lens by the policymakers. I sincerely believe that medtech industry cannot be seen as just one single canvas. It is an industry which has got multiple divisions within the industry itself. Even if you see, it can be largely divided into at least 4 large segments: consumables, implants, IVD segment, and then the high-end medical technology. And each of these segment has a different requirement, though they are all covered under the same medical device rules, but each of these segment has a different requirement, and each of these segment needs a special, kind of a, I would not say exactly policy, but definitely a differentiation needs to be created amongst each of these segment, for sure. Today, it's a good thing that in the consumer segment, consumer medical devices, we are export positive. We export more than what we import. But in other segments, it is not the case. Government wants us to manufacture in India, but just by wanting us to manufacture in India doesn't make us start manufacturing in the country. It is not so simple that okay, fine, today we want you to start manufacturing an A technology in the country, and you start doing it. It doesn't happen that way. And somehow, to your point, Prashant, it's not about good actors or bad actors. Even the good actors need education, I believe. So as an industry, it becomes imperative for us that we kind of, educate the policy makers that what is feasible, what is not feasible. I'll give you a couple of examples. We have been, by the way, we as Siemens Healthineers are a beneficiary of PLI scheme in medical technology. We are manufacturing a CT scan and an MRI with a different technology for under-penetrated areas, under the PLI scheme. And I am happy to say that we are the only PLI beneficiary in the medtech space who has been given the incentive for 2 consecutive years. So, I'm sure we are doing something right, because the PLI parameters are not only about investment, but also meeting certain targets, in terms of sales. So both the parameters are being met, and that is why we have been given these kind of incentives. But coming back to this Make in India concept in the medical technology sector, I think somewhere as companies we feel the heat, because people as policymakers somewhat take a very myopic viewpoint. Today, some domestic manufacturer claims that we are manufacturing an A technology in the country. There is a diverse view from the technocrats or the medical professionals' perspective vis-a-vis the bureaucrats' perspective. Bureaucrats just see that something is being aligned from the vision of government, which is Make in India, so let's promote this. But are the doctors who are going to use that technology willing to do that? Is again a big challenge, It's a big question mark. So there is a huge gap in these things. And the most unfortunate part we as an industry are facing today are the quality control orders. I don't know how many of you are aware of these things, but these orders are issued by various departments for the range of components, accessories, or raw material, which they are responsible for, and they want them to be registered with BIS. Now, the challenge is the implementation is just not in sync with the thought process. You can bring those parts as part of the larger equipment without being questioned for the BIS requirement, whereas when those are being brought in independently, then the BIS is being questioned for. So today, even from the manufacturing perspective, let us agree, let's acknowledge that we do not have the system or the ecosystem where the components and the accessories are available in the country. We have to depend on the imports. And when we are trying to manufacture those equipment in the country, we cannot import them because they are subjected to BIS. So it becomes such a messy affair. And there is no one single department in the government which can actually handhold the industry and get us through this whole, messy affair where, we are not able to import, we are not able to maintain the installed base, and we are not able to manufacture the things. So I believe somewhere the biggest challenge which we face is to bring different departments on the single table in the government to have a dialogue on one particular subject. No one is willing to take the responsibility. Unfortunately, our parent ministry is also not hand-holding us the way we would like them to. But yes, these are the challenges which we face. But still, I would say that at the end of the day, as a country, definitely we see a huge potential in the adaptability of the technologies. And we will definitely see that, of course, we'll definitely come through all these issues. And but hopefully, we will be able to come out of this thing. And as you rightly said, that the whole technology aspect, the challenges which we face, eventually have to be addressed somehow or the other. That's how it is.
No, good, thank you. So I'll open up for questions, but let me just conclude this trust piece, because this is getting interesting, right? We are, in any good panel, we must have varied voices. We can't all of us be speaking the same language. Interestingly, we have Professor Gupta, who's worked in the private sector, who's written policies, who's worked with the minister. So I think a lot of these things we can actually put together and come to you. I'll give you an anecdote. I was in a meeting, and I don't want to tell you where, just for the data privacy. We had representatives from the patient groups. We've had policy advocacy groups. We've had hospitals. We've had lab setting folks. We've had payers and insurers, medical technology, and pharma company. Right? So this is like, there's nobody who was left in the healthcare space, from the consumer to the provider. Hospitals say we have very high overhead, we are not making money, we are bleeding. Payers said, we do not foresee that we will break even and start making money in India in the near future. Patient group says, you guys are fleecing us completely. The kind of money that you're charging, there's no common man who can really afford healthcare in this country. By the way, there was one ex-retired policymaker also in that room. That guy said, what are you talking, big Indian pharma, you making money like anything. The pharma company said, in India, we have probably the lowest drug prices in the world, amongst the lowest, if not the lowest. Medical technology guys, you've heard Vineet speak. My question to you, Professor Gupta, who's happy? Patients are crying, hospitals are crying, medtech is crying, pharma is crying, policymakers is crying. Then who's happy?
First is that people in happiness also cry.
So these are all cry of happiness.
I don't know that. But let me tell you, how the narrative gets shaped. And I spent large time of my career in private sector, and I still run a startup. I still am plugged into the government for feedback. I also run the largest patient group. We don't talk about it, but we hold a conference, Patients Union Conference, where policymakers sit and patients talk. And if you heard the 7th April one, the son-in-law of the BJP's founder was there, telling his part of his suffering in the system. The director of Ministry of Corporate Affairs was there. The plumber of my building was there. The office boy was there. So not a single person is paid by healthcare. Now let me get to the part of trust. I always hear this issue of trust. No one talks about ethics. If you started talking about ethics in the first place, you would never talk about trust. And now let me give you my first-hand experience who transitioned from the industry to work with the health minister. I had a chance to work with 5 cabinet ministers, including doing work for the Prime Minister and the President of the party. In the morning, I'm naming people, so don't take it, not people, but organizations. In the morning, I had IPA. Sir, we represent Indian pharmaceutical companies. Look at what multinational companies are doing. Few days later, I had OPPI. Sir, we are OPPI. We spend a lot on R&D. Now, OPPI is talking against IPA, IPA is talking against OPPI. I am sitting as advisor to Health Minister listening to them. If that was not enough, I get IMED's president. Sir, I have Indian medical device manufacturers. We have 500 members. That time it was 300. We are the ones who do make in India. Then next time comes APACMed. Sir, we are APACMed. We represent multinationals. You should allow import of refurbished devices, their quality check. Now tell me as advisor to Health Minister, what do I do? What kind of trust are we talking about? No one came and told me that, sir, this is the need for India. And I can give you another example. Since you talked about trust and you talked, when I was writing the manifesto of BJP, CII entire delegation came to me. I was there, Dr. Joshi was there, Yashwant Sinha, all of us were there, listened to them. They had all the tax demands. I said, we will do that. But give me two solutions. The requirement for chips and semiconductors will be very high in next few years. What's your plan? First point. It will be more than the fuel bill. And it's now that we are talking about chips 10 years later. It's there in the manifesto of 2014. And the second thing is, how do I cut down my dollar bill? Today we are trying to do that. You know how much time they take to come back on the inputs? 8 weeks. They had not worked on that. So why would I trust those associations? And another meeting, with the first meeting I attended Ministry of Health, I had the entire industry sitting. And my additional secretary, that time KB Agarwal, told me, sir, this entire healthcare industry is here. And it's not just I'm a professor that I asked question. I asked them, how many of you represent hospital less than 50 beds? Not a single hand came up. I asked them, how many of you represent independent clinicians? Not a single hand came up. And I told KB Agarwal, KB, this is not healthcare industry. These are the big groups. Tell me clearly, I'm open to listening them, but tell me who are the stakeholders whom I'm talking to. So whether it is AHPI, CAHO, Nat Health, they're all funded by the same three guys. I mean, why as a policymaker in the room should I trust them, whether it's CI, FICCI or PhD chambers? I mean, I think we should shift the talk from trust to ethics. If everyone starts talking ethics, I think the problem of trust will go. And we always go to the government, when do we go? That's another thing. I think all of the people on the government affairs, and PAFI is mostly of government affairs, I know the founders. We go to the government when the water is above our neck. We never go to them when we are doing things. That has been the biggest challenge of communicating with the government on routine issues. We always go to them, sir, there is a problem. My shipment is stuck here in customs. I need this. This is the issue with me. We have a problem with approvals of these devices. I think the industry is divided in itself. There is an Indian lobby, there is a multinational lobby. So if the industry comes together, I think the trust problem will get solved over time. But at this time, the distrust is very high. Let me tell you that. And the other side of the problem also, I must tell, that it's not just the industry. And I've always been very open, that I always used to tell my prime minister. I actually wrote an editorial in Economic Times, let's not do Congress Mukt Bharat, let's do Bureaucrat Mukt Bharat. Sitting in the government, because my bureaucracy doesn't support the word profits, but they want taxes. So I kept telling them, if industry doesn't make profit, how will we get money to support you? So industry also has to change the mindset. In fact, we should have a revolving door policy where the bureaucrats go to the industry and come back to the government understanding what their pain points are. So I started lateral entry, but as always, bureaucrats don't love all that. You know, but the whole idea is we have to bring people from the industry to the government. I think that's where things change. But I totally agree that this is not going to happen in few years. I think we need to shift the debate from trust to ethics if we really want to create trust. By not just talking, trust will happen.
No, thank you. Harkesh, I'll come to you.
If I just might, on that question itself, right? It's a journey. Just given our socialist context at one point, and it's a journey that, you know, we are undergoing that social economic change right now. Health and education have normally been considered as public goods, which should be provided by the government, simply because, you know, there is issues of moral hazard. Issues of moral hazard in providing those public goods. If you were to just look at three separate examples, you look at India, you look at United States, or you look at one of the Nordic countries, right? In India, healthcare is being provided by public and private sector. In US, it's mostly private sector, and they're not happy as well, right? There is deep distrust there too between the public and the private. You look at Nordic countries where most of the healthcare is provided free by the government itself, and at the very highest level. So I think there is some debate to be had whether it should be a completely private, should be a mixture of public and private, or it should be completely public. And that's a social, cultural, moral hazard question, which we don't. But I think it's a journey. I do think the way our healthcare, you know, discrete parts of the healthcare are structured, both public and private, and the way digital health can enable all that to seamlessly deliver care at really affordable cost, and I think I am encouraged by that. Just to give you an example, a few years ago, there was no drug for hepatitis C. Then came a drug. In US, it was priced at $84,000 for a 12-week course. Then generics in India came in and said, we'll manufacture this. They were licensing that we as an organization facilitated. It was launched at $69. $84,000 to $69, right? And therefore, I think this issue that healthcare is expensive, I think we're very lucky that healthcare here is very affordable already, and it can only get more and more affordable, and trust is something that needs to be built over a period of time. It's a part of a journey, I think. Digital health will bring greater transparency, which is required for trust. It will bring greater privacy, which fosters trust. So I think we are getting there. 10 years.
You guys are not letting me speak only. I mean, what, the moderator also. No, go ahead. No, go ahead, please.
I fully agree to your point, Professor Gupta, on the ethics, But then, again, it is the responsibility of the industry also, whether it is the pharma industry or the medtech industry. And within medtech industry, again, the Indian manufacturers and the foreign the MNCs, The point is, are we bringing the right picture before the policymakers? I mean, today, IMED, or for that matter, the Indian Manufacturers Association, goes and claims that we are, there for the we represent the complete medtech sector, in terms of manufacturing, which is not the case. I mean, the impression which people get, and that's why I'm saying we need to be viewed with different lenses. We should not, I mean, the whole canvas cannot be painted with the same brush. And that is where the education part from the industry perspective to the policymakers comes in, that are we conveying the right picture? Are we conveying the ground realities to them? I mean, even from the manufacturing perspective, I say, somebody may claim that he or she is manufacturing one specific technology. But is it good enough to cater to the requirement of our country? That single, even if I start manufacturing a product in the country, I'll be probably manufacturing only one particular model of that a product, whereas I have a range of 10 different models. So the rest of the 9 models are still to be brought in from outside.
No, okay. So we've digressed from technology to policy making, but it's a good digression to have, because you needed to understand the complexity of policy making, and of course digitization really makes it plays an important role there. On the issue of multiple voices coming to the government, my view is this is exactly how it should go. Nations are typically microcosm of multiple voices, just as family is. I have a family of 4 people, me, my wife, and 2 boys. Every summer, we literally have a riot at home. My older son wants to go and visit a historical place. My younger son wants to go to a beach. My wife wants to go to the nature, and I have to, as the father, whatever. I mean, not that most of the decisions are vetoed by the wife, but at the end of the day, you'll have to listen to all 3 of them. If we only keep visiting the historical places, we would have never seen a beach, right? Or we have never walked into or trekked into a nature park if we had not listened to one of them. The important part is, what does India need? I am limited by my vision. The government is not, and government should not be. Does India need, let me give you an example. Does India need refurbished, good quality equipment for health access? The answer is yes. Does India need Make in India? The answer is emphatic yes. And both of them can coexist, and both of them must coexist. If they don't, then we are actually not being honest to the patient of India, to the people of India. So I think somewhere we'll bring all of these things together. More importantly, I completely agree with you, Professor Gupta. The industry, there are 2 things, and since some of us are here and Puffy is doing this event, many of us are government affairs and policy professionals, remember one thing, you're not the company marketing person when you get into the policy. You're the industry representative. And you must elevate your thinking at least to the industry, if not to the country. Ideally, you should actually elevate it to the country, right? So that would be my take. I don't know if you agree with this briefly, and then we can probably open up.
I totally agree. You know, first is, I think Ishtiaq very clearly said that I have worked with people across party lines. I mean, it's another thing that, you know, I have my roots in this current dispensation for a long time. But I have friends across political parties, and I, like you said, you talk to 4 family members, I talk to 14 parties also. And I listen to all, and I tell you that across party lines, we have some fantastic people. I used to ask them one question, including my party, what's their vision for this country? Not a single answer came. I said, we are running a country with 5-year vision of running elections, we need to have a bigger vision. So that's where we said, we should create Viksit Bharat. How long we will continue to be an LMIC? And I did all the numbers. There's a book called Tough Choices, Hard Decisions, Making India a Developed Country, which was released by Mohan Bhagwat, for obvious reasons, you know very well. So, and in that I did complete analysis of where India's problem is. We have maximum 20 crore middle class. How do you expect to support 140 crore people with 20 crore people's taxes? You can't. So the basic idea was to increase middle class, but to where to take it? Next challenge that we'll have is by 2047, 1 out of 5 person in this country would be a senior citizen. Their healthcare expenses, their incomes would not match to sustain this country to make it developed. So for all of us, it has to be a vision to make India a developed country by that time or forego that goal forever. And I think, so everyone should have vision, but underlying framework of ethics is very important. In fact, my line for Atmanirbhar Bharat is, अगर आप आत्मा में निर्भर होंगे तो भारत आत्मनिर्भर होगा. हम लोग अगर आत्मा पे निर्भर नहीं है तो आत्मनिर्भर कैसे कराएंगे? This, you go to the Viksit Bharat website, that's the landing page message. There's a document you can download. And I think Vineet raised that point about people. The first thing starts with people. So I think we all should understand about digital. I will just sum up, since this is something that I am very passionate about. And I say this now is trademarked by the startup, that if you're not in digital health, you're not in healthcare. And I think my friend Harkesh put it very well. Most of the things that you are doing today, you will not be doing in 5 years' time. It may appear very bold to you, but we run a course. I asked you a question, go to the Academy of Digital Health Sciences. I mean, what I did is started training people, because like he was saying, Rajan, this is how the room filled up. This is how India fills up. When we started the panel, we had more people on the panel, less people in the audience. And this is how India moves. There is need, but not demand. And by the time demand comes, there's so much that we can't handle. You know? So that is India. So it is the way to reflect how India moves. And in Europe, I was asked in Mobile World Congress, I love India, but I hate traffic. And I said, look, there is traffic for you, there are consumers for me. There are so many consumers on the road. Any single product you bring to India, I have more than 300 million consumers, more than the size of United States. True. So I think I always love my country for the potential we have. Where do we release that is totally our responsibility collectively. We are the government in real sense. We pay the taxes, we support the policies, we actually are the beneficiaries or the victims of the policy. So the power lies in the room. Thank you.
So let me open up for questions from the audience. Okay, I see a hand going up there. Please introduce yourself and keep your question brief. And if you have a specific person in the panel, please ask them.
Absolutely. So I am Tushar and I work for health as a all, generally we can say. So discussion started with the government's commitment to the very robust policy making, and as coined by Harkesh with the word friction, and they will literally see the friction, the opinion. We saw a complete picture about the industry side, or try to understand the industry side. If we can move the lens from the industry to the population or the patients, how can the National Digital Health Strategy ensures that the innovations in the healthcare or the technology doesn't create the digital divide in terms of the equity, not only access?
Harkesh, you want to take this?
You know, really super important question, right? You'll have to bring it close, huh? Really super important question, right? Accessibility is fundamental to making whatever the vision tomorrow is possible, right? And I think there is a fair bit which is being done there. Of course, you know, there's always need to do a lot more. Digital health, so first of all, isn't the very design element of any product, right? You're designing for, you know, a person, you know, who's the least digital literate, right? And therefore, whether it's online platforms, whether it is, creation of Aadhaar IDs, whether it's engagement with ABDM, the first is the design element, that you're designing for someone who's the least of the digital literate, right? But apart from that is the whole issue of actually creating digital literacy. And I think there are a number of initiatives that government has taken. I don't remember the name of the schemes, but there are at least 3 different schemes where government has undertaken in order to create that digital literacy. And I will refer to my notes and I'll come back on this, that there are schemes there, both for frontline healthcare workers, for citizens. And then there is a whole this thing of CSC centers that are there, right? Common service centers that have been created for those who are not able to engage as effectively going there. But again, it's a journey, right? Digital literacy, we have phones, we have, I think, 900 million platforms, but, it's creating that effort and really pushing the financing behind it to create that literacy. But fundamentally, it has to start with the design element itself, is my answer.
Thank you. You had a question? Yeah. Go ahead. Go ahead, please.
I wanted to ask that...
What's your name?
My name is Dr. Shruti. Yes. I work for comprehensive primary healthcare and I work with an NGO. So lovely. I wanted to ask that we do have great policies and good amount of technology already in our primary healthcare. But how are we planning to make it quality-wise high? And are we looking at prevention? Are we focusing technology with prevention? And what we see good numbers with technology uptake and everything, but when we come to rural setup, is it actually being uptaken or is it shown that it's being uptaken?
Okay. Professor Gupta.
So, if I go by the numbers of the Aadhaar IDs, they're fairly decent in terms of 766 million. If I go by eSanjeevani consultation, I think every day's dashboard is out there, some 250 to 270,000 consultations. But what I feel is a challenge. You talked about rural. I'll go back to test with you also. What is the consultation fee on eSanjeevani for a neurologist? Can someone tell me? Just only one person, right? The challenge is even in urban areas, we don't know the realities of government schemes. So, we have ASHA workers, 1 million. The job is to outreach and do, but I think we all don't do it. That's why my question was on ethics. So if we did our job well professionally, we would have taken the government schemes to the masses. My problem is not coverage. My problem is usage. We have wonderful schemes. You tell me a problem, I'll tell you a government scheme. And every time a ministry returns the budget back to the government finance ministry, I feel pain that people are in need, but we are not delivering. So our job is to push. In fact, when things don't happen here, I have a limitation that I'm a policymaker. I'll not go to implementation. I blast my bureaucrats. The only segment of the people who are unhappy with me is my bureaucrats. So I'm very open to tell them. See, their job is to make sure that whatever government has planned, there are 2 things you have to understand, government and administration. Government is the politically elected every 5 years, and administration is, we say in perpetuity, implement the government's plans. The disconnect between that is a bigger one than the disconnect between the industry. Everything, you tell me a problem, I'll tell you what is the government scheme, what is the budget. My problem is that doesn't go. NGOs are there, but I have a difference of opinion on the way we work with NGOs. But I think we have benefited. You can see the numbers, IMR, MMR dropping down very clearly. I will go with numbers. I will not go with opinions that I have. I think over years our longevity, look at where we are. COVID brought us down, we again bounced back. So government schemes have delivered to a large extent, but do you think we have a long way to go? Absolutely, yes, we have to. But government is well-intentioned, there is plan, there is a budget. But as I said, it's a big country. If in 4-member family, he can't decide I have 140 crore people. I have to still manage all that. But still, I think NGOs do a good job at many places. But implementation still remains my biggest challenge. I mean, ABDM, I tell them. I told the minister when he came back that, we have rolled out Aadhaar IDs. Can you tell me what is the data in Aadhaar IDs? Please change the team. Coincidentally, the entire team got changed. But still, we have a long way to go. I mean, for me, 766 million doesn't make sense unless there is a citizen's data on it. So, yes, I mean, I think we have done fairly well, but we have a long way to go. So the point of between coverage and usage, still there is a gap.
If I can just respond to that once. Okay. My guru for all things health is Dr. Gupta for a really long time, but I need to push back on what he said. And not push back really. policymakers and government really sees, from the side of supply, that this is being supplied, and they don't look at it or don't invest enough on actually demand and actually making citizens aware that this scheme is there and this is how to access it and this is what you can get. And which is principally the issue with ABDM as well, that not enough investment is going into really awareness, into demand generation. It's saying that scheme is there, but it's not being taken up as we would like to. So I think there needs to just be greater investment, and it's really not incumbent on either the citizen or the civil society as organizations to do that, because they don't have the reach, they don't have the platforms. Government has the platform and the reach.
I'll add just one phrase there, that NGOs come in where the governments fail, very simply put.
So to Professor Gupta's point, I think you talk about numbers, Aadhaar cards, almost 750 million plus Aadhaar cards have been issued. But somehow I think there is one gap between the rural and the urban segment, is that there is a mindset in the urban segment that all these government schemes are largely meant for rural population only. And they are not meant for us. So, I mean, today in this room, if I ask how many people are actually aware about Aadhaar scheme, how many have availed that scheme, where they are eligible as well, I don't think we'll have anybody answering that question. So that communication probably needs to be, fine-tuned.
Let's bring in Prashant, because he's actually bridging that gap to a certain extent, outside of the hospitals and giving the information on the platform. Why don't you come in?
I think, see, the question was also around is technology enabling quality, and how does it, there was the digital divide question. I'll just answer or try to at least address a few of these questions together. I think, see, what technology does is fundamentally it brings transparency, it brings processes, systems, and it brings accountability in the system. It brings access, that's the front end part of the technology, but then at the end, digitization is actually more focused, or the value of digitization is to move healthcare from a transactional event into a long-term care management of a patient, and to move it from a generic population base to more and more personalized, individualized kind of a model. So what is the big change that is happening, and where does this value actually come, and what technology will bring? Today, every interaction with the healthcare system, be it your interaction with your doctor, pharmacy, diagnostic, allied healthcare services, those are independent transactions that have often not sufficient context of the life journey of the patient. Now, can all that context be integrated, first of all, so that various elements of the healthcare supply chain have an idea of what this situation of the patient is about, and we deliver those services in context. And secondly, over a life cycle, where is the patient on a trajectory, what is that journey? So mass personalization is what technology is delivering. So where is the model going? What we are seeing now more and more, and I think India is blessed with scale, so the data that feeds the AI models is available in abundance. We also are blessed with capability in technology and data sciences. So the challenge has been that people on this side of the spectrum who understand technology and data sciences, and people who are in the healthcare side of the spectrum, and our Indian education system, after class 10 you decide medical or engineering, and then these two just don't overlap. And one of the big secrets of success of a company like ours or digital health startups is that they bring this together. In future, I think it has to be embedded in medical education and technology education. Healthcare and technology are not separate spaces as they have been siloed from in our system so far. But what is happening? Now, I have say 1 million patients with diabetes, and I'm able to, and when you take the government scale system, you're talking 50 million patients on any condition, and you are able to see the disease progression at scale over a long period of time. you start seeing inflection points. You start seeing what happened at what point, that some went up, down, sideways, and what is the intervention required. That informs that, okay, a person is on a certain trajectory. There is a case that if this person doesn't take corrective action soon enough, then that person might have a healthcare complexity come. So healthcare, just definition of healthcare is going to change in the future. From today, we call it healthcare, but it is the curative care after health has already broken. So healthcare is not caring about keeping you healthy. It is about, since health has gone, now fixing you is what we call healthcare. That will change into your continuum and where you are, so that you stay in the zone where minimum curative require. And what does that do from a economic and policy level and all of that? It brings down cost substantially. It increases economic productivity substantially. So the investment in primary health and digital health, or I think the key word here is actually investment. Health is seen as an expense. From moving it from expense to investment that yields return, that is what technology is going to do. Now, how fast it will happen, what is the business case for that, I think it's fairly clear, and it's going to happen much faster than most of us often imagine. Why has it taken time? Is because the underlying potential of technology is underappreciated so far. But I think what Professor Gupta also mentioned repeatedly and clearly, if you don't embrace technology, then you're not going to be a key part of the healthcare architecture of the future. It's important because it is going to be integral, because your patients are going to need the interventions based on that kind of quality expectation. So that's where all of this kind of comes together. We are very optimistic that digital healthcare is going to actually help the doctors, nurses, caregivers work with patients to deliver better outcomes. And the best part is everything is measurable. So the impact of all, and it will not be a 0 to 1 switch. It will be iterative learning, fix back and forth. Some mistakes will get made, some things will work out, but the direction is clear. So fundamentally, this is happening, that healthcare will be personalized, it will be predictive, it will be preventative. That's the promise of digital healthcare.
I see. No, she raised.
Yes.
So 1, 2, 3. Okay, 3.
Should I go?
Yeah, please go
Yes,
ahead.
Hi, this is Isha Sharma. And first of all, immaculately moderated.
Thank you.
And I would say that this panel has been amazing because I could resonate with ideas of each of the speakers. And that, I believe, is something that, like you mentioned, that all panelists should not be talking about the same thing. But the idea that you presented, Harkesh, that demand-side generation is not there, I completely agree. And so you mentioned about the eSanjeevani part. So I've worked with NHSRC earlier, and now I'm working with PATH in digital health. So I come from health systems and digital health. And I understand that, yes, the demand-side gap is there. Of course, we are focusing on supply side. Even in digital health, I would say we are still focusing on the supply side. But how do you see, I think I would suggest that we kind of need a polyamorous relationship between public, private, rural, and urban. But seeing the simulation that we have, I mean, this should be this, I could see this as a simulation of maybe what can a policy table achieve when all the stakeholders are sitting together. And how do you see we can achieve that sort of a thing, let's say in coming 5 or 10 years? Because Prashant just mentioned that it would be sooner than any of us could actually foresee or envision. Any thoughts on that?
Okay, so let's take all the questions together, and then we can just divide it. So
Yeah,
thank you.
thank you.
I think
Thanks
it's a
a lot.
very valid point, and with people like him around, we do have all the stakeholders coming, and he reaching out to each one of us. That really makes a lot of difference, to be honest. But yeah, your question.
Oh, yeah. First of all, thank you for the panel. It was lovely to hear your views. I think someone in the panel earlier mentioned that they were asking a question about our policy changes keeping up with innovation. So I kind of want to take a step back and want to understand from the panel that how are we, first of all, even evaluating these innovations? Like, of course, the metrics for evaluation of technological innovations in healthcare would differ in public sector, private sector, even from the perspective of policies, right? So how, one, are we evaluating them? And two, have there been instances where after evaluation, the evaluations have either been extremely wrong or extremely right? Have they been worked out in the favor of your respective professional endeavors, or have you noticed that they have not met the expectations?
Hello. It was a lovely panel. My question is actually to Dr. Gupta. You talked about the limitations of the 5-year vision that political parties usually have in power and how we need to have a long-term vision. I believe that youth of today is obviously an important part if we were to have a long-term vision. And we see the institutionalization of youth voices in platforms such as the United Nations. Even WHO now has the WHO Youth Council, and they have been pushing for the Youth Delegates program. But unfortunately, with the Indian bureaucrats, for example, at the World Health Assembly at COP29, we see a resistance to engage with youth. We do not see an open dialogue or a revolving door for youth. So how do you think that we can work towards that? Thank you.
So we've had 3 questions. Oh, okay.
Hi,
Shoot.
this is Ravinder. I'm from Siemens Healthineers. So absolutely great panel. I think great ideas came out as well. So just, I wanted to highlight the fact because I think Harkash evaluated to access to care, right? And Prashant also mentioned about prevention, right? But the question here is, are we as a government and as a country equipped to pick up, diseases at the stage of a PHC, right? Are our PHCs sufficiently equipped, right? Today we have AIMS, and Vineet referred, you have AIMS in many of the states now, right? And those are, institutes which go for high-end equipments and all. But prevention doesn't need high-end, right? So are our policies catered to that as well or not?
More of screening and stuff.
Yes, because that saves the cost a lot, right?
So we have exactly 2 to 3 minutes, and many of my panelists have to leave. So I'll probably start with you since you have to leave immediately. Vineet, I'll come to you on the innovation part because, where do you really stop that innovation and say whether it's working, not working? How do you discard it? How do you pursue it further? So that's the question for you. But for you, sir, in terms of engagement with the youth and limitation of 5 years vision?
I think there is...
And all stakeholders together, as she was mentioning.
So I'll start with her. So, one of the things that you talked about the system. So digital health will only work when there is a system. So in fact, on the Global Digital Health Summit, the first session will start with fixing the broken health system.
Absolutely.
If you apply digital health to a broken health system, you will get broken digital health. So that's the first understanding you should have. And that's what we're trying to address in the Global Digital Health Summit in September, is that first fix the healthcare system, then apply digital health, or it will fail. Anything multiplied by 0 is 0. That's one. On the youth part, I think there was a complete youth panel headed by IIM Raipur for the government. See, as I think someone said that everyone is unhappy. In a large forum, if your group doesn't get a seat on the table, you'll be unhappy, very likely. But it is not that youth were not part of the delegation. There was a Youth 20 hosted by Anurag Thakur under his leadership at that time, and there were voices. Well, on the bureaucracy, I would agree with you because I am also the unhappy guy on the bureaucracy side, and I have always voiced it publicly. Unless we get rid of them, I would say that line, or change them, I'm not going to see much changes. I mean, my vision of Viksit Bharat doesn't get done with bureaucrats of the current times. There are a few very good ones, but majority of them are, I think, drawing and pulling back the country. So unless you all keep raising your voice, we all keep raising a voice in the system, outside the system, it's not going to change. But I think for me, if country has to become developed country, 2 things have to change: bureaucracy and judiciary. Thank you.
Vineet, on innovation.
I'll take leave. I have to run for a meeting, and I don't like people to wait for it. Thank you.
Thank you. Thank you. Thank you. Yeah, go ahead.
So, to the point of innovation, I think you mentioned about innovation for the rural segment and innovation for the urban segment. Somehow, I feel that it is not that any company will probably develop any technology with any particular segment in its mind. The technology is available for addressing whether the disease burden or whatever. However, adoption of technology is something which is a concern. And I'll give you an example, We have developed an MRI, 0.55 Tesla MRI, helium-free MRI, which brings down the cost of the MRI significantly and can be deployed, in tier 3, tier 4 cities or under-penetrated areas. What we have been trying to figure out with the government is that today there is a government scheme which, kind of reimburses a certain, category of MRI. And we are trying to move the needle that if this category can be included, because then this will definitely have a much vast, penetration point of view. But then there are so many challenges in adoption of technology at the government level that to bring that minor change from an X category to X-1 or whatever it is, because people have a mindset that we want the best when it comes to technology. Whether that best will work for the conditions they are in, nobody thinks about that. So we have worked on many PPP models also, where there is a doctor from the government hospital who will probably help in kind of devising the specifications of the technology for that project. And again, they will ask for the moon because they feel that but is that required for that particular segment where they are catering to, which they are catering to? I don't think so. So the point
the
is
ecosystem. So it's the overall ecosystem that's
yes.
That's
So it is not about the best technology or separate technologies, but what is suitable for that particular segment. I think that is a bigger concern, I would say.
Great. Thank you. Thank you very much. I hope you enjoyed the panel. You're taking a couple of points back home. Thank you for being a great audience, and thank you all my fellow panelists. Thank you very much. Really appreciate this.
Good afternoon, everyone, and welcome to our session, Public Health Diplomacy and Emerging Public Health Competency towards Consensus Building, Negotiations, and Multilateral Partnerships. It seems that we need this session now more than ever, right? In a very challenging world, we have the greatest opportunity to come together and just have this conversation and together trying to advance towards a more healthier and just world. So thank you for being here. I'm Laura Magaña. I am the president of ASPPH, which is the Association of Schools and Programs of Public Health in America. But I'm also here in my capacity of president of the Global Network of Academic Public Health Institutions. And the GNF is the one that is actually organizing this session. So I'm going to talk a little bit about a couple of slides just about the GNF before I introduce an incredible group of colleagues that are here for this panel. So the GNF is an alliance of regional associations of schools and programs of public health around the world. There are 7. These 7 associations, and the 7 associations belong to this global network. You can see here in the screen. All of them, of course, your region is represented. And we all together represented more than 500 institutions around the world in 100 countries in 6 continents. What's our goal? Because that has to do really with the topic of this session, is to enhance academic public health worldwide through mutual learning and collaboration between academic public health institutions globally in order to improve and protect the health of people and the planet. Our priorities are listed here: workforce development, advocate for public health education, climate change and health, ethics and codes of conduct, faculty development, and most importantly right now, public health diplomacy. So I have the great pleasure and privilege of having an incredible co-chair for this session, which is Dean Ashish Joshi, here with us today. He is the Dean and Distinguished University Professor of the University of Memphis School of Public Health and co-chair of this session. We also have an incredible group of panelists. We have first Dr. Matthew Brown. He is professor at the University of Memphis School of Public Health. We have the Ambassador Luis de Almeida Sampaio. He is chairman of the Coimbra Health Strategic Council, University of Coimbra. We have Dr. Ashu Grover, Deputy Director General Senior Grade at the Indian Council of Medical Research, and Dr. Ilona Kickbush, founder of the Global Health Center at the Graduate Institute of Geneva. So please, a round of applause to our distinguished panelists here. So the format that we're going to have is that each of them will give an initial presentation, opening remarks. After that, we're going to start a moderated discussion among us, but most importantly for us is actually the third part of this session, which is the dialogue with all of you. So please start noting your questions, your feedback. We really want to engage in a conversation with all of you in this important topic. So we're going to start with Dr. Brown, and he will be talking about framing our conversation and talking about the different types of diplomacy. After him, the Ambassador Sampaio will talk about what's the diplomatic perspective in this topic. Dr. Grover will be talking about, after Dr. Dr. Ashish Joshi, we're going to talk about the Public Health Diplomacy Summit that we had and some of the findings, followed by Dr. Grover. She will talk about sharing the right message with the different stakeholders, guiding evidence to policy to acting dialogue. And finalizing and really closing and really challenging all of us will going to be Dr. Kickbush. She's going to be talking about where is public health diplomacy going for the future. So with that, please join me in receiving Dr. Matthew Brown.
Thank you, Dr. Laura. And just as a start, how many people in this room are health diplomats? Just raise your hand if you feel you are a health diplomat. Okay, 2, 3, 4, 5. All right, I'm going to come back to that. So this is really a tradecraft of health diplomacy, and it's drawing on a few papers that I published over a decade ago and need more analytical activity and effort. And I hope I can enlist your help. So these views are my own. They're not representing the US government or the Department of State. These are based on my personal experiences working abroad for the US government. I spent several years working in China during COVID. I've worked in Ethiopia, in Cote d'Ivoire, and in Haiti, Mexico. And these are drawn from my PhD experiences in UCSD. I'm currently based in Washington, but continue publishing on global health diplomacy practice. And so I'm going to make 3 points very quickly. I'm going to identify competencies to advance public health workforce and to facilitate effective global health action, because that's what we want to do in global health, is facilitate global health action. And I'm going to present 2 relevant publications that need more analytical activity, and I hope I can inspire you to help update this material. But first, what is global health diplomacy? It's improving health while improving relations between nations. 20 years ago, you really wouldn't hear this term. Today, it drives academic journals, it drives public resources. The unit that I work for in the Department of State is the Global Health Security and Diplomacy Unit, and we're channeling great amounts of public resources around the globe. But this framework is new, and it needs more analytical work in order to have more effective action. So this is an emerging field. It has no standard framework yet, and that impact is that there's confusion when you're trying to design complex global health actions. And so to speak to some of this confusion, here's the first paper, Bridging Public Health and Foreign Affairs, because there was no paper defining a health attaché. And a health attaché is a representative of one government on health to another government on health. And so I was working in HHS, in the Office of Global Affairs, and we were the head of the US delegation of health attachés. We have a health attaché in the office, in the audience right now from HHS, the Department of Health and Human Services. But there was no published paper, there was no definition. So we published one and really presented a tradecraft model. How do you advance public health practice across governments? And so you can QR code that and take a look at it. It was published in Science and Diplomacy. But one of the elements is this pyramid of global health diplomacy. And it's really a cascade of actions, tools, and actors. So core health diplomacy is state-to-state action. So when I was assigned as the NIH director in China, we negotiated for a biomedical research agreement between China and the United States, state-to-state action. It was signed by the highest level representative for the US government and the highest level representative on the Chinese government. And that was really done by health attachés. And the tool is an agreement. The agreement was between the US and China and operated how to identify topics that would be mutually funded between NIH would fund NIH studies, the Natural Science Foundation of China would fund the Chinese studies, researchers had to get together, make joint applications, and then the funding would flow. Multi-stakeholder diplomacy is a little different. The Framework Convention on Tobacco Control, multiple states coming together. The tools that they use are different. They're going to be framework convention, a partnership agreement. It's a different type of tool that's going to be used when you have a state-to-state versus multi-stakeholder. And then the actors are governments, agency representatives, multilateral institutional representatives. So the base is informal health diplomacy. Informal is what you do when you're working on health and you're crossing a border. And so to ask the question again, if you're a health diplomat, if you're working on health and you cross a border, are you a health diplomat? Yes. Everybody's hand should be up. Yes, you are a health diplomat. Whether it's core, multi-stakeholder, or informal, the types of tools that you use are different. The type of actors that you're going to engage with are different. And you need effective action at all levels. So why is it on a pyramid? Because there's simply fewer actors at the very top because of the accreditation. In order for me to be an NIH director, I had to get a visa from the Chinese government that allowed me to represent NIH to the Chinese government. There's very few people that's a very high accreditation. But to be a university professor crossing the border and engaging in a health collaboration, there's going to be more of you. And then at the base, that's really the public, companies, everyone. So you need to facilitate global health action, you need all levels. And if one level is not working at the moment, you need to go to a different level. Just be aware that there's different types of health diplomacy. Okay, the next study, and you can QR code this and read it on your leisure, but this is mapping competencies. So we wanted to look at what were the competencies that made global health action more effective. And we looked at global health competencies. We borrowed from the American Society of Public Health Programs. Dr. Laura here is the head of, they have competency matrix for PhDs and masters. And then we had foreign affairs. The US Department of State has a foreign service. In order to be promoted in that foreign service, they have a competency network. And so we simply looked at the public health, global public health competencies and foreign affairs competencies and bridged them. And this is what we found. So just quickly, what is a competency? Competency is a knowledge where you learn a skill and you apply it at the same place. You apply it at the appropriate time. So if you learn from a book how to take out an appendix and you get really good at it by reading and reciting it, and then you walk into a cadaver and they ask you to take out the appendix, and you take out the appendix very skillfully, but then you walk into a patient's office and somebody complains of a headache and you take out their appendix, inappropriate application of skill. So that's what competency is. You need the knowledge, you need skill in a mentored environment, and then you need to apply it at the right time. So why is it useful? Competencies are useful because they standardize practices of skill. And this is something that we need to do more of in health diplomacy. So the call to action is recognize core, multi-stakeholder, informal, have different actors, have different associated competencies, but you need all of them. So these are some of our, Department of State has a public competency network for becoming a Foreign Service officer and being promoted, as does the American Association of Public Health Schools and Programs to get a master's in public health or a PhD in public health. And so by looking and comparing these, you can see there's some global public health needs more training in substantive knowledge of foreign policy, because in public health school you don't learn that. Leadership skills to get your PhD in public health, you're not necessarily going to be trained to be a leader. And foreign language skills. You can get through a master's or a PhD in some programs without having language skills. Again, this is 15 years old. So this needs to be looked at again. This type of information is stale, but has not really been updated. So for foreign affairs, health communication skills are incredibly important. And to be a diplomat, they don't teach you how to communicate in health. Public health analysis skills. For the ambassador during COVID, what does it mean that China is bringing vaccines? Is that a good thing? Is that a bad thing? How do we prevent transmission among the people in the country and the community? There are ways that science can provide those information, but unless public health communicators are communicating them to leaders, it's not going to be effective. And interpersonal ethical knowledge around public health communities. This is, again, not something you get in diplomat school. So here's my call to action. Just consider the papers published over a decade ago. They desperately need to be updated. These topics, we need to develop more durable competencies in global health diplomacy so that we can facilitate more effective global health action. We need this now more than ever. As governments are having difficulties coming together around trade, around border issues, it's incumbent upon communities, institutions, and health diplomats in this room to find ways to operationalize, standardize, find, design studies to really identify those gaps and fill them in. So thank you very much to my esteemed panelists. Looking forward to the discussion. Thank you very much to ASPPH for organizing this panel, and to Jean Joshi from the University of Memphis School of Public Health, who has funded my travel together. There's my LinkedIn. Feel free to reach out with ideas. Really encourage you to get engaged. Now, how many health diplomats are there in the room? Great.
Great.
People who came left,
Thank
you are
you.
now a health diplomat.
Thank you
very much.
Thank you so much, Dr. Brown. Ambassador Sampaio, please.
Thank you very much, Laura. Good afternoon, everyone. We have a full house today. That is very encouraging because it is also a very good indicator that we are going to have a very lively questions and answers session after we, all the panelists, deliver our remarks. I will be trying in the 5 minutes of my remarks to achieve 3 main objectives. First of all, to give you a very vivid, concrete example of health diplomacy from my own experience, to share that with you, then to share a thought about the international geopolitical situation we are living in, and then to make a point about a very important task, as I see it, in the context of that international geopolitical crisis, again, we are living through. So, starting with a very vivid example of public health diplomacy. Some 10 years ago, during the financial crisis that hit specifically some European Union member nations, including my own country, Portugal, I was ambassador in Germany, in Berlin, and Portugal had to be bailed out at that time by the troika of the international financial institutions, the European Central Bank, the European Commission, the International Monetary Fund. But the main lender of Portugal, in order to allow Portugal to gain momentum to overcome the financial crisis, was Germany. So it happened that at that time, the academic alliance that is really behind at the inception of the World Health Summit that we are witnessing today, the regional meeting of the World Health Summit here in New Delhi. The academic alliance, with a different name at the time, was at the very first steps of its existence, trying to gather a lot of attention and international mobilization for global health problems. And the main international medical institutions, very top tier, top level, were already engaged in that Champions League of the international global health community. A country as Portugal, living the dire straits of a financial crisis, for a country like Portugal, it would be extremely important to join that alliance in order to demonstrate not only that in what else was concerned, Portugal was a very reliable and prestigious partner, but also that we were willing to face the difficulties the social impact, the health impact of the financial crisis. And we succeeded doing that, creating a consortium around the University of Coimbra that I am here today representing, that joined the then AMATE Alliance, now Academic Alliance, profiting from that synergy to help Portugal to overcome the difficulties of the financial crisis. So you have, with the example of the consortium Coimbra Health, that encompasses university, hospital, and a cluster of pharmaceutical edge, very innovative companies, a good example of public health diplomacy in action. And I believe that that complements very well the more systematic context that Dr. Brown presented to you. My second point is also related to crisis, not the financial crisis I referred to, but the international crisis we are living through now. And the crisis is very complex, but very easy to explain. Since the end of the Second World War, we were living in an international rules-based order. And we all know the reasons why that international rules-based order is in a state, at least, of some confusion, of some uncertainty about its future, and even a lot of political analysts, political scientists, they believe that we are on the verge of a new world order, not necessarily based on values and rules, but most probably more based in spheres of influence and power politics. And we need to be aware of that. We need to try to anticipate that. We need to try to understand that we are living through a moment of geostrategic shift. And as it is always the case in history, those moments are also full of opportunities. It is not necessarily a doomsday perspective what the future will entail. Those opportunities need to be seized when we would be presented with them. And my third point, and that is the recommendation that I would give to you all based on a 40-year diplomatic career experience, living in many latitudes, in many regions, in many continents. For me, it is very clear that now more than ever, in order to profit from the opportunities that a new world order could bring, more than ever, it is indispensable to protect, to deepen, to preserve a healthy relationship with the United States of America. Looking from the European side and trying to deepen the transatlantic relationship, or from Indo-Pacific perspective, again, looking at the United States as an indispensable partner in our common future, in what the future will entail, not only in health, but also in all the other aspects related to economics, to finance, to security, to defense. So the big geostrategic landscape, either you look it from the European perspective or from the Indo-Pacific perspective, will need to protect the bridges with the United States of America and not to burn those bridges. So it is a very concrete geopolitical suggestion that, in my mind, will have a lot of implications in what public health diplomacy in the 21st century is concerned. Thank you very much for your attention.
Thank you. Thank you, Ambassador, for your diplomatic perspective and adding these very, very concrete examples. So, Dean Ashish.
Good afternoon. So first of all, thank you so much for the organizers, and to be honest, I'm very being humbled and privileged to be here with my colleagues. And thank you, Dr. Magana, for your leadership in this, and Ambassador for taking the time, and Dr. Brown for coming in, Dr. Grover, and Dr. Ilona. So thank you so much, and thank you for the participants. I think we want to leave a lot of discussion for your questions, so I'll just rush through. And to be frank, like when we looked at the paper of 2016 call to action, I thought that it's the time for us to talk about public health diplomacy. I put this slide because I'm not a diplomat. But to be honest, as Dr. Brown mentioned, we are all health diplomats. So which means I just want to give you a background that I'm a clinician who did his public health training and then did PhD in informatics, and I'm a dean. I think in every day-to-day life, we are doing some diplomatic work in some capacity. It's at the local level, it's at the national level, regional level, or the international level. So why public health diplomacy? There is obviously, as talked earlier by my colleagues, that there's an urgent need to talk about global health threats. Countries have different representatives who can come. You know, we have credentialed diplomats, but there are people-to-people communication which is happening, person-to-person relationships. And then those can play a very big role in diplomacy. Now, that could be a soft diplomacy, actually. Okay. The commitment to local, regional, and global cooperation. So as academics, we have a responsibility to advance knowledge, advance cooperation, advance science, and advance data-driven decision-making. Communicating complex and technical information is very, very critical. We live in the world of misinformation, disinformation, fake news. Is it going to go over? No, not at all. It's going to be there. So we need to train ourselves on how to respond to this challenge of miscommunication which is happening. And lastly, and not the least, but there is a lot of significant influence that can be done across multiple sectors. So if you want to influence health, you need to look at it from the economic side. You need to look at it from the trade side. Are we trained in public health to talk about those? Probably not. But that's the need of the hour, that we need to a little bit reimagine how public health needs to be looked at. And how will this be useful? There are 4 C's in terms of public health diplomacy. Yes, we do collaboration, we do coordination, we need cooperation, and we need communication. So if you want to do a public health project in an international setting, you just don't walk away with a bag and say, I'm going to do a project. You need some collaborative partners who will facilitate that. Another thing is we need to support sustained collaboration. So I think continuity, consistency, and persistence are critical elements that are required. We are living in a complex environment, and it's an ecosystem. Health is an ecosystem. So it's not just going to be looked at from one lens. We have to talk about data-driven. I want to highlight this. It's not narrative-based. It's science-based. For achieving fair, equitable health outcomes, and as Ambassador Louis mentioned, that we need to have collaborations which are both Indo-Pacific, transnational, or academic to academia. So academia has a role, significant role to play in advancing these equitable health outcomes. But before that, we also need to have trained people in workforce. You can't expect that, okay, without you just put in front of somebody and say, okay, now you speak up, and then somebody's saying, okay, I don't know, I'm not being trained to do that. And I think COVID was a very important example. Because of some gaps, there was some ability of avenues that were spread out. So I think traditional diplomats, I know we have here, but may not always be trained in health space. But often they make decisions on health. So we need to design agreements that have some health as a priority, not just economics, not just defense, not just security or trade. So health has to be also a priority at the table. Growing number of countries have become increasingly more engaged in health policy. There is a value of how we need to work with different stakeholders. Government to government relations, government to civic society relations, civic society to people relations, all are important. I just say that we need to identify what skills and competencies are needed. So if there are people who are from public health background, they need to know how and what kind of things we need to be trained in. Consensus building, negotiations, problem solving, critical thinking. Very few programs were identified in terms of what is being trained in that. So I think the need is, are we really equipping the students and the practitioners in that domain? So we were very fortunate that the University of Memphis, as a leadership, I want to thank the leadership over there who actually was able to support this effort to establish the first public health diplomacy lab. And to be honest, you know, I don't say this because Dr. McGenna is here, but I always say this, that if you have a good leader and you can count on them and say, this is an initiative I think we should, is there an opportunity to do something? She immediately came forward and supported. So I don't think that this could have happened without the support of ASPPH and Dr. McGenna. So really, this is very important. We can always talk in a room, but you need more stakeholders. You need people to rally behind this. So this effort has been there. And the first thing which we thought was, okay, what are we going to do? Okay, great, we've opened a lab. Now what do we do? So looking at the frameworks of Dr. Ilona, who has been doing tremendous work in the area of global health diplomacy, and Dr. Brown's work over there was a framework we identified. Who are the people who need to be public health diplomats? These are people from legal framework. We need intellectual technology transfer. We need management. We need policy people. We need economics, international affairs. Everything is integrated. And this has to be looked from the local to the national to the international stage. It cannot be just, we are living in a local environment. We need to take into account those local parameters that influence decision making. Very fortunate that in September, we actually did the first Public Health Diplomacy Summit. And we were able to get 15 countries representing across the world to come to Memphis with 29 experts. And over a 3-day period, there was an objective that was there to understand what we need to achieve about 2 things. One, how do we define public health diplomacy? That's the one. And what is the 9-point agenda that we need to finalize? We were glad that the summit findings was that there was a consensus over a 3-year period to define public health diplomacy. And we found it that it is a multidisciplinary field. We need people who are practitioners who can effectively communicate. They need to be trained in facilitating negotiations, consensus building, systems thinking, evidence-based. We need to look into community engagement, so human-centered approaches are critical. So this is a definition that came out after 15 countries were represented by 29 experts, so that there's some kind of an agreement between us. The last component was, what are the findings? These were very important findings because these came from the schools of public health largely, that what are the kind of skills that students and practitioners must learn. If we have a public health workforce who's getting trained in conflict areas, we need to train them in cultural sensitivity, visibility, advocacy. I'm not going to go through, but we have papers published around this. But this gives you an idea that there were over a 3-year period, 3-day period, we were able to build some key components of what is needed to be a public health diplomat. And this work, what are some of the resources? Are we training enough the people in these domains? Are we not training? If you look at this, some may say, okay, we are trained in certain areas, some areas we are not trained, but we need more experiential learning, real-world examples to apply these principles. This is a 9-point action plan that was identified, that a global health, public health diplomacy working group will be established. That was done. Public health diplomacy capacity building group needs to be established. We got the steering group together. How do we engage all the stakeholders critical from the schools of public health and beyond to really understand better what skills and knowledge and competencies are needed? Obviously, there needs to be a resource hub that needs to be created. And so these 9 points were being established. I'm delighted to share that in September, after the summit, we were, with the help of our all collaborators who actually took a precious time to come from different countries, we were able to publish the findings of the public health diplomacy. So it's basically, it was not just a talk, but we want to take it into public health in action, as you mentioned. So thank you very much. No one is safe until everyone is safe. Thank you once again.
Thank you so much, Dean Joshi, and for reminding us that we need to train our people in all of this. This does not happen just because we have the experience, but we need to train all our students. So thank you for that. Please, our next panelist, Dr. Grover.
Thank you so much. Very good afternoon to everyone. Respected August panelists on dais, and my friends, colleagues, and juniors, seniors, my mentors in the audience. This is really a wonderful opportunity to talk about the public health diplomacy at a global platform. I really thank Laura and Dr. Ashish for giving this platform to me and sharing some of the Indian government perspectives and have the field level challenges that how do we put up the right message with the different stakeholders as the public health diplomat. As Brown said that are we all diplomat? I too agree with him. Yes, we all are public health diplomats. Maybe in a smaller capacity, in a soft capacity or a hard capacity, the level varies with the, as and when we go that. So some of the key principles of public health diplomacy, the points have already been highlighted, but we need to put up the right perspective to the right stakeholders. We know that we have the governments, we have the communities, we have to connect the two with the right research questions, we have to connect the two with the right message, for which we need to take certain outcomes based upon how and whom we are going to convince with them. And that can be initiated when we have the right public health dialogue, with the right evidences, and of course supported with some of the matters related to technology and the integration of these competences which we have been talking about at a local, regional, national, and international levels. Talking something about my organization, which is Indian Council of Medical Research, Government of India is a funding agency to the various stakeholders in the country, to the research institutions, the universities, the medical colleges at a national and international level. So it has its 27 research institutions, which all we are the stakeholders. And these 27 research organizations are working with a multiple level of stakeholders, which comprises around 700 medical schools in the country, along with the private institutions. Apart from that, they're working internationally with the various other universities in US, Canada, Australia, France, and some of the parts in the African countries as well. If we see the budget of our organization, which has really doubled up in last 5 years, so this means that the dialogue of the research translational is really gearing up in the country, not only at a national level, but at a community level as well. And because I am representing one of the division of the extramural research division, which really has to have the highest level of competency to translate the evidence into the action mode. So that is how on the right hand you can see we have the national level projects, which are usually at the tune of the 30 lakh US dollars, and the lowest level of the research project, which is up to the tune of 2.3 lakhs US dollars up to a period of 3 years. So do we think that is this a sufficient number of years to put the translation of any evidence to any large level to action? I probably guess no, because we need to have the competencies of the diplomacy to be built it at the community level as well, because the evidence translation, which is the budget limit, will go and up to, but still we need to have, continuum. If I compare, our intramural and the extramural research program, the majority of the budget is going 60% to the intramural program, and I took out some data from the NIH as well, wherein we are in line, because NIH is, it's different kind of a headings which is broken up, but yes, our largest funding is going on the research component for this country. So this means budget is not a constraint for converting the evidence into the action. Coming to the stakeholders, yes, I have been really visiting and to the public health domain for more than 2 decades, and I have gone to the various parts of the country and in the globe as well. I had been to Portugal, where I had a chance to speak to the various leaders, where they were really trying to translate some of the epidemiological research findings. It's a long study which was being funded by McMaster University, Canada. We were discussing about the prospective urban-rural epidemiological study. But what does that study indicate? We were discussing in Portugal in last year that there are certain findings from the study that if we take the clarified butter, is this a protective or is this a risk factor for cardiovascular diseases? So we need to put those perspectives into the right language. How do we do that? So for a cardiologist, yes, the clarified butter intake may be a risk factor, but for those who are engaged into the physical activity more common, may be a protector as compared to the other kind of the refined oils on which the cooking is being done. So these are some of the messages we discussed. So now how to put this message into the right perspective, we have to craft the right message and bridge that evidence to policy, but who are our stakeholders? You need to know, are you talking to a government? Or are you talking to a peripheral health functionary? Because the message is going to be different. The content of the message is going to be different. If you're talking to a private sector, we have prepared the standard treatment workflows. If you need to talk to the private sector, they are going to prescribe the medication which they like to do that. But the government policies are a little different. So how are we going to do justice with that? Yes. Do we need to, customize our message as per those who are all stakeholders? And same is to the academia and the research organizations. Here are some of the glimpses which I recently in last 1 week had a meeting with the governments. You can look out on the pictures that the government highest decision making person in the state level took the decision in 15 minutes. Saying that, yes, these are the things which we are going to change in our whole scenario with the public health delivery perspectives, with the peripheral health level workers, with the mission directors and the providers and the private players as well, giving out the circulars to reduce and providing the resources available. We have talked to the grassroots level organizations as well, but the message again is going to be different. So we need to identify our stakeholders right in the beginning itself for whom we are going to do this public health diplomacy. And of course, we need to have the focus of our message rightly carved out for the governments. We need to talk about how much saving in the cost is going to happen, or how much is the economic burden if I put a COVID-19 vaccine to the whole program. If I am able to give the antenatal steroids to all the antenatal women at the risk of delivering the preterm baby, what is the cost? So we need to talk to the government like that. But if we need to talk to the community, they need to talk that it is going to save your baby if you give the antenatal steroid. So the message has to be quite critical and, giving the same thing to all. So here is that we need to carve out certain interventions, starting from reducing the neonatal mortality, from the preconception to the small and the sick newborn babies. But what intervention to be communicated to the different stakeholders at a different levels of your platform needs to be modified. So we need to really bridge this evidence to action gap by overcoming the barriers when we are having a dialogue, and we need to have to measure the success. Are we going in the right direction? Are we the right diplomats? Are we the best diplomats? Is our task done? We need to know that, and of course we need to have a steps approach and navigate the political realities way. We cannot talk about the measles and malaria at the time of the COVID-19. We need to craft the messages and look at the realities. We cannot talk about tuberculosis in America. We cannot talk about malaria in the US. We need to contextualize our priorities and the realities of those countries. So we need to overcome the barriers. We need to have communication like misinformation to be avoided, resource constraints. We can't say that provide HPV vaccine to every country when it is such a costly vaccine. Of course, yes. There is a political resistance is always there. We have felt in our country, we have a political resistance. They say that what is there for me, how I am going to gain it out, but it's all your message, how you are going to overcome those. And of course, India is not a small country. It has various, continents in its own country. So we really need to push back our cultural sensitivities and geographical barriers and topography while addressing the health diplomacy. Thank you so much, and thanks once again for the opportunity.
Thank you so much, Dr. Grover, for highlighting the importance of really crafting the message to the audience. Okay, please welcome Dr. Kickbush.
Well, good afternoon. I'm delighted to be here, and I'd like to since we've said this needs to be a multidisciplinary enterprise, tell you that I am a political scientist who, for a whole number of strange reasons, ended up in global health. And of course, political science and international relations has never left me. I had the fantastic opportunity in around 2003, 2005 to found the Global Health Center at the Graduate Institute, and our focus then, and then practically nobody talked about it, was global health diplomacy. And I started the very first courses on multilateral health diplomacy at that point in time. And it's fascinating to see how the field, you also refer to it, Matthew, has changed over these 20 years and the challenges that we face now. And my starting point actually is that we are in a totally new era of global health. We can't even fully define that era yet. We don't yet know where it's going to. And some of us are very negative about it. Some of us actually see fantastic new opportunities. And I'll be coming back to that in a minute, because it also relates to context and what part of the world you're in, whether you think history is on your side or whether you think your time is over. So if global health is changing, if international relations are changing, obviously global health diplomacy has to change and is changing, just as diplomacy in general is changing. And one of the key issues that has happened, I would maintain, is that health is no longer a unifier. When you were talking about this 10 or 20 years ago, you would say, if countries don't agree on anything, they will agree on health. Everyone wants health. Now, okay, they agreed sort of on a pandemic agreement, but if you watch those negotiations over the last 3 years, it becomes very clear how difficult it is in this point in time to reach an agreement on health. And I will come back to some of the issues that are driving that. The ambassador referred to the rules-based order. And definitely most international relations experts agree that that order is falling apart. And that we are actually witnessing an interface of different global orders that obviously all impact on health and in consequence impact on health diplomacy. One is that a new geopolitical order is emerging. The other is that a technological order is emerging, and we can't even grasp that properly yet, who actually has the power. And we see a new economic order and trade order, etc., emerging. That, of course, has implicit an enormous power shift. And so at present, what we're experiencing is not value-based diplomacy as much as we would like it. We see a growth in transactional diplomacy. We see an increasing negotiations based again on national and not common interest. And that, of course, impacts on health very significantly. And so this, of course, also makes international agreements, I already referred to the pandemic agreement, but also in other areas, more difficult. Now, part of that is an enormous power shift. And if you're in the global south, I'll just use that term, you are incredibly more optimistic than if you're in the global north. And many of my colleagues who are here from the global north have commented on the optimistic feeling they have at this conference. And of course, yes, you know, India is on the rise. And India is at the center. India doesn't belong to any of the blocs. Mr. Modi manages to talk to everybody. And he is developing a type of diplomacy that nobody has a name for. And so just being here and watching, you of course will also get traditional security policy after the dreadful events in Kashmir, but you see something different is happening. And you still see, because while I'm here, I sort of read European news, that reporting on this still hasn't, gained the kind of attention it should in other parts of the world. So this power shift is very clear. I agree with the ambassador. Yes, the United States has to be part of this game. And sadly, at present it said goodbye to the World Health Organization and a range of other global health issues. But the difference is the United States also in global health will no longer be the hegemon. It also does not want to be the hegemon, at least under the Trump administration. So we're seeing a shift here, which those of us who did global health diplomacy the last 20 years, even though one perhaps didn't talk about it that loudly, but the fact was, there was diplomacy, 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 and there was hegemony. And, with that hegemony, you could do as much diplomacy as you wanted. If the hegemon didn't want, then, well, thank you very much, goodbye. So we're seeing, a shift of that power. We're seeing the Global South define agendas. We might see a shift of values. Think of the different types of interpretation of human rights, for example. And we see the creation of new structures. Think of the various new investment banks, etc., that have grown out of the Global South. And think of the last G20 meetings. Maybe some of you were involved in the Indian G20 activities, also on global health. I was lucky to be in Goa at one of these meetings. And it was totally different. And you see the BRICS setting a health agenda, the G20 setting a health agenda. You've had 5 chairs of middle-income countries of the G20 now that, are consistently shifting the agenda. And, if the global health doesn't listen, well, guys, we're going to build our own shop. And this is happening. It's a fact. And, those shops grow in power, in what they have to offer. And that changes the negotiations. So, interestingly enough, all these new types of regional or political alliances, including the BRICS also, actually have set health agendas. It's very interesting. And actually the BRICS just recently at their Moscow meeting made a long health agenda, including science, diplomacy, and research. And Brazil has said, we are going to continue this. So, if in the traditional rules-based order, you're not going to listen to our voice, well, guys, we're going to go over there, and you're not going to be part of that discussion. So this is what's happening. And the question is, how does global health diplomacy adapt? Will global health diplomacy be, as one film said, everything, everywhere, all at once, but not really talking to each other, but developing, one's own agenda and taking that forward. The last point I'd like to make is that it's not only, this power shift and all the other changes I've spoken about, it's also about what is being negotiated. Because in my view, one of the greatest weaknesses of the old global health model is that it was based on development support, donor support, charity, in the widest sense of the word. And we are moving away from that. And that means that quite different agendas are being negotiated. And you could see that from the negotiations of the pandemic agreement. You know, what did they talk about? Supply chains, access and benefit sharing, loss and damage, you know, all kinds of concepts that had never entered the health arena before, and which are very, very significantly related to equity issues that the Global South was absolutely adamant on, and are linked to economic development and trade and issues related to that. So it's no longer, will you fund us, and will you tell us what you are willing to fund? But it's a question of, hey guys, what are we willing to share? And how are you willing to be a partner in this game? So this means a very, very different kind of health diplomacy. And that is, in a final way, also related, and you alluded to it a little bit, that the very tools of health diplomacy have changed. So the digital has, of course, entered the diplomatic world. It's related then, it's more difficult to do global health diplomacy because of the mis and disinformation. It's much more difficult. But you know, if you're that poor health diplomat, I mean, the one in the mouth, not the one everyone here, but the one sitting in the negotiating room in Geneva, you have much less leeway because your capital, you know, expects every minute a report on what is happening in the room and will tell you what you are able to negotiate. So it's no longer the Vienna Congress, you know, where for a year you were sort of talking to each other, but no, it's, you know, it's a much tighter area, and that relates back to the interest-based notion, because you are not going to give in on our interest in the room. So global health diplomacy has become more difficult, has become more controversial, more conflictuous. It's much more difficult, but that's why we invented diplomacy. And that's my last word. What I actually think fascinating is that now, where the conflicts are there, where the power shift is there, where, you know, the difference of interest is there, that's when we need diplomacy. You know, if we all understand each other, why bother? And that was the case in global health for a long time. You know, we all sort of wanted the same thing. And, you know, give more money to the Global Fund and support WHO a little bit and this, that, and the other. And suddenly, something else is happening. And that's when we need diplomacy, and that's why you should be global health diplomats. Thank you.
Thank you so much, Dr. Kickbush. Very insightful thoughts and challenges, and really the current moment. You picture a fascinating current moment, because yeah, it's tough, it's challenging, it's shifting, but it's on us. All of us are actors, not just observers, are actors in this world, and we need to really move forward. And that's exactly what we're going to be doing in the next half an hour that we have, which is engaging with all of you and all the panelists. And in order to do that, I will ask Dr. Andine Joshi to moderate the discussion. So please interact with our incredible panelists, and thank you, all of you, for your really incredible opening remarks.
Thank you so much. I think I'm going to stand if it's okay. You know, I feel a little bit more comfortable this way. I think, like, to be honest, I think what we need to do is we want to straightly jump to the audience, if that's okay, and just open the floor. If you have any questions specifically to what you have heard so far, give your insights. And I think that's a little bit change in our agenda of how we wanted to do. But I think we want to really make this a more like a dialogue and a more like a engaging, enriching discussion. So I'll leave the floor here, and if there are any questions, we start it from there. Yeah, okay, go ahead.
Thank you very much for the interesting session and also for all the expertise and for sharing the very important thoughts. Maybe a quick comment and maybe question to the panel. I think I agree that we need a model for health diplomacy, but also we need a governance. We need an agreement, and I think historically, as being said, we have a global, sort of like a global governance, sort of, probably through the WHO Health Assembly, maybe through the United Nations General Assembly, sometimes that health topics move and being discussed at that very high level. But within that and beyond that, we need also a governance model. Who should be on that panel that govern health diplomacy? Because that's also important. And here could come the voice of everyone. So as you rightly said, Global North, Global South, and many other stakeholders, and not only governments, where diplomacy usually links somehow with government representatives, but we need also the stakeholders, the other stakeholders, the non-government organizations, and also civil society. So any thoughts about how we could really better governing this health diplomacy? Thank you.
Yeah. So the one paper I published about 15 years ago really looked at core health diplomacy, state to state, multi-stakeholder, multiple governance, and informal. And really, you need all of them, right? You need the government, you need some type of multilateral framework to be able to bring governments and institutions together, and you need, everyone else. And that's why it's a triangle. That was an attempt to show the numbers of actors. Really, there's a finite few maybe that are representing all of their countries, but you actually need multiple levels to be able to be engaged. I couldn't agree more, but it's not, it's all, maybe each level needs its own type of competency framework, and that's more of what needs to be developed, and really understanding that you need all levels to be engaged. And if one level is not functioning, then engage another level. Especially when you're seeing a block in one area, that's the call to action, is to try to engage other levels. Maybe others, and Dr. Kickbush.
Just one or two points here. First of all, there is, and given the new issues that I've mentioned that are challenges in global health diplomacy, it needs diplomacy communication with the private sector. And we saw that during the negotiations for the pandemic treaty, that, for example, access and benefit issues were being discussed without discussing with the industry, sort of saying, well, you better deliver and we'll tell you what to do. And that became incredibly controversial, also, of course, because countries with big and strong industries were not willing to move one bit. We, from the Global Preparedness Monitoring Board, of which I am a member, we then organized a forum where we gave the industry a voice. And the rule of the game was the industry would present its positions, questions could be asked, but it was not, sort of, but I, Germany, think, or whatever. And we were actually told, we did a similar one for non-governmental organizations. And just the fact that the industry put forward its points, you can be cynical about it or whatever, but it made a difference in the negotiation. And, in the end, an agreement was reached. Now, in health, we are used to, well, certain industry actors, meaning, pharmaceutical, et cetera, but we are not ready for the tech barons. We are not ready for that area. Actually, so far in global health, we have been very, very nice to those people because they have helped us, in pandemic control, et cetera. But what we would actually need, if you ask me, is an international agreement on the responsibility of the tech industry in global health, particularly in relation to data and other things. But that industry is stronger and bigger and richer and more politically influential, as we know, than any pharma magnate has ever been able to be. So there is a big, big challenge, and we'll need formats. We will need new formats to be able to take that kind of agenda and decision forward. The old UN format, member states only, will not provide us with the answer. I don't know what the ambassador thinks here.
Thank you, Ilana. Thank you very much. The traditional thinking about governance, international governance, the idea that states, governments, even though they don't have permanent allies and permanent adversaries, they have permanent interests. They would not be able to create the kind of governance you are hinting at. So in order to bring along the other stakeholders, be it from the industry, from the technological side, the civil society, we need a different approach. That different approach will no longer be based, according to all the indicators, on the San Francisco Charter that bases the United Nations. But how to replace that without creating major shifts that then would make international relations utterly unpredictable. So that is the big question mark. So it is a huge task for diplomats, knowing that the exercise of external policies will no longer be done only following the program of a government or of a certain constituency or even a group of governments like the European Union. We will need not only to take into account the Global South, but also to take into account the other major players out there that are not under the control of a government or a parliament or an international organization. So it will be an extremely interesting but very challenging couple of decades ahead.
Yeah, I had one follow-up point that Ilona, you made, what to do with the tech bros. What to do with the tech bros. You know, that most of these AI companies right now are raising huge amounts of money. I think the current valuation of Palantir, Microsoft Bing, what's the big one with Claude? Anthropic. Anthropic is worth $53 billion, private. Huge amounts of funding. Now imagine trying to look at the needs of a government in a diplomatic sense. You have to find areas of agreement and expand them, and find areas of disagreement and diminish them. Now imagine having that type of large language model that can know all of the countries on a continent, all of the subcontinent policies around civil society, around academia, the governance structures, know all of them at once, and then use the engine that is very much in the private sector, driving, product development, but use this use the tools of health diplomacy to bring countries together, to find areas of common understanding and exploit them. I think that's an area that hasn't really been developed yet. We haven't approached the tech brothers to see if we can appeal to their greater angels, to see if we can find areas to expand, because knowing all of the governance structures of all of the public health, civil society, that's something that wasn't possible before this revolution in AI. So that's another call to action, is to really find areas where we can use the drivers of AI that are driving market to be able to bring countries, communities, societies together around common public health challenges. Because it may not be governments first, right? It may need to be led by scientists, by academics, by civil society. But using those powers of AI, I think, is something that hasn't been exploited yet and maybe could be in the future.
Hi, I'm Pooja Jha, Editor-in-Chief of the Lancet Regional Health Europe from Munich, Germany. And thanks for the very interesting discussion. So my question is in relation to the research funding. We know that this total loss of funding for climate research, equity, diversity and inclusion research, sex and gender studies. So now there is this huge amount of loss of funding. Where is that money going to come from, and how is global diplomacy or public health diplomacy going to work to enable that money comes in to sustain the research?
Yeah, so maybe I'll just quickly chip in here. I think it depends, like, how we see. I think the work is going to continue to be done. Let's put it that way. I think we just need to reframe the language and the terminology and the vocabulary, how we are going to use it. So public health, somebody may think it's an economic impact. And economic impact doesn't just mean return on investment of how much money we are putting to improve health outcomes. It's about creating jobs. So I think we have to start rethinking a little bit about how we put that context. As earlier mentioned, that the traditional model of thinking may not be fully applicable, but I'm just speaking from the academic side of the things. But our core values and principles of what we are as public health professionals continues to be done in that way. So I think we need to a little bit think, and I think, to be honest, as the ambassador mentioned, this is also an opportunity for innovation and a little bit thinking out of the box here. And as when in academic we are being asked, like, okay, where the money is going to come? I say, there's no storm which is permanent. There's no storm. So we need to just find ways, and I think as much as you close some doors, there will be some which will be opening. So I feel a little bit optimistic. That's just my view. I may be wrong on that. But I love Dr. Magenia to have some.
Yeah, but also,
Yeah, just a short comment though. I mean, all this is happening, but other things are happening too. I don't know that China has reduced its research funding. I have not heard that India has reduced its research funding. I've not heard that the tech brothers have reduced their funding, to develop stuff. So I think also we always have to keep this shift in mind. And the fact is, others have not reduced their research funding because they know it is the basis of their economic development, and it's a power base, basically. And so, that's why some of us find it hard to understand what is happening in the United States, because part of the competition is knowledge, science, technology, and everything else. So, if one country stops doing that, others will follow. And in terms of not following cutting, but in saying, well, here's a nice shift. Now, European research agencies aren't used to apply for money in India. They will start. They will start. So I think it's also consistently keeping in mind, also we don't want the world to remain stable like that. We want more research from other parts of the world. And we want, in this case, coming from Europe, Europeans to be the partners of India and not the other way round. So I think, that is something where we should grasp some of that opportunity and develop models to think that further.
No, I totally agree. I think that we need to just to be holistic about the thing and not just focus on one specific issue. I think that just the environment is changing, so we need to be just open. When one door is closed, I'm sure there's going to be another open doors. And in the United States, we are really changing the narrative. So, and I agree with you. We are continue doing the job. It's just in a different way. So I think everything is going to change, but I think that we will find the money to continue doing things. And also we're going to start looking more into sustainability within the countries. So the model definitely is going to change, but we are changing the model already. So thank you for your question. And let's continue because there's a lot of questions, I think.
Okay, good afternoon, everyone. I'm Dr. Abdullah from Yemen, WHO TDR scholar in Aitar University, and WHO IMRO Youth Council. As public health diplomacy to ensure public health for everyone, so how we can ensure to build strong alliation for all to ensure the public health diplomacy without to avoid escape and say bye-bye as she says, as USA make, to ensure the future collaboration and no one escape in this. For example, like for research list fund, for Yemen, for example, there is a polio, or for Corona, if spread in one country, they will affect the other countries. So we have to ensure no one escape from this.
Hi, I'm Priyadarshini. I'm from the Center for Social and Economic Progress in Delhi. And my question is to the panel in general. I think an important aspect of health for all is the public provision of health. And that essentially is an ideological project. Yesterday we were at a very interesting discussion where our Right Honorable Helen Clark said that at the national level, it is publicly oriented, committed politicians who are getting the right legislation in the room. And once that's in the room, then it sort of stays, and it's very difficult for politicians to undo it. So in this context of creating this sort of ideological support for public provision of health, which in many countries is facing a lot of pushback, what is the role of diplomacy, if at all there is such a role right now, given that the world is a different place now? Yeah.
Thank you. Roy from the University of Global Health Equity, Rwanda. We are trying to develop a public health diplomacy course with Makerere University, Africa CDC, and with AMREF. And my question to the panelists is that you showed us a list of competencies, which Dr. Kickbush showed us. Do you think that the Global South would need a different set of competencies? Because for us in the Global South, in Africa, the hegemon just keeps changing, isn't it?
Thank you. Thank you for the floor, and then thank you for the insightful panel discussion. My name is Gafa. I'm here with the International Pharmaceutical Students Federation. We represent 500,000 pharmacy students and recent graduates worldwide, and we are also Youth Lab, a civil society organization. So after an insightful discussion and an insightful explanation, especially from Dr. Joshi, you already put like the action plan for the public health diplomacy for the upcoming years. My question is actually about a meaningful youth engagement, as we're also approaching like 2030 agenda, and then like also SDG 3 is actually being reviewed this year. So this year I think it's a super special year. So my question is actually, how can actually youth being involved in, especially in the topic of public health diplomacy? Because I believe, as mentioned by also Dr. Brown, that 20 years ago, public health diplomacy wasn't a thing, and now we got this new chance. And then like I believe in like 20 or 30 more years, like me as a youth might actually be the stakeholders and also like the decision makers. So I think that would be meaningful if you could explain more about meaningful youth engagement, particularly in public health diplomacy domain. Thank you.
Well, I'll start with the youth question and to say, set the agenda. Don't ask us. Why are you asking me? I'm old. But if you ask me, I'll say, you are the digital natives. If we say we need a kind of international agreement in relation to data, technology, social media, and whatever, and health, and responsibility of the tech industries in this context, then I'm looking to you. You understand that system, you have to live with it. It's not just an issue of privacy, it's an issue of data solidarity, it's an enormous issue of digital determinants of health and whatnot. So, I'm looking to the young people not only to use social media, but to actually say, what kind do we want? How should this be regulated? How can it help move health agendas forward? So that would be my thing. Act. Somebody said act. You set the agenda. And that's what young people should do to drive for the future. That would be my.
Thank you very much. So on the same vein, not only the question of leadership from the global south, but also the question of an important contribution to accountability. Because when it comes to the point of building a new world order based on a set of rules that we don't know yet how to define them exactly, we will need accountability. Governments, parliaments, democracies provide that kind of accountability. When it comes to industry, when it comes to the tech brothers, the question of accountability is much more complex, much more difficult to deal with. So we will also need input, suggestions from the South in what concerns ways and means to create that accountability when it comes to industry and technology. My other point is really to stress the opportunity perspective. Global health is an economic opportunity, not only economic opportunity for the traditional recipients of aid and funding when it comes to global health, but also, nationally speaking, for countries like the United States that will come to the conclusion, sooner or later, that public diplomacy in global health is a good basket for good investment. I am trying to protect the job of my friend Matthew Brown, of course, but that is only a drop of water in the bigger picture of the question that my answer entailed. Please.
I would like to answer to the question about the competencies and if the competencies should be different in the global south. Well, first of all, when we put together this framework of the competencies, all the world was represented there. We have colleagues from around the world, and we were thinking about really cross-cutting competencies that doesn't matter where you are, there are at that level that anyone can use it. For example, negotiation skills, analytical skills, communication skills. The way you implement those is the one that it makes sense, according to the region that you are based. But the competencies themselves can be applied in other contexts because they are cross-cutting as they are. And our thinking was that hopefully, because somebody else talked about the health, public health training, is that every single student of public health has really the skills, the knowledge, the competencies in health diplomacy. So hopefully we are working with our accreditation body in order to see if the health diplomacy competencies can be part of at least the MPH or the graduate programs. So everyone, all our next generations of health professionals have already developed the competencies in health diplomacy. Hopefully that will happen. And also we are pushing for an area of concentration in health diplomacy so we can have the researchers we need in order to, in the science part or in the science-based degrees. So we have the researchers that we need in health diplomacy to help us create the evidence that what are the, the effective techniques that we have to be implemented in this new era of health diplomacy.
Yeah, I'll say here one to your question on public provision for all. I think there's been a top-down approach and there's been sometimes bottom-up approach. What we need is a middle-out framework. The more data can be used for both advocacy and diplomacy. And that could put some pressure on the politicians in the room to make decisions that are not just driven by narrative, but also by some objectivity. I think what is really missing has been some objective assessment of what really the situation is. So I think bringing the data and the evidence to the table, despite no matter what, how much disagreements are there, I think it's going to put some political pressure on people who are making decisions that will make them accountable if they do not respond to the needs of what actually the data is showing. So I think that's a very important aspect, that we need to have both actors, as Dr. Brown mentioned, the top-down and the bottom-up. So I think there's a middle-out approach that we need to explore here right now.
Just to
30 seconds.
30 seconds, really quickly. I think the skills that you can get as a public health professional at the master's and the public and the PhD level are excellent, but learn the governance structures of foreign affairs. Learn what the diplomats learn. There is also a pathway to become a diplomat. So those, they actually intersect. And we don't actually train people to be a diplomat and then a public health professional. Public health professionals kind of learn to be a diplomat. Diplomats learn to be a public health professional. Until we create a foreign health service, which we don't really have yet, we need, diplomats they're gonna be savvy in public health and vice versa. So get those competencies while you're in your school mode and early career mode. Thanks.
Thank you so much. I think I just want to first of all acknowledge the panelists and everybody, and Dr. McGanna for your final remarks.
Yeah, thank you so much. It's already 3 o'clock. So first of all, please join me in welcome. I mean, thanking all our amazing panelists. So thank you. All of us are going to be here in the summit, so please continue the conversation with all of you. Thank you for being here, and just maybe a closing sentence that I really, really appreciate this conversation, because all of us are part of this new and shifting world, and it's up to us what we want in the future. So we are really optimistic about this. Is a great opportunity for all of us and for the young people who are here and around the world to just be part of this new order. So thank you so much for being so interested in the health diplomacy, and we hope to see you in the journey. Thank you.
Thank you very much. Yes?
I'm Jyotsna Sharma. I'm taking care of branding and communications at MIMS University.
Very well.
Yesterday already.
Very well. Very good.
Yeah, I want to introduce myself. My name is
very
Madhu
much.
Kaude. We are from Nepal. I am the pharmaceutical supply chain partner for
I'm going to give you my pharmaceutical-related card.
Oh, that's right.
And also that anybody else.
Hi, good afternoon, everyone. Please be seated. We'll start in a couple of minutes. Name card here? Sir, Archana. She is not here. उनकी जगह डॉक्टर पूजा सहगल है. प्रिंट हो गया ना? सर हम करवा दें. कितनी देर चल रहा है बस 2 मिनट. मेरे को एक सिग्नल कर दो. I think we'll make a start. Please get to your seats. We are just waiting for one name tag here because there is a last-minute replacement of one of our panel speakers. But I think we'll make a start. I've been told it'll be here in a minute. Yes. Okay. So thanks everyone for joining us for this important discussion around amplifying the voice of the Global South. It's my real pleasure to have esteemed panelists with us who come from various different sectors, but all of them are truly passionate about improving the access of technology, improving the access of knowledge, information, and all the experiences that the world has for the Global South. So that's the underlying passion that every speaker today has. I'm going to also give you a little bit of context setting here before one of the panelists does a proper context setting. So just for the panel itself, the idea here is that we want to see what is it that the world can do to improve Global South participation in global agenda. More often than not, we realize that Global South is either missing from the global discussions when the important agendas are being framed and shaped and decided and delivered. But going forward, we are seeing an increasing appetite from the Global South countries, especially in the current environment where the funding has changed hugely. that Global South wants to become more sustainable, more independent, more pragmatic about taking the ownership of their own issues and delivering them for their own betterment and the betterment of their citizens, children, and other fellow countries that are nearby. So there is a lot of information that exists in public databases. There is a lot of global agenda, global policy being formulated. But what we have seen most of the times is that the policy that is being formulated is not easy to read. And therefore, Global South misses out on important pieces of information and important pieces of the dialogue where they can contribute and eventually shape the discussion and shape the outcome so that the outcome is relevant for application in the Global South. So today, we're going to be also launching a report of a platform called Global South Research Collaborative, through which we have launched a program called the Simplified Series, which simplifies very complex information of big political pieces that are being discussed. For example, the Pandemic Accord, which just got agreed and will hopefully be launched at the World Health Assembly, and also about COP, which is a UNFCCC framework, which a lot of us talk about. I've heard a lot of people talk about COP in many of the rooms, but if you actually asked many of us who understands what goes on in those COP meetings, many of us would actually not know, especially the Global South audience. So we try to simplify that information for the benefit of the Global South so that they can start understanding it, they can start participating in the dialogue. So that's one of the things that the Global South Research Collaborative does. And we'll be launching our report on COP, Health at COP, UNFCCC. So now I have the pleasure of inviting our panelists first to the dais. I would first like to invite Dr. Shishendu Mukherjee, who is the Managing Director of Vadvani Innovation Network. Please welcome him with a round of applause. He brings over 30 years of experience in pharma companies and also has worked extensively with government and global philanthropic agencies. Before taking the role at Vadvani Foundation as the managing director of the foundation, he was the mission director of the Grand Challenges India program, and that's when we also worked extensively. I had the pleasure of working quite a lot with Shishendu and really enjoyed his company. So Shishendu, thanks for coming and welcome. Next, I'd like to invite Professor Amit Kapoor, who is the President and CEO of India Council on Competitiveness. Amit, thank you. Please, a round of applause for Amit as well. He's also the editor-in-chief of the Thinkers magazine, an affiliate faculty for microeconomics of competitiveness and value-based healthcare delivery courses at the Harvard Business School as well. So very well read, very well respected figure in the Indian government diaspora as well. We have the pleasure of having Amit with us to participate in this dialogue. And then I'd like to invite Dr. Zelalem Tefesse, who's being very humble and sat in the sort of third last row, but please welcome him with a round of applause as well. Dr. Zelalem is the chief of UNICEF office for Andhra Pradesh, Karnataka, and Telangana, which are three very important states in the southern part of India. He's currently based in Hyderabad. He's a surgeon by training and a public health specialist with over 20 years of experience, and he's worked in various different geographies, including the Pacific Islands as well. So he brings a wealth of experience to the podium today and will contribute to the discussion in a very enriched manner. Second last, I'd like to invite Dr. Monica Kocher, who is the advisor of health at the Dakshin platform, which is an entity that looks after India government's affair of India for the World program. They were very nicely shaped during the G20 India presidency, and they're trying to deliver a very important agenda of making sure that the South-South interaction and the Global South exchange happen. So, Monica, welcome to you as well. A round of applause. And then I'd also like to invite with pleasure Dr. Pooja Sehgal, who is a marketing communication professional with over 25 years of work experience based at the Gates Foundation. Please welcome her with a round of applause. She currently, I think, Dr. Pooja Sehgal heads the nutrition communications for the Gates Foundation India office and also participates heavily in the South-South agenda and strategizing of the agenda at the Gates Foundation, which is something that the foundation is really trying to pick up on. So welcome, Dr. Pooja Sehgal as well, and look forward to your thoughts. So without further ado, it's my pleasure to invite all the panelists to just quickly first launch the Global South Research Collaborative report on the health at COP before we get into the panel discussion. Please get ready with a photo opportunity as well. Thank you. Sorry, forgot to invite Neeraj to the to the podium. This is your platform, so you are here. So thanks for joining. Okay, so before we get into the panel discussion, I'd like to invite Dr. Pooja Sehgal to set the context for the panel discussion. I believe you have all the readiness for that. Thanks.
Thank you, Ankur. And thank you, everyone, for attending the session today. I'm going to start by requesting for some grace, because this is not a session that I was supposed to be in, and this was not a context setting that I was supposed to be giving. So I am actually a replacement today for my colleague, Archana Vyas, who's unfortunately unwell and could not make it for the panel discussion today. So the conversations is really around the Global South, and like Ankur said, the whole element about the participation and the need for the Global South to be represented equitably and in a manner that truly represents the asks of the Global South when it comes to development issues, health issues, and overarching change that we want to see in the world. This is a very, very important topic, and especially now in this time of global uncertainty, when we're almost at the cusp of a shifting global order. And this is very likely to also completely change the shape of the future global health and diplomacy. Historically, global health architecture and diplomacy have been largely shaped by decision makers in the global north, who have been often very far removed from the communities that are typically the most affected. While we have seen remarkable achievements over the past decades, such as eradication of smallpox, almost the near elimination of polio, reductions in maternal and child mortality, and the development of many, many life-saving vaccines, there continue to still be many, many challenges that need to be addressed. And while we see these successes, we are also reminded of the urgent need for continued progress and innovation to be driven in greater part by leadership coming from the Global South. The insights and expertise of Global South nations are typically grounded by their proximity to the challenges that they face. Like Ankur mentioned, there's been this disconnect between the understanding of the problem and the way the solution's being created because of the distance. And here, when we talk about the Global South representation, they're essentially very, very proximal to the challenge. They've actually developed lots of innovative solutions as well, and we are increasingly seeing the impact of these efforts. Many countries have also already begun financing their key health programs, such as immunization, from their own domestic resources. As such, the Global South cannot just be a recipient of aid, but actually an active and equal partner and contributor to the global health development agenda. Challenging the status quo, the Global South has long demanded a greater voice and a rightful seat at the decision-making table, shaping the policies and priorities that directly impact its populations. More than 7 decades ago, the Bandung Conference actually laid the groundwork for this vision, bringing together Asian and African nations to advocate for a more equitable global economic order and sparking momentum for South-South cooperation. This vision of South-South cooperation in the years that followed has seen the formation of powerful, influential regional groups such as the BRICS, the IPSA, the AU, BIMSTEC, and many others. These platforms actually enable the Global South countries to set their own priorities, grounded in local context, local requirements, and local expertise. Global South countries are already working together to share knowledge and learnings while improving policy coordination for mutual development and to achieve collective and shared goals. There are recent examples such as India and Indonesia signing multiple MOUs across key sectors, including digital infrastructure and health. Indonesia and Nigeria's health ministers connecting on expanding healthcare access through stronger public-private partnerships and vaccine production. And very recently, the Abu Dhabi Crown Prince's Court spearheading efforts to eliminate neglected tropical diseases. Today, emerging economies across Asia, Latin America, and Africa are expanding their influence and asserting themselves on the global scene, thanks to innovative health approaches and steadfast political commitment. As an example, India, for example, is taken widely, it's known as the pharmacy of the world, a reputation cemented by its COVID-19 health diplomacy through Vaccine Maitri, which helped protect millions around the globe. The lineup of 4 Global South G20 presidencies, starting with Indonesia, then India, Brazil, and now South Africa, has further strengthened these partnerships and positions, putting forth agendas that better reflect the pressing needs of the majority of the world's population. I'll share some recent instances here again. Under Brazil's G20 presidency, the country launched the Global Alliance Against Hunger and Poverty, uniting 148 members towards the goal of ending world hunger by 2030. Second, India and Indonesia again. India and Indonesia have both championed Global South initiatives to deepen cooperation on shared development priorities. A third example is the South Africa's Health Working Group, which will be hosting high-level meetings on tuberculosis, AI, and health financing later this year, with an intentional focus on building a global agenda that appropriately reflects the participations and needs of the Global South. We're actually now just 5 years away from the deadline of the Sustainable Development Goals. Yet a midterm assessment of the 17 SDGs and their 140 sub-targets reveals that most of the world, especially the low and middle income countries, are far from being on track. It is essential then to fully and actively engage the Global South to achieve the SDGs. Today we are at an inflection point where crisis also brings opportunity. The Global South's leadership is indispensable to shaping a new world order that can meet today's health and development challenges, and we are seeing countries take up that responsibility. We are all aware that the WHO member states made significant progress on the draft pandemic agreement despite the US temporarily withdrawing from the global health body. As Dr. Tedros said, this moment was not just a diplomatic success, but a reflection of resilience, unity, and unwavering commitment to the health and well-being of people everywhere. It marked a meaningful step towards health equity. The message I want to emphasize as we begin today's discussion is simple. While health challenges know no borders, the solutions unfortunately do. Geopolitical disparities continue to block the most vulnerable communities from accessing life-saving interventions at an immense cost. And that needs to be addressed urgently. As we navigate this turning point in an increasingly dynamic geopolitical landscape, we must recalibrate. We need new perspectives, collaborative strategies, and a reimagined approach to global health diplomacy, rooted in equity, inclusion, the leadership of the Global South, and the allyship of the Global North. Thanks.
Thank you, Dr. Pooja. I think you've really set the context really well that under the leadership of the Global South and annexure of the Global North. So I think it really sets the tone of today's panel discussion. My first question, just to kick off the dialogue, is for Professor Amit Kapoor. If I may start with you. For you, I think I'm really keen to learn from your wisdom. What do you think are the key actions that are needed for overcoming the long-standing imbalances between the Global South and Global North? Those imbalances are embedded in the structures, in partnerships, in decision-makings. What do you think the Global South or the Global North or the bodies that are interested in making sure that the partnership between the Global South and Global North is encouraged? What actions should those agencies take? Thank you.
Thank you, Ankur. So a great question, but just trying to pull up from what Pooja had actually said. There's some important points, like in terms of like how the world is changing, how the global order is changing, and how the whole economic paradigm is working right now, and how it is likely to change. I have a few points in terms of like what needs to be done, or how we should really look at it, look at things, because we have to fundamentally understand that solutions that are going to emerge in the future will have to emerge from the Global South. It is going to be countries which are, say, within the low resource settings, which will create some unique set of solutions over a period of time. So it becomes fairly imperative that we should not look at low resource setting in countries as what we call not laggards. We should really look at them as solution providers for the future. India has actually led away in many, many interesting ways. There are countries in Africa who've done a wonderful job. But having said that, I think there would be a couple of things that need to be done. Like one is that investing in regional and national institutions. How do we really create that institutional structure where innovation is the key driver? How do we really create the capacity within the health bodies that exist? And when you talk about, say, can we do something with, say, Africa CDC or health units across the world? How do we empower the national public health institutions? Right now, I think there is a lot of political interference that does happen, but we need to find a way that they're empowered, they're able to take the decisions in the right earnest. We have to really, second point, or the second big point would be that we need to invest in issues of productivity. And when I'm saying productivity and health diplomacy, like productivity becomes a very critical aspect. So we need to professionalize the ministries. Right now, you know what happens, or professionalize the think tanks which actually operate, how they are able to operate and work together. Quite interestingly, ministries across the world, of course, they have the heart at the right place, but they need to find a more professional mechanism for really bringing the knowledge and understanding from a data-driven approach. And you know, like this is where I would also make a very interesting point, that we need to give brutal, honest truths as to what are the challenges we face within the Global South. We need to actually move away from, say, populist narratives and really say that this is something which is important to be done, and just try to understand what are the disparities that exist across the board. I think Pooja did make a very important remark that there are those regional disparities, and when you talk about regional disparities, they are unique, they are what do you call substantial of them. How do we get those things right? The next point would be, say, how do we restructure the funding models? Right now, there is something wrong with the funding models as we are really looking at it, because we have to move away from a siloed approach or a traditional approach of funding. We need to look at, say, long-term financing that supports health system strengthening. We need to create that unique structure wherein the Global South financing mechanisms or a pooled system actually can get created. And then, of course, encouraging equitable partnership is going to be very, very important as we look at. Because when you talk about partnership, that has to be based on respect, knowledge sharing, and so on and so forth. And then, of course, the last point, which we cannot miss, and that is going to be that the challenges for the future, that require a very unique, associations that need to get created. One is that when you talk about climate change, and then the climate health synergies that have to be built. You know, like in one of the talks when we were doing this paper, I did say that I'm absolutely happy that the human race is going to get extinct in no time because nature will prevail and find a new species coming in. But having said that, if you want to survive, and then we need to understand the climate health synergies for the future. And that's going to be the most critical point as we move along into the future, because we have to rethink the health approach. We have to really see that how the future is going to get challenged because of all these climate changes and the challenges that are going to occur. I think I am more from a doomsday perspective, that there are going to be challenges because of the melting of the Arctic or whatever. There are going to be new things that will emerge. COVID has been a very interesting political situation. So we need to find that we look at not making false choices. We need to make some pragmatic, science-based, evidence-based choices as we move along. So some of those very quick points, but over to you, Ankur.
Well, thank you, Amit. I think important to have that transparency and honesty, as you mentioned. I think without that, how would you really address the challenges? So I think that is a lesson for the Global South as well. So the debate is not just about how can Global South be empowered, but also what is it that Global South needs to do to really get empowered. So thanks, Amit. I think with that framing, I'd really like to come to you, Pooja. You mentioned in your talk that the leadership of the Global South and Global North really just being a supporting role partner there. We saw recently there were huge funding cuts from the US government only for now. And we all are aware what kind of shock that brought to the whole world, especially in the development sector and more so in the health. Is the decrease in funding and the structural change, do you think it's an opportunity? Is that really a good thing for the Global South to really stand up and say that, okay, we're going to take the charge? And how do you think the politicization of the global health agenda play into all of this? If you have any comments to share on that.
Thanks, Ankur. I think it's going to be hard to say it's a good thing. Having said that, is it an opportunity? Yes, there's a perspective that one actually can bring to the table around this really being an opportunity. There's actually no doubt, right? I mean, so many years of development funding has really led to a lot of improvement in health indicators globally, right? And diseases, maternal health, child health, mortality numbers, all of those, the minute you look at the indicators across the board, we've seen a huge, huge improvement. Gavi, the Global Fund, I mean, the amount of effort that's gone in through these organizations to globally really help health agendas across the world. And at the foundation, of course, we've been privileged to support a lot of this work as well. But the decline in funding really also means in the moment, you know, it's a transition phase, one could argue, but in the moment, it actually means access to life-saving medication and drugs really stopping for a lot of people, right? I mean, with PEPFAR, for example, I mean, you know that about 20 million HIV positive people are now wondering whether or not they'll get their antiretrovirals. Or I'm told that there are about 42,000 premature deaths that have already happened for HIV positive people. So those are very real challenges when it comes to change in the funding ecosystem that's suddenly come upon us. Gates Foundation has given about $16 billion over the last so many years to both Gavi and the Global Fund and the Global Polio Eradication Initiative. But the US government has given about $70 billion. So now how do you make up for that gap? That's a massive, massive gap. And you can't say that, oh, it's an opportunity, right? Because in the moment, then what's going to happen or where is that funding coming from? This is, however, a moment for you to sort of look back and say, okay, now this is happening, so what do you do? And therefore, then you say, okay, this is then an opportunity to start to look at countries across the board to say we are not going to be only dependent on one donor country, but what is it that we can do to build our agency together? How can we collaborate across the board, across these issues in a manner that we're able to collectively solve for this? It's not going to be one country or one institution or one organization that makes good these gaps, but essentially countries coming together and sharing solutions and collaborating to fund those resource gaps. So innovative solutions, for example, becomes one way to look at it, to say, DPI that's come from India, for example, or India and Indonesia vaccine manufacturers, or examples from Rwanda, where they've looked at community health as a big piece of work with regards to using those mechanisms and actually sharing those learnings across the board. Because then suddenly, because of resource crunch, you start to look at becoming more creative to say, how do I make up for this gap? And it doesn't necessarily mean that if you're losing that $70 billion, you need exactly 70 to make up for it. You might actually probably need 45 or 50 because you've started to look at more creative solutions, more innovative approaches, and across the board, countries coming together to solve for them together. Even in terms of, if you look at the economic progress as well, right? We know that out of the big 4 economies over the next few years, in fact, even in the next 5 to 6 years, out of the big 4, 3 are going to be from Asia. We have China, India, the US, and Indonesia, who are projected to be the biggest 4, right? And therefore, the order of the world in many ways is changing, right? And therefore, to some extent, one could say that because we are looking at a shifting order of the world globally, even from an economic perspective, growth perspective, there definitely means that there is opportunity for countries to come together to say, hey, we need to solve for this, but maybe the answer is not exactly what we had thought of in terms of the numbers, but more creative, innovative solution and more sharing across the board more than anything else. So, yeah.
Thank you, Pooja. I think you're very right in saying that the magnitude of the funding cut that we've just seen is just not easy to fill. I was talking to some colleagues in Africa and who said our governments are just about realizing what sort of dependence we had on the funds that we received, and they're just trying to find out where exactly the gaps are now and how they could be filled. And like you said, it can only be filled collectively because no country would really be able to serve that. So just building on that, if I may move to Monica, to you, because you are really in the organization and in charge of health of the India government's agenda to improve the Global South voice, to encourage the South-South collaboration, to really leverage the strengths that Amit mentioned in his comments that the Global South has. What is it that Global South, moving away from being a recipient of global solutions to being a driver of global strategy and innovation, could do?
So, Ankur, this is a very, very important question. And to answer it, we are seeing that slowly and steadily, Global South is reshaping its identity from being a passive recipient of global health solutions to an active architect of global strategy and innovation. And there are few dynamics which are shifting. Very recently, we have seen a lot of groundbreaking innovations happening. These innovations coming from, they are tailored from the local realities. And we can say whether these are digital solutions from India or community-led insurance programs in Rwanda, or telehealth or telemedicine in Kenya. Everything is coming from the Global South, And these innovations are not only scalable regionally, but they can be increasingly seen as global solutions. And that is a very important aspect. Also, the countries from the Global South, they have started investing in their own data ecosystem, ABDM happening here in India. We are working on our own research institutions, implementation science, and moving beyond piloting imported ideas to generating contextual evidences So these ideas not only help in the national policy, but also play a very important part in global agenda as well. So that is important. And then the leadership. We can talk about G20, India's leadership in G20, or Brazil's leadership in G20. So very certainly, we are seeing global South countries in more powerful leadership roles now. We had this GDHI in collaboration with WHO during the G20. So we are on the right path. So there are several examples from India and from the global South countries as well. We can talk about our indigenous vaccinations during the COVID times, Vaccine Maitri as a leadership role which India took during the COVID times. Then our own indigenous solutions like platforms like CoWIN, DPGs, which we are actually giving it to the global countries free of cost. So very certainly we are there. We are changing that narrative of being, at the recipient side to being very vocal about what we need, what we want to negotiate at the policy advocacy level, everything. We are there, right there. And probably this is the movement in the right direction. Thank you.
Thank you, Monica. I think it's pretty clear. I think you spoke a lot from the Indian context and all the digital innovation from India that is making its way to the world. In fact, DPI is something that a lot of global South countries are coming to India to learn from. Sticking to the global South, thanks, Monica, for just setting the ground there. If I may come to you, Zelalem, on learning from your experience, your broader experience of working in many of the global South countries, what do you think global South countries are doing today for pushing the participation of their governments, of their stakeholders, key agencies in the health deliberations? What sort of steps do you think they are taking to get their issues included, to get their issues addressed in the global policy making? If you could share some thoughts on that.
Thank you. And in fact, I defer to the very able description of the kind of changes that are happening over the decades that Monica has just mentioned as some of the examples that are already shining the pathway towards a lot more democratic engagement on a global scale and influencing decisions. But I think one of the key things to remember is also that as we talk about being represented or being set in the agenda, it always boils down to people. And it always boils down to the health of the populations that we talk about. Today, in a lot of ways, if we were to take a look at the data, and we mentioned earlier on, we're more than halfway through the 2030 agenda. We're very close to the goal line, and we find that actually we are not meeting majority of those goals, especially on health. And if we were to meet, for example, the SDG goals on child survival, by 2030 we would be saving 11 million lives. So we need to think of it from that perspective. And I think one of the things that is happening across the board is taking stock of that. And in a recent interagency report that took a look at the trends in maternal mortality, for example, we know that 95% of maternal mortalities are happening in the global South. Right? So one of the things that, and the reason I'm bringing up the data is that it is this kind of data that is also driving the awakening consciousness that exists in the global South to say, this is my data, this is what affects my population, this is my responsibility. And you can see that across board for most countries. And I want to do a little bit of a digression, not talk about only health, because I think you cannot talk about global health and global health agenda and setting health agenda for the global South without talking about, for example, advances in research and development, publications. Over the last few decades, we've seen significant shifts to reliance on global north-driven research to global south-driven research. You gave an example, Monica, of India. The volume of research that is published in India alone is staggering. And if you were to go to the African continent, for example, it's similar. And there are many more publications that are global south focused that are bringing the spotlight. So data and bringing the data and bringing it home is one of the avenues through which they are speaking. But beyond that, also, you need to think about in terms of the economics of where we are. Health on its own is a non-starter. The health economics that is driven by geopolitical considerations pushes quite a bit. I work for UNICEF, so I will talk about vaccines as a starting point because they're such a crucial part of the work. Over the last decade, and especially post-Ebola and with the COVID pandemic, we've learned that there is a need to have better and homegrown capacities, not just to be able to plan for, purchase, distribute, and vaccinate, but also to develop those vaccines that meet the demands. And this is the same case for the pharmaceutical industry. Now, the conversation is not just stopping at whether or not I want to produce vaccines. The conversation goes to where do I source the raw materials? Where do they come from? Because without that, then the technology on its own is inadequate. So technology transfer, ownership of problems, and creating the platforms to have that conversation is very important. And over the past few years, I think we've just launched a really beautiful little document earlier on about, in relations to COP. The health as a topic was not even on the table for quite a long time. And recently got accepted on that and is being discussed actively. Climate change as a real significant contributor to the future of health, to the impact it already has on nascent health systems, is becoming a lot more magnified. And COP has been a platform where, for example, small island states from the Pacific and the Caribbean, sub-Saharan Africa, countries like India, who bear the brunt of the impact, have been able to put on the table. And within that conversation, there's also a recognition that the people who suffer the most are in the global south. But in the global south, you also have children who take the brunt of that. And you'll see that also within the global conversations related to child rights, where the climate crisis has now been included in the Convention on the Rights of the Child as a child rights crisis, focusing the lens on the most vulnerable within our society. So there is the growing trend, but I think more than that is also setting the agenda for the next few years to come, where countries are having this conversation across board. Beyond countries, states, we also need to recognize the importance of subnational systems, people-to-people exchanges. If you go across board today, there's a lot more learning that happens between states. If I use India as a country, as a subcontinent, in fact, to talk about the learnings that happen between different states, you find similar look where the Vietnams of the world are showing different types of innovations that they have. And countries are no longer going to the US or to Europe, to Finland, to go and learn new systems. They're doing it across board within the South-South cooperation, enhancing cross-learning, optimizing the opportunities for localizing solutions that reflect cultural and societal structures. So I think there's quite a bit that happens on the side, bringing countries together, but there are also the traditional platforms that have existed for a long time that are becoming a lot more visible in being able to facilitate that. I work for the United Nations, for UNICEF. Part of the role that we play is to create that cross-learning between cultures, between systems, between countries, and to be able to take the learnings from one to the other and enhance accelerated development for us, specifically for children, maternal health, and ensuring that we stay ahead of the curve to try and get the governments who have signed on to the Sustainable Development Goals meet the goals that they've set for themselves. And on that platform, you will see significant changes and engagement from the Global South. In UNICEF, for example, the UNICEF's agenda on an annual basis is set every year for every country for a 5-year program. And that is normally adopted by an executive board. And that executive board is made up of about 36 countries, 20 of which are always, in fact, from the Global South. And this election happens on a 3-year basis that is guided by ECOSOC and the General Assembly to give the kind of voice and platform. And you can see that platform reflecting in countries being able to stand there and say, this is what I need, this is the kind of support I want, I do not want this. And that's a very important principle to think about as we follow through. Finance is maybe one of the last things I want to mention. Traditionally, there's been a lot of dependence on donor-driven programming, which over a period has actually started to peter out. There's significant support that's come from many countries across the globe, and in fact, for UN agencies, there has been a really good basis on which aid, support, system strengthening has happened. But there's also been increasing investment by countries themselves in their own systems. It's the rate of investment and the rate of growth has not increased as fast as we would like to see, but the trajectory is that they will be spending a lot more. And there is recognition that investing in today's, for their own health systems, investing in children today is the way to get you to a brighter tomorrow. And I think that recognition already sets the pathway to that.
Thank you, Zelalem. I think that's very enriching. I think you said we have to zoom out a little bit and not just look at health in a siloed manner, but also sort of read it with all the other dimensions of economics, financing, people-to-people connect, cultural similarities or distinctions that have to be adjusted in the process. That's very, very useful. If I may come to you now, Shishendu, I think you've had experience of working in both the government, and even in the government you had quite a unique position there, which was sort of a mix of grand challenges with Gates Foundation. Previously you've been with Wellcome, so you've been on that side. You've worked on the government side. Now you're on the Wadhwani Foundation funding innovations. I just like to get your perspective if you think Global South can get to a position where it can not just start participating in the global dialogue, but can it really get to a position where it can start defining global priorities and start offering solutions to tangibly influence the decision making? Because once you define those priorities, it really sets the tone whether you'd be able to influence the decision making or not in a real tangible manner.
Thank you, Ankur, and thank you, Ankur and Neeraj, for the invite today. I think what Pooja started with her opening statement, and then Professor Kapoor gave an elaborate statement. You are, in a commanding position to define priorities, and people should look at the priorities. The countries should follow priorities. Is firstly, you should. And I will be speaking from my experience in funding innovations, where I've seen, and my experience when I was heading the Mission COVID Suraksha for the vaccine development program as well. And that time I had a very close working with the lot of Global South countries. And so I think first thing is, you have to have that right capacity within the ecosystem to, design, define, and think the priorities. So I think for that, capacity building is one of the key elements within the ecosystem, within various countries in the Global South. Things have changed, and it will change. And as was mentioned earlier as well, things are improving, and as we move along, things will change. But I think the capacity building is the first important thing within the ecosystem, to talk, to speak the same language as the developed countries speak, and then come out with your priorities. You have to have your priorities, your gap analysis, what you need, what is your unmet need, and then, so firstly is capacity building, and thereby, capacity building will come from creating institutions, as was mentioned by Professor Kapoor as well, in creating institutions which will, lead to such type of HR or human resource in scientific field, in public health field, and various other fields, which will be important to talk about defining priorities and command respect when the priorities are defined. Firstly, then the institutions are built. Once the institutions are built and you have priorities, and within the foundation, when I was in my earlier role at Grand Challenges, we did a major work, connecting Global South. We had fellowships for Africa called Callister Zuma fellowships, where across the Africa we funded fellows. In India, we had Rajbhan fellowships, in the honor of former Secretary DBT Rajbhan. And then what we tried to do, and this was a building capacity, we exchanged the ideas across the boards and things like that to cross-fertilize ideas and see how we can build the capacities. Once the capacity is built, and then you can define innovation, you can design your own. The question is, once the innovation which comes out for India may or may not work in that ecosystem there. So once you have that capacity, you will design and you will have your own innovation ecosystem. You can design your own, you do your own, research, bring out your own innovation, and implement and validate that innovation in that ecosystem. So that is the second most important thing which needs to be done. And once you move the innovation, you need to have infrastructural support to support that innovation, which will be again an important priority, like IP issues, regulatory issues, clinical trial development sites, plans and things like that. Well, a product which is tried in India may or may not work in that cohort or that ecosystem there. That sort of infrastructure and capacities, if it is built through capacities, institutions, and then you can set your own priorities and build infrastructure to support those priorities in terms of IP, regulatory, and other things. Then comes, in the funding support, working in a funding agency, for almost more than 2.5 decades now, is, I think, a good team, good innovation ecosystem, doesn't, starve for funding, I should say. If there is a good innovation ecosystem, a good story you can tell to a funder that this is the gap, this is the science behind what I am addressing the gap, funding is available. And that's how you can take, and then you can, within that ecosystem, you can make your own, programs and get it funded and validate it, and then you can, as we call it, made in India. You then, that sort of approach, a national ethos can come out into that ecosystem, which will help to develop the Global South countries more strongly and more steadily as we move ahead. Finally, I would also like to say that, creating those things, and, it is not only that ecosystem, but there has to be a strong relationship and cross-exchange of ideas within the Global South countries. That is one of the critical elements. So that's, for example, we are working with Indonesia, we are working with a lot of African countries within my programs as well, to see how we can, help them not only, to put our innovations there, but they should be forced to bring out their innovations, help them the infrastructural support to create those innovations, validate that. Finally, it comes to manufacture that innovation, or that, to be mass manufactured. So that there we need, public-private partnership type of mechanism to see how we can do that. It's not always that it is manufactured in the X country and goes to a Y country, and then it is. We need to also build up that ecosystem there so that it can be locally manufactured and is made available. Vaccine Maitri was described by a lot of my panelists, and I was also a part of that when we supplied to 80 plus or 90 plus countries vaccine. But now I was in Abu Dhabi 2 weeks back, so we were discussing how we can create these vaccine hubs around the globe, so that local production capabilities are enhanced. And for that, the big discussion was how we can collect the Global South ecosystem together. When, God forbid, no further pandemic should come, we should not face. But if it faces it, there were only 6 countries around the world, Ankur, who made their own vaccines, not a 7th country. And, so, and then a lot of the Global South countries and where, literally had to ask for vaccine from other sources. So, innovation was a key element that we developed our own 5-6 vaccines India developed. But we should also think that how the global community gets benefited, and for that, if we build capacities, if we build the innovation ecosystem with other institution building, I think it is a strong thing that we will take our innovation to the next level, and the Global South countries can design their own priorities and move it more ahead from there. Thank you.
Very, very wisely said, Shishendu. I think capacity building is an area where a lot of investment is needed, and for highlighting the priorities and for really sort of talking, let's say, eye to eye and standing shoulder to shoulder and participating in the global health discussion. I think it's really important. We have those solid institutions that the Global South should invest in. Since you mentioned vaccines, I think just for the benefit of audience, I should tell that, during the COVID, for example, with only 5% of global funding going to the Global South, 65% of the global vaccine doses were actually produced by the Global South. So that's the kind of cost effectiveness that the Global South as a leader could bring to the global agenda. So I think there's really, from a finance perspective as well, Zelalem, you mentioned, and Amit, you as well, that it's important that Global South is strengthened. Sticking to the finance then, Amit, I think Shishendu mentioned there is funding available. But a lot of Global South institutions, stakeholders complain about lack of funding, and it also reflects in budgets, etc., comparative budgets compared to Global North. Could you also please highlight what alternative financing mechanisms could be leveraged to empower the Global South?
So great question, Ankur, and couple of points. And just picking up from what Zelalem had actually said, and of course Pooja and Mr. Mukherjee, fundamentally I think we need to understand that the solutions from the Global South or from whatever will have to come through enterprises. So they will have to rediscover their business models. Your point that when you said 65% of the vaccines were created in the Global South, that itself is a testament to the point that we need to change the business models that corporations are working on. All of us fundamentally always talk about what governments are doing or what aid agencies are doing or what great organizations like, say, Gates Foundation is doing or other agencies. But at the end of the day, you need to understand that we have to fundamentally alter the exploitative business model of the corporations. We don't want to talk about it, but that's the elephant in the room, and that needs to be solved for. And Global South is the fundamental place where this is going to happen. If you really talk about the Indian enterprises, they provide you what I call solutions, pharmaceutical, or drugs of whatever at a very interesting price, and that's what needs to be done. The second thing is that, we have to fundamentally look at health as an important social parameter. So, there was this whole point of GDP that Pooja was talking about, and she made a very important underlying statement, and that was that we have to move beyond the GDP. We have to talk about an aspect of what you would call as social progress. And when we talk about social progress, that would mean we have to understand outcomes. We have to create models or financial models which are on the basis of business or on the basis of outcomes, not on just input or output. It has to be an outcome. So can we actually create something like, say, health impact bonds? Can we do that? And where outcomes are the most critical factor that we have to look at and things. And so the corporations or the agencies or whatever will get paid for the outcomes that are actually there rather than anything else. And when you talk about, say, when Zelalem says that SDGs is something that is they need to be achieved, they're not getting achieved for the next, until about 2195. Because that's the figure. In fact, the first country, or the big country which we are talking about is going to be India, and they'll achieve SDGs by about 2060. So we are talking about the world will achieve all the SDGs by 2195 at the pace at which we are changing right now. So how do we create those solutions? And those solutions are going to come from the Global South itself. I think, having said that, I think there are a couple of other things that, one is this whole narrative, which is very disturbing. And we need to learn from India, and I'll pick up what Monica ji had actually said. This rise of me first nationalism, and I'm sorry, I'll name a country here called the Trump era country or whatever you might want to call it as. So the divisive state of America rather than the United States. They're actually creating that whole me first nationalism tirade, and they're effectively really trying to create a mess. And that is going to create an opportunity in terms of how we are able to work as a regional bloc, How do we really, we have to break that thinking somewhere in the world. The world has to be together. And the government of India, or India has always been talking about Vasudhaiva Kutumbakam, a world family or whatever. Vaccine Maitri was a very interesting reflection of that. We might have our own problems, but there are some great solutions that have happened from this part of the world anyways, from India. And you know, like my co-author, who also happens to be the G20 Sherpa, we did a book together. And I learned something very important from him, and that is that, you know, like, it is not about north-south standoff. It is going to be south-south handshake, which is going to which is waiting to happen. And this is what we need to really work on and really make sure that the countries in the global south come together, work together, and create solutions. And last point, I know I'm running out of time, or you're also running out of time, but there's one important thing that I would like to say is that if we want to talk about creating economic models, etc., we have to clearly position health as a competitiveness issue, as a productivity issue. We cannot look at health in isolation, because health is effectively about economic productivity. Good health is about economic productivity and nothing else. As long as I'm able to say that if I'm able to save 11 million lives, as this figure was mentioned on the panel, what is the economic impact of those 11 million lives if you're able to say? That's a stupendous impact that we are really talking about. Now the question is going to be, how do we value life? Those are economic constructs that we can talk about, but the important element is that it improves productivity over a period of time. So we need to move into that direction. So frame health not only as a human development issue, create it as an economic issue. And then as we all understand and agree, healthier workforce, healthier population, we'll be talking about, say, investing in health systems will create economic stability and popularity. And sometimes, you know, like we also do away with some technologies, and we get obsessed with the various set of what you call corporate lobbies, and we don't let those technologies to come in. There is this very interesting product, which is a smoking cessation device, which has not happened. We need to understand those technologies and see how they can actually be brought into the country, rather than actually just saying that they cannot be brought in. So there are those technological solutions which help. In fact, there has been, in fact, I can just publicly say, like, there are medications which can help health. I am a person who's just starting to take Ozempic. And then, of course, like, if there are those solutions to really improve your health, why not bring it to the mass per se? We need to do that. You can't really keep those exorbitantly priced. 41% of people in India, across Africa, much more than that, who are obese, then this medicine has to be actually brought in at a much reasonable price. So we need to create innovation manufacturing systems which are effectively going to create those solutions. So, and develop indigenous innovation and manufacturing capacities over a period of time. That's going to be one critical element. But at the end of the day, we need to understand that it is governments can do so much. It's the corporations which will have to improve their R&Ds. The problem or the biggest challenge in Global South is that most of the R&D expenditure is done by the governments, not by the corporations. Corporations are the biggest laggards in the system. They are actually, in fact, I can actually just say it very brutally, honestly, that if you talk about India, 70% of innovation funding happens from the government of India, not from the corporations. So corporations are a bloody mess. They are the most overrated bunch of citizens in the world. We need to change that. We need to tell them that you are a bunch of buffoons who are not bloody contributing to the development of the world.
Thanks, Amit. I know that you said all of this, you know, knowing that there are 2 cameras out there, and so I think that's real sort of Global South advocacy here. So thanks, Amit, for that. You mentioned South-South handshake would be the winner going ahead, not really sort of South going to North for help. I think South-South handshake is really important, and this is something that Africa seems to be doing better than most other continents across the world, and in particular on the Global South agenda. If I may come to you, Zelalem, on this, I mean, what is it that Africa has been able to do that Asia could learn from its model? I know that they've set up agencies like Africa Union, Africa CDC for health matters, etc. Why is Asia not able to come together? I don't think we've seen that kind of cohesion happening in Asia as it happens in Africa. And whenever we talk even to the Gates Foundation or to the UNITAIDs of the world or et cetera, everybody says that Africa is our top priority, and then we think of India, Indian subcontinent, and Asia. Why is Asia not able to come together?
Thank you. I am not entirely sure that is actually true in some ways, because I think there is a lot of collaboration that already happens in Asia. And there's quite a bit of hitting above the belt for smaller countries, but also the larger countries like India, who are actually on behalf of the Global South that are doing a lot more. So in terms of collective action for a whole of Asia, you're absolutely correct. But that goes into the shared history, the kind of health systems that existed in Africa that has grown not just as a health agenda, but as a political, economic agenda that has given a glue for those countries to be able to grow through that process. In Asia, you've got big giants, and you've got smaller countries that are in between, and the rate of growth, the infrastructure, the health systems, they are significantly different. So not all would be speaking to the same issues. And I think that's one of the areas where you have significant like-minded groups, like in ASEAN, for example, a group of 10 countries that are able to merge around these issues, albeit political as a starting point, but as you see, they have very clear agendas in terms of pushing the health of their populations forward. And the partnerships that can exist with India, with China, with a few others that are not within that grouping, has the potential to take that. On the global stage, in terms of Africa doing better, I think that's about the conversations that go with donors and donor systems, because you've got a much bigger block and you've organized yourself and you can talk about that. But you also have to recognize the rate of economic growth that happens in Asia that is not as attractive for external funding that comes through. But there is, I think, significant potential locally here. And part of the solution to getting that voice across is ensuring that health is not just, as you put it, it's not just an economic gain, that is not about, it is a right. And ingraining that and ensuring that there is collective understanding throughout our society is going to be important. Now, when I say this is a right, I want to draw the parallel. When we're talking about a north-south divide, inequitable health distribution, we need to make sure that we're not creating that inequity also within the South, within our own countries, because you do have inequalities and inequities and different access to health across, even in the countries. And some of it is extreme, far more extreme than you would have seen within the north-south divide, where it appears that the economic reach is expected to be the driver for health growth. And in our settings, I think we're learning that is not always the case, that where we're having the biggest strides in gaining economically, where our economies are doing far better, the GDP growth is phenomenal, but the health indicators are not moving as fast. And that kind of paradigm requires us to take a look at the masking effect of averages. So we look inwards and we take a look at and ensure that the rights of citizens are equally respected. So that corporations, whenever they do take up the mantle, and private sector, for example, does a lot of heavy lifting in the health system. There are more people that access private healthcare in some states than they do in public states. But the question is that care affordable? Is it adequate in terms of ensuring that it's not throwing families into poverty? Is it disadvantaging the most vulnerable in our societies? So creating a voice for populations, adolescents, youth, children, to be able to voice out their issues and their concerns and giving them the platform to ensure that they are heard well, and policymakers, decision makers, governments are able to respond to that. I think those would be the benchmarks across which a lot of union could happen within Asia. In Africa, as I said, politically there's been a big push. But you see also that historically Africa has had significant strength in having these regional, sub-regional groupings, SADC in Southern Africa, in West Africa, ECOWAS. Those have grown, and they're still politically strongly active. What has propelled Africa's union and stance in terms of health has also been issues like Ebola and COVID, where the realization, the birth of the Africa CDC that followed a phenomenal impact like what Ebola did, and the realization that we need to band together and work together for collective good. And that also translates into financing, by the way, because it allows for that finance to be shared across board. In Asia, I think you've got different levels of development. The financing and economic power of different countries has peaked at different times and still on a high trajectory. And because of that, demand for a collective funding may not have been as obvious. Of course, going forward with the new climate and the understanding that global funding is not as easily accessible and is not as it used to be, we need to be thinking about how we generate funding for healthcare within our local systems, within our regional systems, to support each other in order to make that happen. That entails creating the kind of capacity you need in terms of governance, planning, and engagement with young people who will lead this going forward. And I think that's a really important perspective.
Thank you, Zelalem. I think again highlighting that it's not just thinking by Asia is not coming together. There are many factors there at play, economics of it, and I think another factor to add there is the geopolitical situation. I think of Asia is very different from the African continent, how those countries interact with each other. So, well said. If I may come to you, Pooja, on this, I think. We're talking about encouraging South-South collaboration, etc. I think it'd be very useful for all of us and also for the participants to really hear from the foundation perspective. What is foundation trying to do in that space of encouraging global South engagement? Not just, actually, I would not just say South-South, but also enhancing that North-South axis as well, so that capacity building can happen to the level that Shishendu mentioned. Over to you.
I think the Gates Foundation's just sort of being an enabler more than anything else, because like everybody's rightly pointed out, there is a realization that, this needs to be collectively solved for, and you can't, one, depend on specific countries, and two, you can't assume that the global North will continue to solve for all the problems, and it's everybody's solutions, right? It's almost sort of like when we used to say during COVID that no one is safe till everyone is safe, right? And you have to ensure that, because everybody has a stake, therefore everybody needs to have a seat at the table, right? And to be able to enable that, then what do you do as an organization like ours who has some degree of a convening capability and some degree of connections and networks that we can harness? The idea really from our perspective is, how do you create frameworks for countries to actually connect, right? So while we've spoken about capacity building at the institution level, capacities for countries to be able to maybe do the technology transfer or have the HR that is ready to sort of work on the new innovation ideas, etc. But at a country level, how are you creating frameworks that can enable those interactions more than anything else? The G20 presidencies, for example, have been particularly significant in enabling some of those conversations. And one is you have those initial conversations maybe at a presidency roundtable, but then how are the follow-ups happening? How are you ensuring that there are delegations coming from one country to the other to really learn? What are the best examples and exemplars that a country has that can actually be shared with others? So we keep talking about DPI from India, but even vaccine manufacturing has been talked about. And what are the innovation and research frameworks that have worked for India that actually can be taken to other countries, and how? Because that how becomes super important, right? How are you creating opportunities for sharing of best practices? How are you bringing countries together, the right kind of delegations, people with the right kind of authority people with the right kind of mindset who are actually wanting to bring that change happen for their countries. And we've seen a lot of Africa-India sort of connections. We've seen a lot of, delegations coming, organizations also and institutions also enabling them. Indian institutions like the DBT and the ICMR, for example, in the health side, ministries actually creating those cooperative frameworks, global platforms enabling that as well. So, while, you talk about you just referred to ECOWAS, for example, for Africa, or the BRICS nations coming together, the BRICS Plus initiatives that are happening, multilateral banks, which are not just necessarily the IMF, but also when you look at what's being sort of brought out from the Global South and bringing that together, and how are each of these then creating platforms for those conversations to move forward? What are the best practices that can be shared as playbooks? What are the good examples that can be showcased? And how is that happening on an ongoing basis? So the Gates Foundation in many ways is helping create those frameworks and helping enable those frameworks and actively sort of nudging countries to make those conversations more real, more active, more here and now, so that you're able to actually enable the dialogue consistently to actually move those things forward. So in that sense, I think we have that sort of an enabling role where we're presenting our best knowledge and expertise, but bringing countries together to have those conversations actively.
I think very important that enabling environment and facilitating those convenings where everybody sits together and learns from each other. I think just again to highlight, one of the lessons we learned when in one of my previous roles is that when you bring Global South and Global North players together in one room, a lot of Global South players don't say a thing in the room. They feel underconfident, they do not feel empowered, they feel that they might make fool of themselves when the FDA is in the room, or when the MHRA, etc. are in the room if there is a regulatory discussion. So it sort of discourages them to bring their point to the table. So that's also another thing I noticed in a couple of my previous lives before joining PATH. And I think you mentioned the how of it is really also important. And with the how, if I may shift to Shishendu, then I think you worked previously at BIRAC, which was a key government agency which was promoting and ensuring that the how gets shared as well, because patents are probably if following Amit's leadership on being brutally transparent are the biggest fraud, because you can't read a patent and replicate it. There's a lot of know-how built into it, which is never written in a patent document. Shishendu, if you have facilitated those kinds of transfers, what is it that you have ensured to enable the complete how is shared?
Okay, quickly, the time is short, and when a technology is transferred, especially between organizations or between countries, the criticality is the demonstration of technology at the transferred level. That is the very critical aspect of technology transfer. Whatever is written in patent, we generally don't look at it. What we say is there is in a product we call target product profile. In technology is called technology final production profile. That has to be enabled to see that the complete technology transfer, what has been done, is enabled and it has been completed. Saying so, what generally is done is we build in mechanisms to see that the proper milestone is achieved when the technology is done. There is a we will we mature that and see. Now, coming back, I'll take 30 seconds more. So that is the way. What we are trying to do, as your question, and how we are creating these capacities. Within my present role, I am planning to create innovation hubs. Not only in India, my organization plans to do it in other countries as well, and basically in the Global South region, where these ecosystems are created within these host institutions, where not only the academics are brought into play, the industry connect is there, mentor is there, funding is there, to see the identified unmet need and to scale it up for that country's need. So that is how we plan to roll it out, and this is hand-holding from the academic level to the startup level, if you say, and to the industry level to see the complete connect. It is not only funding, but the science, the exit strategy of the technology has to be well built in, so that we are trying to do. And that's how we'll see that the complete knowledge know-how moves from the literally bench to the bedside. Thank you.
Thanks, Shishendu. That end-to-end knowledge sharing is absolutely key. So glad to hear that you're doing that. And then finally, Monica, before we open it for questions from the audience, if you can tell us a little bit more about what is Dakshin doing. I think you are the flagship agency of the Ministry of External Affairs and Government of India, trying to encourage Global South strengthening. If you can just guide us what Dakshin does so that people can reach out to you for help as well.
So we were just talking about institutionalizing the learnings of Global South, and that is what Dakshin stands for. So at Dakshin, so where did Dakshin come from? Dakshin came from when we had this G20 presidency, and there was a realization during the WOGS summit that there is a similarity of needs between these Global South countries, and the solution needs to come from us. And that is when the highest leadership of our country spoke about Dakshin. Dakshin, as it's a Sanskrit word, says Dakshin. Dakshin means south, but it is also an acronym for Development and Knowledge Sharing Initiative. And we are reaching out to all the Global South countries, nearly 370 think tanks across 100 and something Global South countries. We are reaching out to them, collaborating with them, talking to them, speaking about what their needs are in the health sector, and not only in health sector, but also in agriculture, but also in digital innovations, in connectivity, in gender. So what are their needs? And when we understand what their needs are, we look for the proposals. And once these proposals come, so just to give an overview, we are working very closely with Ministry of External Affairs, and that is where our inputs come from. And once the proposal come in, we start working with them, and we are looking for funders, we are looking for public partners, private partners, and the idea is to become a disruptive force, a force which can speak at the global level. What you just mentioned, Ankur, we need not to be frightened at the global level that what do we stand for. And every Global South country is a brethren, and they speak amongst themselves about their needs and at the global level as well. That is what Dakshin stands for. Thank you.
Thank you, Monica. And I think with that, I'd like to invite the audience, if there are any questions. I think we can potentially take one, maybe two questions in the next couple of minutes. The first hand came up from here. Sad. We'll take all the questions and then we'll respond. And you can also catch up with panelists afterwards as well.
Hi everyone, thank you so much for this. My name is Saad Alam Khan. A bit of background, worked in the UN a bit and in the public health diaspora. It was very interesting to hear the esteemed panelist, and I would quote things like, how do we tell our need in the current geopolitical landscape? Is it about, do we need life-saving support? Because of life-saving support, we won't have X, Y, Z, right? And rather than saying that, if we say, having sustained and saved 11 million lives, by this time we will be having that much of economic benefit. So what I see here, and Monica and everyone, what you mentioned, that global, the fact that it's a word Global South, that means that Africa as well as Asia as are part of one large umbrella. Now that there is, when we are scared and it is about people, the question is, I was just wondering and looking at the whole agenda of the WHS regional meeting, and I was trying to find that when I work with organizations, do organizations in the Global South have the capacity to strategically communicate their work? Mr. Mukherjee was just mentioning about if you have a great program, if you have a great team, which a lot of grassroots organizations do, but do not know how to strategically communicate or communicate in front of that global north and let go of that fear. And if we are letting go of that fear, how do we not say, when there's a fund cut, how do we not say that this is a life-saving support which we really need, and without that, we don't know where we'll go? Versus, this is a life-saving support which will save and take our economy from the south to the north to an X percentage growth by this year, having saved 11 million lives, and therefore we need that. So my question to the panel here is, one, do you think there is scope for us to invest in that capacity building, Ankur, to enable ourselves to learn about strategic communication while we might be great at technical aspects, one, and B, how can the Global South talking with each other about talking about at the global platform as one Global South?
Thanks. Just one more question and then we'll try and answer.
Yeah, I represent Academia, I'm Sunil Srivastava. So there are a couple of points. The pandemic preparedness of the Global South is a little unique, what I feel. As we saw in Ebola crisis in Western Africa, the crisis suddenly erupted, and the wet markets and all the animal-to-human contact is much more predominant as compared to in the north. So I think our problems are more unique, and we have to look into the One Health aspect more profoundly and more rigorously in the Global South things. Our diseases are more endemic, like tuberculosis and things of those kinds. So that also, the biologicals and the thing that was ZMapp that was used in Ebola crisis, though it was discovered and the company was in the US. So if we can develop those kinds of technologies in the Global South, plant-based vaccines, which all these South countries are more dependent on plants, and such technologies are more cost-effective, they are easily scalable, and things of those kinds. So more attention should be paid on that. The other part that which was not discussed at all, the genetic diversity in the Global South is very different and very unique. So when we talk of the gene therapies, the cell-based therapies that are coming into the market, we don't have much information regarding the genotypes and things of those kinds. So we heavily depend on the Caucasian genetic information. So we should have our own atlases, whether it be for personalized medicine or whether it's for cancer genome atlases. And when the sequencing technologies is going considerably down by Oxford Nanopore and many platforms that are available. So I think Global South should pay much more attention on those things.
Thank you. I think Zelalem touched on how Global South is creating its own data and how that data should be used to come up with formulations for solutions that are local. Maybe Pooja, you can answer the strategic communication strengthening, and then you can answer the vaccine side of things.
Sure, thanks. Maybe we can take some bit of this offline as well, just considering the fact that we're over time. But I agree, the fact that a lot of communications capability needs to be built and addressed more strategically and more from the perspective of actually creating a long-term institutional strength and robustness in organizations around that. Unfortunately, typically we end up spending much more on the program and much less on the communications of the program. We assume that we'll do good work and the world will get to know about it. That's pretty much like our marketing fundamentals and principles as well. And we've seen, in fact, a lot of big brands come out of the Global North as against the Global South, predominantly because, we do the work, we don't believe in talking about it as much. And we are increasingly realizing that different stakeholders need to be given different messaging, and narrative building is super important. It is a skill. not everybody can do it just, you don't wake up on the side of the bed and start communicating. There is learning to happen. And it needs investment. It needs consistent investment, both at an institutional level. I mean, how many institutions do we have collectively in the country that are purely focused on strategic communications? There'll be a handful, right? So as a country, India, as Global South collectively, we need to actually start to understand the power of the narrative building, because that helps us communicate better, collectively sort of have the same voice that actually helps emphasize and brings consistency of messaging. It's not something that traditionally we've invested in a lot, but it absolutely requires a lot of that effort, and it requires it here and now. So completely with you there. There are lots of ideas and a lot of new work that's happening. We can really learn from a lot of political messaging as well in terms of communications. There is a lot that we can actually learn from. Science communication, Dr. Soumya Swaminathan yesterday spoke about the fact that every scientist needs to be a communicator. And that's a very, very fundamental principle. We don't teach communications to engineers. We don't teach communications as a core principle to doctors. And that's something that we need to actually revisit, both our education system, but also at the same time our capacity to understand the art and actually build our strength around that.
Thank you. On your question on vaccines, completely agree. Yes, we should have the capability to produce the vaccines that we need. But I'm going to take it one step further. It doesn't mean that every country should produce vaccines. And I think this is where, at the core of it, what we are talking about is equitable access to healthcare, and that needs to be across board. So, for example, if we are able to create the kind of incentives and environments for the production and manufacture, distribution of the vaccines that is affordable for countries, that they are able to meet the demands that they have, that is the attainable short-term goal that you work for. The second thing is that in terms of even developing that, you need to be able to work on the background, the raw materials, the technology transfer that is required, ensuring that you have the capacity not just to produce, but also the supply chain systems, which are really crucial. And those go hand in hand with economic development, with growth, with industry. And I just want to touch base on the last question that you put in terms of, and I think it was to do with the genetic diversity. Correct again, but I think that question really shines the light on the question of whether or not we are setting the agenda for health, or it is being set by somebody else. And that goes at the dichotomy of it. That kind of genetic therapy, the kind of push that comes, is addressing issues that are predominantly up north, that are not necessarily being prioritized in the south, because we're still dealing with significant percentages of people living with tuberculosis and dying from tuberculosis, with children who are unable to attain their 5th birthday because of infectious diseases, because of lack of access to water, sanitation, hygiene. And I think the divide that we talk about is trying to focus now that the Global South is looking at, we need to get this in order, because there we also have the double and triple burdens that are hitting us at the same time. The non-communicable disease that is adding on to the infectious diseases creates an extra burden that does not exist in the North, because they've sorted out the infection. So, and I think that question is a brilliant one, because it allows us to shine the light on how we prioritize and how we allow the Global South to take the lead on the issues that matter to it, not forgetting that there are technological advancements that could allow us to make that jump, and much faster, much quicker, because we live in a technological age. Thank you.
Thank you, Zilal. I mean, I think with that, I'd also like to thank all my panelists as well for their wonderful comments and contributions and enriching discussions. So thank you again to you all as well for patiently listening and participating. Thank you.
almost on time. We'll start in another couple of minutes. We are just waiting other people to settle down. Please bear with us for another 2 to 3 minutes. Thank you. इसमें झंडा डाल के ले आओ बस झंडा Very good evening, our esteemed guests, dignitaries, and colleagues. I'm Dr. Deepti Subhat Tiwari. I lead the Human Resource for Health vertical at HSTP. HSTP, Health System Transformation Platform, gives heartiest welcome to all of you for this World Health Summit 2025 regional meeting and to this important panel on building competency for the in-service primary healthcare workforce. We are formally registered as Forum for Health System Design and Transformation under Section 8 of Indian Companies Act, and we were established in 2018 and incubated by Tata Trust and Gates Foundation. As a non-profit organization, HSTP is dedicated to generating and applying evidence to inform and support health policy and system reforms in India. We work closely with several state governments, including Karnataka, Odisha, Madhya Pradesh, and Meghalaya, across areas such as urban health, health financing, NCD, health insurance, and yes, human resource for health. As India advances on the path towards universal health coverage, it is the capability of our frontline health workers, their knowledge, skills, and confidence that will determine the strength and sustainability of our progress. Today's session is about bridging that competency gaps and reimagining how we can support and train a health workforce. We will also witness the formal release of 3 landmark training manuals designed to transform primary healthcare training ecosystem. It is my honor to introduce the chair of today's session, a distinguished leader in public administration and health system strengthening. Madam Avasthi, who is an IS 2003 batch from Odisha cadre, a gold medalist in economics. She also holds a master's in public policy from University of Oxford. She has served in several pivotal roles across governance and social development, including as collector of multiple districts of Odisha and as a director of Mission Shakti and social welfare. Notably, she served as senior faculty at Labasna from 2015 to 2022, mentoring future civil servants. Prior to her current role, she served as Secretary School Education. Her current leadership of Health and Family Welfare Department is marked by her deep commitment to evidence-driven reforms and competency-based training of health personnel. It is my pleasure to invite Ashwati ma'am on the floor. Thank you, ma'am. Moving forward, I now invite a session moderator, Dr. Sudha Chandrasekhar, a public health leader from last 25 years and an advisor to HSTP, to open the discussion and introduce the key themes and speakers of this session. Over to you, Dr. Sudha.
Good evening, everyone. It's been a long day and almost the end of all the sessions. So thanks for joining us today. But we have a lot of interesting topics to be discussed. So I'd like to request my panelists. So Dr. Santosh Mathew, I would request you to join our panel. Dr. Santosh Matthews, sir, is a lead policy specialist from the Gates Foundation, and he has held several leadership positions before and retired as Additional Chief Secretary for the Government of Bihar, and also has been the chairperson for the National Council for Teacher Education. So thank you, sir, for joining us today. Now I'd like to request Dr. Sitaram Budaraju, sir. He is the medical head and advisor at the Tata Trust and has extensively worked in national health programs with a focus on the vector-borne disease control program. So thanks. Thank you, sir, for joining today. I'd like to request Dr. Santosh Patel, who's the additional director from the Ministry of Electronics and Information Technology and MITI. And he has been currently handling the capacity building scheme, which is very important for us in digital governance and empowering government officials through training programs, knowledge sharing programs, and also skill development workshops. So a very warm welcome to you, sir. We cordially invite Dr. Ibadat Dhillon from the World Health Organization, CRO. He works as a regional advisor for human resources for health from the Department of UHC Health Systems and Life Course. And his work has focused on human resources at national and global levels. So we look forward to a lot for learnings across the countries from you, sir. We'd like to invite Ms. Manjari, ma'am, from the Indian Pharmaceutical Association. She's currently the vice president. She was the vice president of the Indian Pharmaceutical Association for over 12 years, and also the International Pharmaceutical Federation. She has been a regular resource faculty for training practicing pharmacists. This is an important cadre which many a times gets missed out, but we have, and has developed a public-private partnership in engaging community pharmacists in government's national TB program. So a warm welcome to you, ma'am. So We also have Ms. Evelyn, ma'am, P. Kannan from the Training Nurses Association of India. She's a Secretary General and has worked as a community health nurse midwife responsible for strategic and operational planning of various projects at the national level. So the main reason is we have all the stakeholders who actually would help in advancing the cause of a much more competency-based human resource health development. So in that sense, the main purpose of today's discussion is also not just to say what are our challenges, what are the issues, but also look at how do we ensure scalable initiatives for both at the state level and at the national level, and ensure institutionalizing the process. It should not be a one-time initiative by kind of organizations where we work with, but how do we institutionalize it, scale it, and sustain it to make sure that our primary healthcare workforce, who are as important in our dream of achieving a lot of SDG goals that are met, and they are given the right support from the induction, during their career, and also continuously to support all our programs and initiatives. So in that sense, with that background, let us look at what are all the possible ways in which currently they work in, and what are the gaps, what are the challenges, and what are the solutions. So that is the intent of the discussion today. So I'll start with Dr. Sitaram, sir. Mainly in your long career, you have interacted with a huge number of healthcare professionals at different levels. So in that sense, what are the challenges that we face, the human resource face, and what are the key things which will lead them to be retained, and the kind of motivation that are needed to retain such kind of staff?
Thank you, ma'am. Traditionally, the healthcare workers' jobs were mainly from the government side, and the offer from the government itself is a big motivator, because there is a job security, and there are other social benefits like social security benefits like pension, gratuity, etc. So there's a big motivator for someone to join the public health services. So unfortunately, the trend is currently shifting from in different states to from providing regular employment to giving contract employment. So the major incentive of a job security and other social benefits are no more there for the people. So who need more motivation here in this particular sense because of this lack of guarantees. And in this particular scenario, based on our experience, added to that, the public health is no more exclusive domain of the government anymore. Although it is the key player, the private partners, NGOs are coming to fill in the gaps in the public healthcare delivery system. And to some extent, even private players like even corporate hospitals are getting into community outreach projects, although their intentions are a bit commercial oriented. So their goal was to get some feeders into their secondary and tertiary care. But in the process, they are, to some extent, they are also contributing to the primary health care. So in this overall scenario of three domains there, one is public health domain, other is the NGOs, and other is the private sector. The community health workers or primary health care workers, they need real motivation, because there is no guarantee that the contract continues for 3 years or 4 years, whether it is government or NGO or anywhere. So for them, the trainings and other traditional methods are different here. You need to emphasize that they are fit to join other domains as well if it's required. If I'm working in an NGO tomorrow, the NGO jobs are project oriented, and you know what is happening suddenly if the funding is stopped by any agency. Now the worker is out of job. So that mobility between three different domains, public health or NGO side or from the private sector, here you need real motivation to the worker to continue. The guarantees of a job security are no more there in any one of these sectors. So our training program should be in such a way that the worker is benefited even if he or she has to leave this particular domain and to join somewhere else. So our traditional trainings may continue there as well, and traditional incentives also may continue, but the focus should be to empower this person, to upskill this person to join any one of these three domains if the situation demands. I think that is the key motivator for the programs. And in addition, some informal training methods, and we have seen in our public health projects, particularly in Madhya Pradesh, where we did a 5 years project for on maternal and child health. The supervisory support we give to the mentors from outside, it adds a value. Suppose if my trainer or mentor is also my administrative supervisor, I lose that freedom to communicate about my deficiencies and I have problems. So sometimes I may not have the skills which are basic skills, but I miss it, but I don't dare to tell it to my supervisor. That's where a third party supervision, like we did it in Madhya Pradesh, whenever our coordinators used to go, the Anganwadi workers and other ASHA workers, they used to feel free that, ma'am, I don't know how to check BP, or I don't know how to do the glucometer readings. So these are basic things which we don't dare to tell to our administrative supervisors, but we have the freedom and comfort to share with the third party supervisor. And that used to give, that has really given, of course it is not measurable. The benefit outcome of this training is not measurable. It is informal or non-formal trainings. Such training should be encouraged to motivate the health workers in public health area. That is one thing. And as I was telling, it should be considered as a large public health primary care universe. If I train a person in government today, tomorrow he has to leave and join a private sector or a NGO side, he is still contributing to the primary health care of the country overall. So we should keep that in mind when we train it, and we try to provide them as much cross-functional training as possible. In one of our projects which we do across the country, Pan-India NCD program, what we did is sometimes wherever we need some trainers, we pulled people from MCH project and we made them trainers, and we moved them to other states to provide on-site training in the NCD app. So that helped these people. It is away from their routine work and they are learning something new, and again they come back and do their routine work. So giving such cross-functional trainings within the healthcare system is also a good motivator. That also provides them better employment opportunities if they have to leave the current positions. I think these are the key motivators based on our experience in the public health system. Thank you.
Yeah, thank you, sir, for kind of initiating the challenges. I would request Shruti ma'am to give her remarks, taking this background as the context and from the government perspective and from the institutionalization perspective.
Thank you, Dr. Sudha, and really grateful for inviting me, and I'm honored to be part of this very esteemed panel. So when we speak about the need for competency assessment and why do we need competency assessment and the subsequent initiatives, we are, I think, living in an extremely vulnerable and sometimes, transitional kind of stage, which perhaps has multiple, trends that we see around us. One is that we see proportional increase in the aging population. In Odisha, the state that I represent, by 2036, 18% of our population will be 60 plus. Secondly, we have the triple burden of diseases when, along with communicable and non-communicable diseases, we also have increasing proportion of road injuries, which again is something that we see in Odisha. Another major trend would be the threat of climate change. In fact, from today, that is 26th of April to 30th of April, we have a rare and interesting situation in Odisha, where perhaps 2/3 of our districts have prediction for extremely high heat wave, and the 1/3 of districts have a prediction for hailstorm. So 2/3 of our CDMOs are stocking and restocking the ORS packets, while the rest had to shift gear yesterday and make sure that their DG sets are kept in place and so on and so forth. So again, Odisha has been, seen multiple disasters in the past and perhaps in the future as well. So this is something that we see as a major trend that will shape our initiatives in the future. Next is, as you all know, the pandemic situation, re-emergence and emergence of pandemics across the world. And moreover, we have the opportunity that is given to us by digital technology, the AI, the machine learning, which can empower our service delivery systems. And finally, I think we are also going through a phase where societal structures are changing. The structure of family is changing. We have more urbanization. In fact, again, by 2036, the projection is that maybe large part of our population within Odisha would have urbanized by that time. So again, the subsequent impact on mental health and other related issues. So when we have such major trends, now the question is, how do we manage that from a public health point of view? Who has to manage it? Right from the frontline workers up to the policymaker, whose impact is likely to be higher? Whose competency should we assess, and how do we manage the competencies? Now, one interesting thing that I have noticed in the past 7 or 8 months that I have come into this sector is that Odisha has done quite well in multiple indicators. If you see in the last 1 decade, we have improved tremendously across maybe major indicators like IMR or MMR. However, few challenges still remain, but during the last few months, we had few very, very important and maybe a little disturbing challenges. One is that we had outbreaks of measles in some isolated pockets. We had multiple outbreaks of diarrhea in some of our towns, and so on. And we again, to our utter shock, we found that there was some immunization gap in some of our peripheral areas. Now, when we started digging deeper to understand why it was happening and where it was happening, one common thread that we noticed was that wherever this happened, in those pockets, either the multi-purpose health worker was absent, or the person was in multiple charges, or perhaps there was some lack of understanding that the person had. So that was a lesson in humility for me as well, so which meant that it didn't matter whether there was a secretary or not, but for the actual person on the ground, it mattered whether there was a competent multi-purpose health worker in the village or not. So when that is the impact that a field level worker has on a public health outcome, I think we don't have to deliberate on whether we need competency assessment or not. I think that is kind of well settled, and the question would be, how do we do that and how do we move forward? In fact, I always felt that in government, training is we tend to underestimate training. We've seen that in the academy that I had served, and incidentally, sir also was a faculty member at the Lal Bahadur Shastri Academy of Administration, where if you become a faculty member, the general assumption is that perhaps you are someone who were not able to do your work well in the field. So perhaps that is why you were sent to the academy on training. Perhaps, we tend to underestimate training. So the assumption is that since you are coming out of a rigorous examination, your understanding, knowledge, everything is settled and assessed at one point of time at your entry level, and after that you can forget about it. But we've seen over and over again that that's not the case. Everybody requires training, competency assessment, feedback, mentoring, and encouragement. Now, I think it is in that context that events like this is very, very important. I'm here to learn from the eminent panelists that we have with us today, and I look forward to very, very fruitful deliberations. Thank you so much.
Thank you, ma'am, for giving that kind of a state perspective of understanding why and how this is a critical aspect that we cannot ignore if we want to deliver primary health care. So coming from the state and Indian perspective, I would now move to Dr. Ibadat, mainly looking at what are the regional and the international perspective, because this is not something that's being deliberated, I'm sure, not a problem of India alone or a few countries, but I think there's a lot of deliberation happening of why competency development for health professionals is important, and what examples could you give us wherein, with regard to what can be done and what are the innovations that's available, if so, in that area?
Thank you very much. It's really a pleasure to be here. I think this is, my title is Regional Advisor, Primary Health Care and Human Resources for Health. So obviously, I think this is the most important subject in these 3 days. And I will come a little bit more to that. So thank you for everybody who has come here at 5:30, 5 o'clock. Second, I have been accused of being a quack by my colleagues. Priyanka is laughing, a quack doctor. I'm not a doctor. And recently, I've also started pretending to be an IAS officer. So I've been told that there are penalties for both of them. I didn't realize that for the latter also there's penalty. but I will come. But I think so. I'll just share a few insights in my own thinking around why PHC competency is so important. The 2006 World Health Report said that the biggest shortage in health workers, in doctor, nurse, midwife, was in the WHO Southeast Asia region. So of all the places in the world, the biggest shortages were in our region. Today, it is the opposite. Today, I think we have to be honest that we have, I think I was just looking at our data. India alone is producing annually about 120,000 MBBS graduates. All OECD countries combined, 38 of them are producing 160,000. So soon India will be producing as many as all the rich countries in the world. Okay, so that could be good or bad, but I just leave it to you. 500,000 pharmacy seats every year, 400,000 nursing seats every year. So the numbers are exploding. So it is really important for us to now think about what is the competency, what is the distribution, what is the performance. So that's the first thing. Second thing is when I came to, and why are they becoming health workers? And the second thing that really struck me when I came to India 4 years ago was this Niti Aayog report in 2021, which said that the health sector since 2008 was growing at a 16% compound annual growth rate, which means that every 4 years, the health sector since 2008 has been doubling. So when I came in 2021 to today is another health sector. And 4 years from now, whatever we have, there'll be another one. So that really begs the question that is this growth leading to what we envision in primary healthcare? Or are there different interests that are driving this growth? And I think we have to be honest and straightforward. And this is, I think, Dr. Sitaram, I think, Madam, you are making this point, that we also in our data are seeing even in public sector, 3/4 of doctors and nurses are in secondary and tertiary setting. So who really is at primary level? What are their competencies? How do we assess them? This could not be more important. So that's just a quick few points. And then I think this question of team, because we have an ability, especially in the health field, to segregate, to separate, and to not look for a common. But in reality, much of this is common. There's an individual, we heard multi-purpose workers. This is increasingly becoming important. Also to think about what is health. Right? So we are talking maybe different things when we're saying what is a health worker? What are the determinants of health? How can we engage with it? How can we engage with lifestyle? So these are important questions. In terms of competencies, what are some good practices? When I was in headquarters, we developed something I think Dr. Rajiv Sadhanandan knows, WHO Global Competency Framework for UHC. And as I was telling you, it's very easy to develop these standards and international documents at a global level far from reality. But then how do you adapt it to local context? How do you apply it? And Dr. Rajiv Sadhanandan and HSTP team, I really want to congratulate you because you have tried to adapt it and make it, Dr. Rajiv has been chasing this for a long time, that how do we adapt this to local context to actually have systems where we can define the competencies, assess them, and build the gaps. And the competencies there is not just the clinical competency, it's the people-centeredness. I think we have Professor Saroj from University of Colombo in the back, who's really emphasizing how important humanities are to building competencies. How in AIIMS Rishikesh, they're trying to train even the security guard to be kind to they are usually often the first people who end up seeing the patients. So really, how do we bring that part in as well? And so many different examples, I think a lot funded by Gates Foundation. This very important point of mentoring, how do we do mentoring well? CHO mentoring, how do we do it at scale? We have institutes in Bhutan and in Thailand that are training for rural areas. Chishti is back there in Indonesia. I think another really interesting thing in Indonesia, if you put Indonesia on a map, it goes from the UK to Kazakhstan, so north of India, right? So they are deploying teams to areas, not individually. So teams are going to rural areas together, from the doctor to the environmental sanitation worker. So these are this idea of team and team competency. These are also some good examples, but all to say very, very hard. I think our language often has been around CPD, collecting CPD points. Its impact on actual outcome or identifying gaps and bridging those gaps have been, I think, more and more recognized as quite limited. So I think these are the challenges, and maybe I'll stop there.
Now we'll come one more round, so we'll have more discussion on that. Picking up from where you left in terms of developing these competencies, I would like to go to Manjari ma'am, mainly in terms of how do we customize it at a more local level. You can come up with a national framework, you can come up with a global framework, as you said, but then how do we make sure that it is customized, and what are the process in our mainly because you were one of the stakeholders who helped us customize it for the pharmacist. And what was the thing that helped, and what was the process that was adapted, and how has the, at least as a pilot state, Odisha taken up to the next level of using that framework for actually delivering, taking that first step for the first batch of pharmacists for a competency-based training?
Thank you. Thank you, Dr. Sudha, and very glad to be here. Thank you, HSTP, for this kind invitation. And many, many thanks for involving or remembering the pharmacist. You know what? As there are neglected diseases, there are some neglected health providers, and the pharmacist is one of them. Pharmacists have been the missing link when we talk about the healthcare or the health systems. And believe me, United Nations says there are 4 pillars of the health systems: doctors, nurses, dentists, and a pharmacist. And pharmacists are the first point of contact for the people with symptoms. And so they are in a very strategic position to influence the patients and the consumer behavior. So having said this, when we talk about India, and when we talk about the pharmacist, the global picture and the Indian picture is totally different. Globally, the pharmacists are considered as healthcare professionals, and they are doing much more than dispensing of the medicine. They're going much beyond the dispensing. They're going up to vaccination. People walk in the community pharmacy and they get the vaccination. Now here in India, the picture is completely different, and the pharmacists in the community are considered more as a trader and not as a healthcare professional. So if we want to achieve the universal health coverage, and if we want to have the last mile delivery, and Dr. Ibadat, if we want to have the strong primary health care, then the pharmacists cannot be missed because they're right in the community. When we talk about the competency framework, I'm sorry to say, but we do not have a very comprehensive, robust competency framework or at a national level for the pharmacist. When we talk about the in-service education, the undergraduate education, there are program outcomes defined, and there are competencies defined for some pharmacy programs, like diploma in pharmacy. But there has not been a robust framework of the competencies and not competency assessment. So the initiative taken by HSTP in Odisha has been unique, has been first of its kind. So congratulations for the same. And I was very glad to be involved in this. So in Odisha, what was done was the competency framework was first decided for in-service pharmacists by involving all the stakeholders and by expert consultation. With those rounds of expert consultation, the 24 competencies were decided by engaging all types of pharmacists, pharmacy leaders, regulators, consumers, And then the 24 competencies were decided with 11 roles of the pharmacist. And then the competency assessment tools were also devised, again by the expert consultation. Then the training of the pharmacist was done, and then the competency assessment was carried out for those pharmacists. It was kind of a first of its kind of training even for those pharmacists, and they were pharmacy officers as they're called here there. So they were so excited and they were so happy because they had not undergone even that continuing professional development programs for even the CPD points. Because for the pharmacists, even though it has been made mandatory by the Pharmacy Council, it's not yet very formalized. So as a result, the gaps in their roles were identified and they were trained for it, and then the assessment was done. This was very successful, and also we came up with the competency-based training manual. I would like to say that this initiative can be actually upscaled, and that can be replicated in the other states and also at the national level. At FIP, I represent IPA as well as International Pharmaceutical Federation. We have a global pharmacy competency framework that can be looked at, and that we can devise the national, competency framework. We have WHO's AMR competency framework. So we can look at all those, and then we can come to the national consensus for the pharmacist competencies. And the Odisha model developed by HSTP can be replicated in the states, having the foundation of the national competency framework. There could be differences in the competencies for the hospital pharmacists, community pharmacists, as well as there could be some differences from state to state. But that's what can be adopted, and that will go a long way in improving, enhancing the role of pharmacists across the country, and they would be delivering the patient care services, and they will be following the good pharmacy practices, which are much needed for the public health improvement. So I stop here, and maybe we can continue later. Thank you.
Thank you, ma'am. I think, as you said, there's the first step or the first processes that we have initiated, but there are certain things that needs to get into the curriculum, get into the education system of the whole pharmacist itself. So I'd like to bring in Dr. Santosh, sir. Yeah.
I'm just making notes about
yeah. So mainly looking at what are the governance and the policy reforms to kind of scale up these kind of initiatives, because we don't want it to be something which is done as kind of a pilot or initiative, but what could be the way forward or how it could move to make sure that it is also not just the policy, but also into the curriculum and into the educational system also.
Yeah, but let me just start by thanking you for convening this panel and paying my deepest regards to my friend and colleague Rajiv Sadanandan, who is here, and to the leadership Ashwati in Odisha. I hope I don't get hammered outside, because I'm going to say things which you don't like. Yeah. So, Ibadat, when you said you were, the people think that you are a imposter, or what is the word you use? Quack. So I quickly looked you up on LinkedIn. Oh no. And I find that if you are a quack, I'm quack to the square, to the power 5. At least you've done an MPH, right? And he's also done law, by the way. Anyway, the point that I want to make is that I have no qualification to say what I'm saying, but I firmly believe that this emphasis on training and competency-based training has to go. We've trained for the longest time. My own Gates Foundation, where I work, we were doing a calculation. It's some $800 million is what we currently have in India-managed projects where the word training has been mentioned. I mean, what does training get you? Even end of course assessment, what does it get you? So I think the fundamental problem is to figure out the difference between a donkey and a horse. That's the fundamental problem. I have nothing against donkeys. They're very good for being hardy, low maintenance, great stamina. The problem is if you want a donkey and you put a horse, that's the problem. You want Ashwati and you put Santosh Mathew, there'll be a problem. That's the problem. So I'm reminded of the time when I used to work in an organization called the NCT, it's the National Council for Teacher Education. So we have an exam called the TET, the Teacher Eligibility Test. And we had authorized CBSE, the great CBSE, to actually run the test for us. So the chairman CBSE had come to me once and saying, sir, we run such a rigorous exam that not more than 6% of the people pass this exam. I said, wonderful. So can I see the instruments that you use? So he brought the instruments and I looked at it for some time, got some experts, and finally I concluded that even God cannot pass this exam. And we're all talking about training. See, the point is, do you know why CBSE exam even God could not pass? Multiple choice exams, multiple choice questionnaire in which more than one is actually correct. That's the problem. Now, there is something in social science, there's a terminology, it is called validity and reliability. So I'm so glad so many people nod, because in the world I inhabit, nobody nods when I say this. I had to spend 7 years trying to do a PhD to, to get to this word. And half the time I forget also. See, what is that word? So all of you are nodding. Fantastic. I'm in the right place. I may not get hammered when I go out. So the point that I want to make is that the real problem today is actually credible certification by the regulator. Now, there is significant political will around this. I had to quit the IAS because of the work I did in NCT. I actually ran away from it. They filed 500 cases against me in every high court on the land because I said I will grade the teacher education institutions as A, B, C, and D. And I said, I'll close you down, D. And A, I'll let you do whatever you want, charge any fees. So I was basically trying to solve a market problem, the information asymmetry. The juvenile decision that I took, that I will shut these colleges down, was the biggest mistake. Much more informed now, 8 years later, I am now arguing that you should just let the market clear the swamp. The point that I'm making is, if you want the competencies of our health workers to improve, then we have to work with the regulators to test what is really important. Now you take a nurse, for example. The work that we are doing with the government of Uttar Pradesh, hearing which the government of Bihar lined up, hearing which the government of Meghalaya has lined up. I'm not talking of government of Orissa as yet, because we have a long list of things we want to help Ashwati ji with, is just this, that can we get the regulator, in nursing for example, what the UP regulator and Bihar regulator are going to do is that 5 years after you pass your nursing exam and you become a qualified nurse, the regulator is going to put out an exam which has got skills and knowledge testing. They're going to set up these centers, which on a voluntary basis, remember I'm going voluntary because I had to quit the IAS because of my alpha male attitude. We're saying voluntary exam, but if you pass the skill and knowledge, you become a grade 3 nurse. 5 years after that, if you pass this exam, you become a grade 2 nurse. And 5 years later, you become a grade 1 nurse. I'm inspired by one book and one paper. The book is by Anirudh Krishna, a senior in the IAS, professor at Duke University. Anirudh Krishna wrote this book. I recommend this for so many of us if you are interested. The book is titled The Broken Ladder. His point is that across sectors in this country, the problem is of a broken ladder. We do not have a ladder that people can climb on the basis of their competency and on the basis of their hard work and good results. I saw that in teacher education. I'm seeing that in so many parts of the healthcare system. Now, what the regulator is trying to do, and we are helping them do, is to set up these exams. Again, there's a problem. if the testing for knowledge is on the basis of the TET, which God cannot pass, then that's not a valid and reliable result. So how do we get deep into the woods to test first of all, list competencies and to test them? You know what we found? There are no competencies defined for nursing educators. They don't even exist. Where was the question of even testing them? It is how so broken the field is. Second, how do you test for skills? So we are having mannequins in rooms that are completely closed off. All instructions are given through an audio system, no human being. The entire, whatever the student does is captured on video. This video is double blind marked. The questions that were posed to her, competency by competency, are stored by the regulator in a dossier for each nurse, for each exam. The video of the skill is also stored by the thing, and a QR code is given to the nurse to explore global markets, national markets, local markets. With her employer, new employers, we're giving her a ladder that she can climb. We have not even started the first assessment center. Government of Bihar recently held a meeting of prospective employers. They're already offering a 40% markup on wages. 40% markup of wages. So the point that I'm making is that it's possible to align this. And by the way, do you know how this whole thing started? Because Gates Foundation tried to improve the quality of nursing through a nurse mentoring program. And we found that 40 months after mentoring, still those mentored were doing better, but the problem was the slope of the curve, which means by the 55th month, they would have been worse off than the people we did not mentor. Why? Because there were 23 things that needed to get done for quality of nursing, which included what kind of people need to be selected to come for nursing. Empathy, checklist orientation, a deep sense of hygiene. These are not things that you can train through some 3-year, 4-year courses. You have to select the right kind of people to come into this. And that's why I have great objection to the titling of this, which says competency building for in-service. The problem is we have to think of much broader approach to competencies, think of the ladder that they have to climb. And here's the political will. Do you know why Chief Minister is interested? Because they are able to give jobs for women. There is a global shortage that's going to happen. The world is aging. They say skill capital of the world is a good, sort of term. But if we get a certification regime in place, if we can get the regulators for pharmacy, madam, that's why I was so excited. But then I was a little disappointed because you used the word end of course evaluation. Instead, if the regulator was actually creating a database and making that available, and if that kind of a certification which is graded could actually be worked, then I believe we are sitting at the possibility of significant transformation. Thank you.
Thank you, sir, for getting in the legal perspective and also looking at regulatory perspective for the different healthcare professionals, because that needs to be at some point, it has to come in, as you said, earlier the better, but again, when it would come, would definitely help in fast-tracking some of the, benefits that we can reap from all these efforts. So linking with what you said on how do we grade it, how do we do this, I would like to bring in to Santosh Patel on this, because again, capacity building training needs to be also to some extent digitally tracked. Otherwise, we are going to send the same kind of people for the same kind of trainings multiple times whenever it is held. And nobody knows who has actually got all these things done. And also the self-learning part, because again, everything cannot be done in person, but can we use the digital platforms that are available so that they have got the basic training as part of their education, but how do we upskill them? And for that kind of self-learning and the kind of modules that can be done, and what could, the way you think of in terms from the METI perspective, is a possibility to collaborate and look at this kind of interdepartmental coordination, because I know you're doing it for a lot of your digital activities, but how can you see this broadening for a collaborative effort with the health department?
Thank you, ma'am. As you may be aware that in July 2015, Government of India has launched the Digital India program with a vision to transform India into a digitally empowered society and knowledge economy by ensuring digital access, digital inclusion, and digital empowerment. So one of the key pillars of this scheme was the digital empowerment. So digital empowerment includes digital literacy for citizens as well as digital training and capacity building for the government officials. So Ministry of Electronics and IT is the nodal ministry for electronics and training for the IT skills and emerging technology. So we are implementing capacity building program to train central government officials and the state government officials who are dealing with the digital transformative projects and their operation and maintenance. In the year 2020, DOPT has launched the Mission Karmyogi program to train the civil servant of the central government as well as the state government. So Ministry of Electronics has assisted DOPT for creation of integrated government online training platform to assist training for the government official and to build their overall competencies. So Ministry is overall responsible for creation of the digital platform, creation of content, and updation of content. So in the same line, we can also help health sector to create a digital platform for the in-service health professional. So content creation, updation, and creation of digital module can be helped by the ministry, and also that can be integrated with the other level digital platform as well as the ABHA platform. In this way, we can manage the contents and monitor the progress of the learners as well as the educators.
And thank you, sir. And I would like to place on record that they've been, willing to support as a pilot for one of the modules to start with.
We can start as a pilot
Yes.
for 1 or 2 states and then further scale to the at the national level.
Yeah, and ma'am, we've negotiated to start with Odisha first. So we will try and ensure that we will try make sure that we will try the system out wherein we can track the people, get them what they are doing, and also look at, as sir said, a good input on how do we grade those people who have completed these trainings and look at what could be the kind of pathways for their career future. So that is something that we'll try to build up. I think Santosh sir also brought in a lot of issues from the nursing perspective, and we have the Trained Nursing Association of India. So we would like to hear your perspective on what is the current situation and how are these, what are the gaps or what are the solutions or what are the things that you're working on to enhance the competency of nurses in India.
Yeah, very good evening, respected esteemed chair, panelists, and the respected delegates. I bring greetings from the Trained Nurses Association of India. And it was established in 1908, only 118 years young association. And we brought the system of formal education in India as well as a regulatory body in 1947. And because since its beginning, one of the major objective or vision of the Trained Nurses Association of India is to uphold the dignity and honor of the nursing profession. And second one is upskilling the nurses. Because as we are talking about the competency, and TNA is very much involved in this upskilling the nurses is very much essential. As we all are talking about this, 70% population are living in the rural area, only 30s are urban area. As well as the primary healthcare is very much important. So upskilling the nurses is one of the major important. So we have our own, as I said before, we have a system, that means instrument establishing the system of formal education. After establishing the association in 1908, there were no formal education. So from the beginning, it's A&M Nurses Education for till 1930, that means almost 20 to 25 years we have taken to create the formal education. It's a A&M course for 2 years and GNM for 3 years, and BSc Nursing in 1946, and MSc Nursing, and reached of the postdoctorate and as well as the doctorate level in nursing. And TNA is not only is a stakeholder, we are the catalyst. We can bring the transformation changes in the nursing, those who are in the upskilling mainly. So for that reason only, we have created the Central Institute of Nursing and Research Center. In Greater Noida, we have our own skill lab where we can empower the nurses with the competency. As you all are aware that the nurses are there from the beginning till the end. So we need to take care of our nurses. So upskilling the nurses is very much important, as we are also constituted of more than 50% of the healthcare system. So we need to be empowered. So the TNA is very much actively involved in providing the competency-based nursing, that means educating the nurses, are very much, we are involved in from the beginning to the end.
Thank you, ma'am. And it's good to also to see how we can institutionalize these processes so that that can take things forward beyond the curriculum and other things, also in terms of the nursing education, but also within the system once they finish their nursing education, that continued
and sir very much rightly said that we need to give them the and check the attitude and aptitude of the nurse before even getting the nursing. But that's fine. That in our period and all, it was there. We have to check the attitude and aptitude before getting the nursing. But so only few numbers. Now there are 3,000 institutions are there, and they need to keep on. Instead of 15 students per batch, now they are almost 100 students. Now the government has already enforced they have to take more than even the 200 nurses in one batch. It's very difficult to check the competency. At least the TNA will take a lead in at least empowering them after completing the nursing, sir. And TNA also in the future, we are also thinking of we are doing a lot of research and publishing the books on community health nursing to empower them. And we are also having the learning management system where during the COVID, and it's very difficult to manage how to tackle the nurses. And digital health really helped us to create the teaching learning management system. We could be able to teach about how to manage the COVID for nearly 2.5 lakh nurses in India. And
thank you, ma'am. I think another point I will again take from Santosh sir is also on the career pathways.
Yes.
So I'd like to bring in Dr. Sitaram sir, mainly looking at how do we reimagine the public health career tracks to be aspirational, not just functional.
Yeah, as I was telling before, the career path is very good if you are within the public healthcare system, where at least there are time-bound promotions and they scale up over years, which is not there in other systems like NGOs or private sector. So the career path should be across these three domains. It need not be confined to one sector. And as you know, there are very much scope for people to get into the government systems these days. And most of the recruitments are on the contract basis, so there is no career path at all. So to have a good career path, we need to have a sort of loose, common system where the healthcare worker is given a, say grade 1, grade 2, grade 3, something like that. So if I'm grade 2 worker in government today and tomorrow I'm fired, I can try for grade 2 position at least in NGO sector or in a private sector. Of course, it's not implementable by legal ways or in a formal way, but there should be a sort of informal management methods here to ensure a career path to healthcare workers. Because once you are a trained healthcare worker, you are an asset for your lifetime and you are required for the society and to the public. So to make the best use of your skills and your capabilities across these three domains, the career path should be more or less identical with some sort of grading. I know it is not easy to implement it, but it's my opinion.
So moving ahead, back to you, Ibadat, mainly looking at what could be the kind of regional, and as you said, there might be learnings within the states, there might be learning within the countries. So what could be a platform wherein you feel that WHO can lead that kind of facilitate the learning and jointly also bring in accountability?
I have two jobs. One is primary healthcare, one is human resource for health. One is easier, simpler, less contentious, primary healthcare. One is more challenging, which is the Human Resource for Health one. For the first, we have a regional primary healthcare forum. It is directors of primary healthcare from across the region, plus we have partners, and we collect a lot of different examples. So I was going to show you this book. In the back, we have about 50 examples of different things people are trying to change the composition of the PHC team, the competence training of the PHC team. So many examples. I think Dr. Santosh already spoke to some of these, especially this focus on mentoring, so much focus on mentoring to build the competence. The other network we are thinking of establishing, or we are in the process of establishing, is a regional network of health professional regulators. This one, I did the first conference in 2019. I was in headquarters. We did the first conference in Istanbul on health professional regulation. So this was WHO doing it, and the first question to us was, this is not the job of ministries of health. Why is WHO doing this conference? So this is to say that every time I speak on health professional regulation, I always say that, fools rush in where angels dare to tread. And Dr. Matthew has already put his finger on a key challenge. So we're creating a network. So what happened? So across our region, we had the British model. The British model was changed over and over again. It was not functioning. The Australians reformed their regulatory acts. The UK brought in a professional oversight authority over the regulators. And yet we had these regulations that continued year after year. So we had, in India, the National Medical Council was suppressed. It was not just India. In Indonesia, just recently after COVID-19, the Ministry of Health has taken over and created the Health Professional Council within Ministry of Health, the regulatory function. In Nepal, they have the Nepal Medical Education Commission. So this is happening in Kenya, the same. So we have a real interest. And when I look at the old speeches of D.G. Mahler, he said that, and this is, again, I borrow somebody else's words, not my words, but his words were, to advance primary health care, you have to be willing to fight the interest of the professions and the interest of pharmaceutical associations, pharmaceuticals. And this is what they were saying to advance primary. But this is a dangerous battle. I don't think we say this today anymore. But this is, it is really upfront. And when we talk about regulation, and the regulation, I think it is really to this point. The situation may be worse than we imagine. I think one of the papers you may have mentioned is Jishnu Das's paper. Oh, yes. And I think that we have the courage sometimes to let him speak. He speaks, so tomorrow again we will have a session. Jishnu Das will just share some of his findings. And when he shares his findings, it's scary. A nurse he says a nurse in South India is not the same as a nurse in UP. Is not, and a doctor also, I know. But I also use that. But it's, I think these are real things we have to do, because we are stuck with a system where you go to university, you've got a license. In the US, for example, florists in certain states have to have a license. Just think about that. So in certain states in the United States, a florist will say, I need a license because it is a danger to the population. It's, so it is, so we have this reality of, so a lot of reforms. So we want to create a network of regulators. And we had Professor Harry Caton who spoke. I was with him in Bhutan. Bhutan is also reformed. They have their medical and health council together under the professional standards. And there he's talked about what is the, for so long in health professions, it was about autonomy. It was highlighting our difference from each other. It was mastery. So you come out as a health professional, you are the master. You have mastered your item, your learning. And then it was about altruism. So these were three principles. Whereas he's saying today, it really needs to be about the relationships we have with our communities, with each other, with other professionals. So I think from our network, we will try to share these findings. And as Gates Foundations works on these grading, I think it is a real innovation that it will, if it works, it will be feature for the world. Because,
Thanks. I think those kind of best examples will always help in looking up to, and as you said, again, going back to the regulation aspect, I'd like to ask Manjari ma'am in terms of, getting Pharmacy Council of India to do a lot of these kind of things and accept this competency and bring it into the processes so that, it becomes mandatory, because unless these things don't get into the system as a routine, then it always stands out as an outlier. Somebody doing something is looked in differently.
Yes. So thank you. I agree to whatever my fellow panelists have said. And I just wanted to also say, as Ibadat said, actually I wanted to say it before, I'm not doctor, but it's written here, doctor. So I'm a pharmacist. So I just want to bring in one point that we are all the health professions sitting here are working only for one client, and that is our patient. Yes. So when we are looking at the patient, and there are so many surveys and studies done in India, that access, we think of access to care and affordability. Access to care is not a problem in India, but access to quality care is a problem. That's what the studies have revealed, peer-reviewed studies. So when we are talking about the quality care, and then we are linking it to the competencies, it becomes very, very relevant. And if we can bring in now, Pharmacy Council of India is also talking about the outcome-based education. And I think that is very close to the competencies. I mean, it's all interlinked. So if we can do the advocacy with the government, there are WHO people here, also the policymakers here. So we have to do the strong advocacy to bring in the competencies and robust competency framework and continuous assessment of it. With the Pharmacy Council of India and with the government, that will definitely bring in, that kind of sensitivity among the pharmacists, and also we have to do the training of the teachers. So that is also very much needed. And then we can see the difference. And also I want to bring in one point, we are talking about the competencies, education, training, skill upliftment, that is fine. But we also need to work with the regulators and regulate, because whatever is existing laws in India, they are also not enforced very well. So some of the pharmacies across India, we don't even have pharmacists sitting in the shop. So if there is no registered pharmacist, and if there are quacks, then how can you improve the quality, how can you improve the care? So when we are talking about the competencies enhancement, we also have to look at what is the enforcement of the existing laws, and if there are health professional regulations coming, that will be even better. So I think through HSTP and through this panel and through the joint report that we can release after this, we can definitely go to the Pharmacy Council of India as well as to the Ministry of Health and do a lot of advocacy for improving the undergraduate pharmacy education, have it based on the competencies, and have the tools for the competency assessment for the practicing pharmacist, and give the appropriate training on a continuous basis, not just for the CPD points, not just for the certificate, but for the real outcomes which will benefit our patients. Because finally, we all have to keep only one thing in mind, that we are for the patients. And so they need to be benefited at the end of the day. Thank you.
Santosh, so getting back for a quick comment in terms of looking at what could be the kind of partnerships, because it is important that it's not just that a health department or a medical education department or one department would be responsible. So what could be the kind of multi-sectoral nature of these kind of initiatives to take it forward? Because
I think I've exhausted my time by speaking too much last time. The only point
quick comment.
No, the only point I want to make is that this is not just about the technical work we do. It's about, like, the Anil Swarup sir used to say when he was Secretary Education, it is the coming together of political salience, technical appropriateness, administrative feasibility, and financial viability. It is in this intersection that magic will happen. So when we talk about pharmacy and quacks being a pharmacist and greater regulation, we have to think of ways in which it is not policemen standing and catching people who are not qualified. We have to think if there are incentive compatible ways to solve for it. So for nursing, I said, no, why just nursing? Even for pharmacy, it's possible to harvest the global, national, regional, and local opportunities. And if you can actually get the certification regime that is credible, i.e. reliable and valid, are there ways in which we can use the positive inducements to be able to lift the quality? And the thing is what I would urge that we should think of. Thank you.
So any specific comments from Meti in terms of looking at, the institutionalizing this process at the ministerial level?
A national learning framework can be prepared, and it can be integrated with the learning platform. As in ABDM, government has already prepared the list of healthcare professionals, and more than 5 lakh health professionals have been registered. So we can integrate with the learning platform and track their performance, and accordingly we can create a national learning framework.
Can I just intervene?
Yes, sir.
I think we should just support CRO's effort to build a regulators network. And 1 or 2 states should agree to host the first sort of thing. And we can just start this off. I think that's the greatest outcome if we could.
Mike. Okay.
I'll repeat myself. I said we should just help CRO to build that network of regulators. And we should get a few states to actually, host let's kick this off. No, I just said a few states. Let's not put everything. She will not come for the next conference. No, but this is not just about Ashwati is Orissa, enlightened, she will do things. I mean, we actually should get state level. See, the regulation is actually at the state level. It's the state, it's the state, So the national should build the DPG and the state should leverage the DPG to implement it. That's when this will happen. Thank you.
Sure. No problem. Evelyn ma'am, as a last comment, any new initiatives that you plan to take things forward?
Yes, because at the national level we have 34 branches across India. So not only at the national level we can do, we wanted to do percolate to the entire states. We have 34 branches. So mainly we have the learning management system. Now also we are collaborated with the HTSP as well as the Orissa government and Satyabama University, and we are working on this how to empower our nurses, in India, competency based. So I hope, and we are also planning to establish a 5 simulation skill lab across India in 5 regions. And later part of India, second phase will be every branch also will be having the simulation lab. And from Odisha, we are getting a lot of participants to come and learn from us. And in Odisha, we have our own building. We are almost nearing completion. So shortly, we will be even with the help of definitely the Odisha government, we'll establish a simulation lab so we can be able to empower the nurses across Odisha as well as all other. And in UP, we almost cover many of the state. So empowering doctors as well as the nurses, we are giving through the National Skill Lab and reproductive maternal child health education. Now we graduating into we are also providing the basic life support as well as advanced life support. And we are also giving a research grant, and we are into publication so that whatever the possibility ways we want to empower the nurses, because the nurses are from the beginning till the end, we are them to take care. I humbly request the entire delegates as well as respected esteemed chair and panelists. So cost effective, empowering the nurse is very less cost. So when you give them empowering them, and the entire nation will be benefited. So this humble request is take care of the nurses will nurture the entire nation. Thank you.
Thank you, ma'am, for those words. I think we have had a good deliberation, and many key points has come in. I would request Ashwati ma'am to have the closing remarks and also the reflections from the panelists' inputs.
So thank you so much, Dr. Sudha. Some of my quick responses to a few questions here is that one, I think Dr. Sitaram spoke about the recruitment, how it is perhaps ad hoc and we go for a lot of contractual, but our experience has been that we've been having large-scale government recruitment. So now the challenge would be how to scale up your training capacity. How is it that we can train at multiple locations at the same time, and at the same time also ensure that quality is maintained. So that has been one of our challenges. Now, coming to the e-resources that we have, and our speaker also mentioned about the iGOT platform. So the uptake of the training resources that we have on iGOT has been not that great so far. However, of late, we've seen that there is an interest in accessing these resources. However, I think when we speak about the competency, one should also look at competency as part of a puzzle rather than just one piece. Because in Odisha, well, multiple villages, in fact, more than 1,000 villages still that are unconnected. And we have workers working in that area as well. So similarly, when we speak about, let's say, the community health worker, and I think for CHOs, we will be releasing a training manual which we've made with the help of HSTP today. And when we were discussing about, let's say, the CHOs and how do we enhance their competency, again, the fact is that it doesn't exist in a vacuum. There is a very complex political, socio-economic context in which this workforce also exists. For example, in Odisha, CHOs are drawn from the nursing cadre. So nursing officers get appointed as community health workers. But they don't want to go there. So CHOs are not very happy because they feel that, okay, in hospitals, there are many nurses and we are one of them. But here we are alone. We're just one person and, there's too much of attention on us. Too much of, so that is something that is kind of demotivating. So when we were discussing with the team who's put in so much of effort in making this manual, one thing that we were also suggesting is that when we are dealing with a group such as this, they are delivering, they're doing well, but they're not very happy. So when we are dealing with a group like that, it cannot be just about the competency part of it. It will have to be supplemented by maybe something to motivate them, something that will acknowledge them. How do we ensure that? If they can, we can have or design a system in which those who are doing well, there is something that is given to them, even within the cadre, whatever is available and what can be given. So this kind of nuancing is something that we will have to do while we deal with this issue of how do we motivate. In fact, when it comes to how do we motivate a cadre, sometimes it is the career pathway because many of our cadres, including the pharmacists and nursing cadres, has been recently restructured because they felt that that pathway is not very clear or it is not very fair when compared to other cadres. So this is one thing that, you incorporate better promotional avenues, and that is one way of motivating. But there were some other requests as well that, we don't want to be called as nurses. Please call us nursing officers. So, so now our entry level of nursing cadre is known as nursing officers. But it didn't end there. Now we don't have pharmacists, we have pharmacy officers. We have, in fact, soon we will, I think we will be renaming our ophthalmic assistants as ophthalmic officers. So name sometimes maybe, but once it is done, I don't think the charm remains, So what motivates is something that we are still trying to understand and improve and learn. At the same time, I think one thing that I'm taking back from the discussion that we've had is the fact that there are resources available, whether it is to train the tutors or whether it is for accessing resources with respect to strengthening of regulation. There are resources available. There are stakeholders who are committed to that particular cause. I think it is a matter of reaching out to the right person so that we will get that. And since Odisha was mentioned multiple times, I'll also speak a little bit about my state. It's a state where public health, fortunately, has been a center of, has received center of attention as far as government policies are concerned. In fact, more than 8% of the state budget is now given to the health department. One of our, apart from the PNJ that we have recently joined, the supplement budget towards that scheme from the state government itself is around 4,000 crore, only for that scheme. So that's the kind of commitment that the state has towards this sector. And therefore, that is where I think, ma'am, when you spoke about skill lab for nurses, please come to Odisha. I think that's the state that you have to be. If you haven't reached out already, please do come. And so thanks once again. I've learned a lot from all the panelists, and thank you for having me. Thank you so much.
Thank you, ma'am. And also to add in, specifically to work out that incentive structure for the CHOs, we have been working with the Directorate of Nursing, which has the main anchor for ensuring that the capacity building just doesn't happen just like a training or a process, but also how can we look at ensuring motivation, what kind of incentives, team incentives, getting non-financial incentives also could be looked in. So we are working that out, and we'll be getting back to you on how we will operationalize the plan and the manual which you have very graciously agreed and approved it. I think that is something we will take it forward and look at how do we roll it out in your state on a pilot basis, and then how it can be scaled up. So I request now over to Deepti to take the next level of proceedings.
Thank you so much, everyone. We now arrive at the moment of great significance of today's session, a milestone that represents months of collaboration, research, and dedication to strengthening India's primary healthcare delivery system. We are delighted to formally launch 3 key training manuals developed under the Competency-Based Training Initiative, which, yes, as mentioned, started under our respected former CEO, Rajiv Sadananda sir, which aim to enhance the capabilities of our community health officers and frontline teams. To begin, may I invite respected Dr. Rajiv Sadanandan sir and Dr. Sudha Chandrasekhar ma'am, advisor HSTP, to jointly hand over the CHO competency-based training participant manual to Dr. Santosh Matthews sir from Gates Foundation and Ashwati ma'am from for the formal release of the manual. Along with that, we have other manuals to be released. Next, I would like to invite Y. Swarnlata, Dean Satyabhama Institute, to hand over the CHO instructor guide to the National President of TNAI, Mrs. Annie, and Dr. Roy, former President TNAI. Finally, it is my honor to hand over the CHO Pocket Manual a ready reference tool designed for day-to-day use, to Dr. Sefali Malik, Additional Director, Directorate of Nursing. These manuals are more than documents. They are tools of transformation for our health system. We sincerely thank all the experts and partners who contributed to their development. Thank you so much, ma'am, for your visionary leadership and for so eloquently summarizing the spirit of today's session. I would like to thank all speaker, guests, and delegates. Thank you for your presence, your insights, and your commitments to advancing the health workforce agenda. Let us carry forward today's momentum with a purpose and partnership. The tools are ready, the vision is clear. Now it's the time for action. Thank you, everyone. Opportunity. बेटा एक फोटो ले लो मैडम की यहाँ Can you just take mine with this? Also, I would audience, please, I would take just few more minutes. Ashwati ma'am, I would like to request you to kindly hand over just a small token of appreciation to our distinguished speakers. Dr. Ibadat, you need to bear us a few more minutes, just a token of appreciation from our side, please. First, I would like to invite Dr. Ibadat. It seems sir has to catch up. Ashwati ma'am, please. Sir.
I have to go where? Come.
मॉड्यूल सबको साथ में देते जाओ. Next, I would like to invite Dr. Sita Raman, sir. Okay. Evelyn, ma'am, it's already, yeah. Manual. Dr. Santosh Patel. Yeah, so. Dr. Santosh Matthew, sir. Dr. Manjari, ma'am. Ma'am, and a token of appreciation for a moderator, please.
Little heavy, sir. Thank you so much.
It's a very interesting.
I hope you like that.
I don't think there'll be anything wrong.
Next, I would like to request our moderator, Dr. Sudha, to kindly gift of appreciation for respected Ashwati ma'am. Thank you so much, everyone. It was a really fruitful session. We had a lot of learning together. With this, we wind up today's session. Namaste and Jai Hind.
So which college are you in? So you have found it? Yeah, I'm in Dr. That's nice to know. Shall we take it on that background? Or, yeah, that's okay. Yeah, that's okay. But ma'am, yes. She's a foundie, so she wants a picture.
Oh, yeah, sure, ma'am.
Can I have the bag, please? Are you associated with IPS Students Forum? You should be part of the Students Forum so that you come to know many things. Indian Pharmaceutical Association Students Forum. So you are with NIMS. Yeah, so there must be some other students who are members of IPS. So join that. Okay, it's a very active group. Okay. Very vibrant team. Yeah.
Hello? Hello? Yeah, okay. I request.
Thanks. All the best. You be in touch with me.
I request all the HSTP members to kindly join for the group photograph with all the delegates and the speakers, chair. Thank you.